Hello students, good morning, welcome to the session. I'm Dr. Ravina Reddy, Medicine Faculty with Medico. Welcome to the final dash. Yes, NEET-PG is postponed just the before day, we are all disappointed. But there are two kinds of people waiting for NEET-PG. One who have prepared well, but the exam has been postponed, but now dissatisfied and difficult to come back. And the other one whose preparation was incomplete and they are happy that NEET-PG is postponed and they're feeling they got a other chance. Yes, it's disappointing, but we have to bring back everything together and read again. Yes, it's important to us. We have to be consistent, persistent. That is more important, right? So today we'll be doing previous year questions which are not covered in the previous session, and we'll be more focusing on the topics which you felt on the before day of exam that I should have read this in detail. So we'll be discussing such topics today in detail by doing MCQs. Okay. So let's start the questions without delay because it's already late. Let's take up the first question. We'll be going system wise. First, we'll be doing endocrinology. So the thing with endocrinology is you should understand the presentation, the hormone, what is its functions, and the deficiency or excess of that hormone, what are the presentations. You should know that presentations. How are you going to diagnose and treat? So for diagnosis, anything is excess, you will be doing suppression test. Anything is low, you will be doing stimulation test. And for treatment, if it's low, we'll be supplementing it. If it's high, we'll be suppressing it. It's very simple. Coming to the first question. Yeah, just a second. Coming to the first question. Impaired function of aquaporin results in. So what is this aquaporin? If you know that, you can answer this. The options are Liddle syndrome, nephrogenic diabetes insipidus, cystic fibrosis, and Bartter syndrome. What is Liddle syndrome? It is activation of ENaC channels, gain of function mutation. So patient will be having, what's the function of ENaC channel? It's sodium and water absorption, ultimately resulting in potassium and H plus secretion, right? So more sodium and water absorption, so patient will be having hypertension, hypokalemia, and alkalosis. Coming to nephrogenic diabetes insipidus, yes, it's nothing but the aquaporin channels are resistant to ADH or vasopressin. Aquaporin channels which are mediated by V2 receptor of vasopressin on which ADH is acting, and it's resistant to that. So resistance of aquaporin channels to ADH or impaired function of aquaporin channels on the collecting duct of the kidney is nothing but nephrogenic diabetes insipidus, and that is the answer. So we got the answer, but still we have to look at the other options. That is what you have to do in the exam. Coming to cystic fibrosis, it's a chloride channel defect. Coming to Bartter syndrome, it's a channelopathy with potassium, sodium, potassium 2 chloride channel defect, which is on the distal collecting tubule. Okay, so the answer is nephrogenic diabetes insipidus. So coming to diabetes insipidus, we are discussing about posterior pituitary. So pituitary gland is one of the important topics in endocrinology, in that anterior pituitary and posterior pituitary. From posterior pituitary, your vasopressin, both SIADH, which is excess of ADH, and diabetes insipidus, deficiency of ADH, are important. So in posterior pituitary, we will be looking into antidiuretic hormone. That is ADH. It's also called vasopressin. what all the things you should know about ADH. What are the functions of ADH? What are the receptors of ADH? What is the excess condition and its presentation, deficiency condition and its presentation? These things you should know about ADH. And the drugs causing diabetes insipidus and the drugs causing SAADH are very important. So we'll go through all those things, the important parts of ADH. So ADH is synthesized from posterior pituitary. Which cells? Magnocellular or parvocellular? It's magnocellular. Magnocellular neurons of your supraoptic and paraventricular nucleus. Of the posterior pituitary. They are present in posterior pituitary gland. From here comes our ADH. And this ADH is going to act on the receptors V1, V2 and V3. The vasopressin on collecting ducts which we were discussing is V2. It's present on the collecting ducts. It will act on the collecting ducts of nephron, ultimately resulting in water reabsorption. So your water reabsorption in the nephron is obligatory or mandatory? Mandatory or necessary water reabsorption is not under the ADH effect. It is ADH independent, whereas ADH dependent on the collecting duct is obligatory. So obligatory is it's based on your volume status of the body, or you can say it's based on the tonicity. If you're dehydrated, the tonicity of the blood increases, plasma increases, so ADH will be activated. So it depends on the tonicity and obligatory. So here you should know V2 receptor acting on the collecting ducts of the nephrons through aquaporin channels, resulting in water reabsorption, and it is obligatory, that is ADH dependent. So everything can be a question, potential question. And your V1 is present in the blood vessels, resulting in vasoconstriction. So whenever we want vasoconstriction effect, we'll be using vasopressin. This is the reason behind that. And V3 will be acting on the ACTH release from the anterior pituitary. And one more important thing, your V2 is also present in the endothelium of the blood vessels. What is the function? We will be giving desmopressin in von Willebrand disease. So the application for this is the V2 is present on the endothelium of the blood vessels, resulting in the release of von Willebrand factor. So whenever there is von Willebrand deficiency, the disease in which von Willebrand factor is absent, we will be giving desmopressin, which is an analog of vasopressin. So these are the functions. Actually this is physiology, but we are discussing the clinical aspects or clinical applications of this, which is very important and they can ask under medicine. And what are the down regulatory pathways which are activated after the activation of V1 and V3? It is IP3 and DAG pathway. Whereas your V2, it's cyclic AMP. So these pathways are also important. Okay, now we know the hormone, what are its functions through the receptors. Next thing is, what is the excess and what is the deficiency of the hormone? What is excess of ADH? It is SAADH, syndrome of inappropriate antidiuretic hormone production. Whereas deficiency is diabetes insipidus. Coming to diabetes insipidus, it can be central or nephrogenic. What do you mean by central? So central is deficiency of production of ADH hormone, whereas nephrogenic, the ADH production is good, but there is resistance at the receptor level. Here the production is decreased, central. Here the action is decreased, that is there is resistance. Central diabetes insipidus, nephrogenic diabetes insipidus. And one more important DD for central and nephrogenic comes is primary polydipsia or psychogenic polydipsia. You should know how to differentiate these three conditions. We'll discuss about SIDH later. Our question is concerning diabetes insipidus. So we'll learn how to differentiate these three things. See, here is a simple thing. How does it present? So we know diabetes insipidus is deficiency of ADH or resistance to the action of ADH. How does it present? There is antidiuretic hormone deficiency. So now there will be more of diuresis, right? So patient will have polyuria. What is polyuria? This is also important. More than 40 ml per kg per day or more than 3 liters per day. This is polyuria. So because of polyuria, what will happen to the tonicity of the plasma? Patient is dehydrated, more water is lost. So the solutes are left. There will be hypertonicity. So what is the physiology behind hypertonicity? Whenever the osmolality of your plasma is increasing, there are two mechanisms which will be activated. There will be release of ADH and there will be activation of thirst. So when you're feeling thirsty, it means your plasma osmolality is raising and you need water to dilute that. So when your osmolality raises by 5, blood osmolality or serum osmolality, your ADH will be activated. When if it's raised by 10, your thirst will be activated. So if you're feeling thirsty means even your ADH is not able to balance your osmolality. You need water. So what's happening here? There is hypertonicity but ADH is deficient. So there will be thirst. The thirst will be activated and patient will be having water hunger. So there should be hypernatremia also, right? One of the solutes in the blood is sodium. But there won't be hypernatremia because of thirst, patient will be drinking water and ultimately patient will be having normonatremia or normal sodium. So this is how the patient is going to present, or these are the key points I'll give in the question. Polyuria, hypertonia. Okay. But are central diabetes insipidus, nephrogenic and primary polydipsia, all these three will be having these conditions. All these three will be presenting with polyuria. So these are the DDs of polyuria. So how do I differentiate? So whenever he gives a question of polyuria in the exam, he expects you to differentiate it between these three conditions. So you should be clear in how to differentiate. So clarity is more important now. Yeah, you have read everything, but clarity, we are giving that final clarity. So central diabetes insipidus and nephrogenic diabetes insipidus, what is happening to plasma osmolality? Because there is loss of more water in the urine, the osmolality of plasma is increased. What is happening to urine osmolality? Because water is added to the urine, the osmolality of urine is decreased. Whereas primary polydipsia or psychogenic polydipsia, it's a psychiatric condition in which patient keeps on drinking water. It's basically water toxicity. So he's adding more water to the body. So what's happening to the plasma osmolality? It's decreased. Obviously, more water into the body, more is excreted, and the urine osmolality is also decreased. So this is the catchy point here. That is how you can differentiate. And one more thing, you can do water deprivation test. See, I told you in endocrinology, anything is deficient, we are going to stimulate it. How are we going to stimulate ADH? By water deprivation. When you are water deprived, your serum osmolality will increase and ultimately ADH should be stimulated. So here, because ADH is deficient, we are stimulating. So in water deprivation test, I'll ask patient to not drink any fluids for 8 hours. So morning I'll start, by evening his 8 hours finishes, and I will be looking at the urine osmolality. So when the water is deprived, more of ADH stimulation should be there, and there should be anti-diuretic effect, and the urine should be more osmolality, more concentrated, right? His urine osmolality should be more than 600 milliosmoles per kg. Then yes, he's perfectly normal. This is how a normal person should respond to water deprivation test. But if the urine osmolality is less than 600, you're depriving him, but still ADH is not stimulated, means ADH is deficiency or not acting. If it's less than 600 milliosmoles per kg, I'm speaking about urine osmolality, I'm suspecting that this patient can have diabetes insipidus. So next thing I'll be giving is, I'll give the patient vasopressin or desmopressin. And again I will repeat the test after 4 hours. After 4 hours, I'm repeating it. Now I have given ADH from the outer source. So ADH should act and the urine osmolality should increase by 600. So if it's increasing more than 600 means previously ADH was deficient. Now I am giving ADH. That is the reason urine osmolality has increased. So this indicates there is central diabetes insipidus. But even after giving ADH, the osmolality is not decreasing, means increasing, means the ADH is not acting, the receptors are resistant, or there is some abnormality with the receptors. So it is peripheral or nephrogenic diabetes insipidus. Okay, this is what you should know. So first thing, if the serum osmolality is low, it's primary polydipsia, excluded. How to differentiate between central and nephrogenic? We'll be doing water deprivation test. In water deprivation test, there are 2 steps. Don't forget that. One is you're depriving of water for 8 hours, and the next thing is you're giving the patient ADH. These are the 2 steps. In water deprivation, the urine osmolality should increase. If it's increasing, it's normal. If it's not increasing, I'll give ADH to the patient. If it's responding to ADH, that means previously ADH was deficient, and that is central diabetes insipidus. If it's not responding, then the receptors are resistant, that is nephrogenic diabetes insipidus. There is no much confusion in this, it's very simple. So this is the approach and presentation of diabetes insipidus. Now let's look into the causes. I told you the drugs causing diabetes insipidus and SAADH is important. So I have given a big table, but those things are not important. We are worried about the drugs. Drugs causing nephrogenic diabetes insipidus. The most important thing is lithium. And your antibiotics like aminoglycosides. And rifampin. Your antifungals like amphotericin B. and demiclocycline. These are the important drugs you should remember. Lithium and demiclocycline. And coming to central diabetes insipidus, any injury or stress to the posterior pituitary can result in decreased ADH production. And other than drugs, the most important causes for nephrogenic diabetes insipidus is electrolyte imbalances also. When the patient is having chronic hypokalemias, hypokalemia and hypercalcemia, they can result in chronic tubulointerstitial disease and ultimately resulting in nephrogenic diabetes insipidus. These are the important causes of nephrogenic diabetes insipidus. So we are done with the causes also. How do you treat? We'll write the treatment here. How do you treat? Vasopressin is deficient, so give vasopressin. We'll be giving desmopressin to the patient, either subcutaneous or intranasal forms. And we will be monitoring sodium because patient can land into hyponatremia at any time. So monitor sodium and give desmopressin. So this is the solution for central. Next, coming to peripheral diabetes insipidus or nephrogenic diabetes insipidus, what can you do? So you don't have to think much for the treatment. For treatment, you have to either target the etiology or pathophysiology or clinical features. Here, for nephrogenic diabetes insipidus, we know the etiology, target the etiology, correct the cause. Stop that drug and the polyuria will improve in 2 to 3 days. And next thing is, one more target is there for lithium-induced diabetes insipidus. The drug of choice is amiloride, which is an INI-CET channel inhibitor. So this is about diabetes insipidus. Let's go back to the question. The question was very simple. Impaired function of aquaporin or resistance of aquaporin channels is seen in nephrogenic diabetes insipidus, and we have excluded the other options too. Coming to the next question. So every point of the question is important. Every key word is important. In exam, he'll give you a lengthy question to waste your time. But you should pick up the key points that will lead to the diagnosis or answer. So we'll be highlighting those key points so that you will be used to picking up the key points in the exam. A diagnosed case of lung cancer. See, that is important. Now he came with complaints of headache, confusion, nausea and vomiting since 2 days. Okay, some CNS symptoms he's having. And he's also developed seizures. Okay, so lung cancer with CNS manifestations. And they have done the labs. Labs is showing hyponatremia and increased osmolarity of the urine. Which of the following is used for the management of the patient? Before going to management, we should know the diagnosis. Only then we can manage the patient, right? So what is the diagnosis? What are you expecting here? The CNS manifestations are due to hyponatremia. So whenever you think or suspect hyponatremia or diagnose hyponatremia, you can treat hyponatremia. It's very easy. You will give NS or 3% NS. You will treat hyponatremia, but you should know the cause and treat that cause so that patient doesn't land into recurrent hyponatremia, right? So here, what is the cause for the hyponatremia? If you know that cause, you can tell the management. So here, it could be SIADH because this is a case of lung cancer, mostly probably small cell lung cancer. And he presented with symptoms of hyponatremia, the typical symptoms, that is headache, confusion, nausea, vomiting, and in severe hyponatremia, which is less than 110, sodium less than 110, patient can also have seizure episodes. So seizures, this is a typical manifestation of hyponatremia. And labs are also showing hyponatremia. We do not know the exact sodium value. How do you treat? Yes, I will give hypertonic saline because patient is in hyponatremia. I will treat it with 3% NaCl. Yes, I will give conivaptan. What is conivaptan? Vaptans are its V2 antagonist. So it's antagonizing the action of ADH. SIADH is excess ADH. So we have to block ADH. That is what this is doing. Demiclocycline. Demiclocycline will cause diabetes insipidus, right? Deficiency of ADH. So we can use that in SIADH. So the drugs causing diabetes insipidus can be used for SIADH. The drugs causing SIADH can be used for diabetes insipidus. That is how you can remember. So this is causing diabetes insipidus. So we can use it for the treatment of SIADH. Now coming to fludrocortisone. Fludrocortisone is a mineralocorticoid. So when we give mineralocorticoid, there is more of sodium and water resorption. And ADH, antidiuretic hormone, is causing urinary loss. Sorry, it's also causing water resorption. And we don't want that, right? It's the same effect. So no, we cannot use that. And desmopressin is nothing but ADH. It's already ADH excess. So the answer would be 1, 2 and 3. So 1, 2 and 3 is the best answer for this question. So just now we have discussed the deficiency of ADH. Now we'll be discussing the excess of ADH. That is SIADH, syndrome of inappropriate secretion of ADH hormone. Syndrome of inappropriate ADH secretion. That is what is SIADH. So to know about SIADH, first we should know the story of hyponatremia. Whenever a patient is having hyponatremia, how do you derive the diagnosis as SIADH? When do you suspect SIADH? That is how we will learn this. And SIADH is a diagnosis of exclusion. This one thing you remember. We'll be going to approach of hyponatremia. This is very important. Every NEET aspirant must know this. Not just for the exam, both clinical and exams. You should know hyponatremia. You should not miss it. Not in your dreams, not in your sleep. So whenever there is hyponatremia, that is sodium is less than 135. Normal is 135 to 145, right? So when sodium is less than 135, you suspect it as hyponatremia. Immediately after seeing the sodium, you have to calculate the osmolality. Look at the serum osmolality. Is it normal or decreased or increased? So whenever there is hyponatremia, what do you think the osmolality will be? It should be decreased, right? So whenever there is hyponatremia, the osmolality should be decreased, then only it's true hyponatremia. If the osmolality is normal or increased, then I will call it as pseudo-hyponatremia. There is no problem with the sodium. The fluid content has increased. So normal hyponatremia, it's called isotonic hyponatremia. The tonicity is increased, hypertonic hyponatremia. Where do you see this? Isotonic hyponatremia is seen in hyperproteinemia, and hyperlipidemia. And one of the example for this is your multiple myeloma, where your paraproteins IgG will be increased and the sodium can be read as false low. Coming to hypernatremic hyponatremia, where do you see this? when there is some hypertonic or osmotic substance in your plasma, like glucose, hyperglycemia, and that osmotic substance can be mannitol or it can be glycine. So if we remember it like this, you won't remember it for long periods. We should know the clinical application, then only you can remember it. Hyperglycemia. So once I got a referral from other department. Patient is completely fine. They have referred in view of hyponatremia. Sodium was 128, bit low. So they want me to opine on that. What's the reason for hyponatremia and how to evaluate. So I have calculated the osmolarity. It was high. Then I have looked at the sugars of the patient. She's diabetic and uncontrolled sugars are there. So the first thing I have written is, first we should control the sugars. There is nothing to do with the sodium because the patient is also completely fine. So it was hypertonic hyponatremia because of hyperglycemia. One more application, glycine. Whenever they are doing TERP, prostatic resection, they will be using glycine as the irrigation fluid and they will do the surgery only for 1 hour. If you go into the urology OTs, they will be monitoring the time, at what time they have started the surgery, and if it's exceeding 1 hour, they will be like, finish it fast. They'll be forcing you to finish it fast. What is this 1 hour time period? Because this glycine is an osmotic substance and the patient can land into hyponatremia. That is the reason they will do TERP only for 1 hour, because the irrigation fluid is glycine, which can result in hypertonic hyponatremia. So these are the clinical applications you can never forget. So isotonic and hypertonic, there is no problem with the sodium. Some other substance is added to your plasma. That is the reason the tone has increased and the sodium is red low. That's false reading of low sodium. Coming to true hyponatremia, we are bothered about this. So whenever you diagnose this as true hyponatremia, what is the next thing you have to look at? You have to look at the volume status of the patient. Volume status of the patient. Is he hypovolemic, dehydrated, or hypervolemic, edematous, or euvolemic? Not both. Why should I differentiate? Because the DDs differ. So in exam, they can give you a keyword of hypervolemia, patient is edematous in the question. So these are the keywords, not only clinical, but also in the exam point of view. So the same table, patient is hypovolemic or euvolemic or hypervolemic. So hypovolemic means both water and sodium are lost. Euvolemic means sodium is normal, but the water has increased. The water content has increased, which is diluting your sodium. That's why there is dilutional hyponatremia. And the same with hypervolemia. In fact, your sodium is high, but the water is more high than sodium. That is the reason in hypervolemic hyponatremia, we will be advising sodium restriction. For suppose a case of CLD or heart failure come to you with hyponatremia and hypervolemic, you will be advising sodium restriction, salt restriction. Because the pathophysiology is water is increasing more than sodium. In fact, the sodium is high. Sodium is increased, water is increased more, resulting in dilutional hyponatremia. So that is why we will be advising sodium restriction to the patient of hypervolemic hyponatremia. Don't be surprised when you see a consultant advising sodium restriction to a case of hypervolemic hyponatremia. Okay. So coming to the causes of hypovolemic. Patient is in true hyponatremia and he is dehydrated. What is the cause? There is fluid loss or solute loss from some places like kidney or your GI tract. Patient is having vomitings, diarrhea or excessive sweating. So there is loss, fluid and salt loss. Coming to hypervolemic. Increased fluid. So fluid overload conditions like your CKD, kidney disease, heart failure and liver disease. CKD, chronic heart failure, chronic liver disease, All these things can cause hypervolemic hyponatremia. So hypo and hyper are easy to remember. Now comes to the euvolemic hyponatremia. So the most important things you should know about euvolemic hyponatremia is your cortisol deficiency, glucocorticoid deficiency, and hypothyroidism. So, and also other causes your SIADH. So when so to come to SIADH, patient should have hyponatremia. That should be true hyponatremia. It should be euvolemic. In euvolemic also you have to exclude the glucocorticoid deficiency and thyroid deficiency by doing thyroid profile and serum cortisol. And then you will come to a conclusion of SIADH. I told you, it's a diagnosis of exclusion. Yeah, now it's true. So now you know everything about hyponatremia. How is it going to present? So you know the presentation. It presents with nausea, vomiting, headache, confusion, and if it's more severe, seizures and altered sensorium. So one important thing you have to remember is some patients will be having chronic hyponatremia. Chronically, the sodium can be 120, he'll be asymptomatic. And acute hyponatremia, even if it's just 129, 130, decreased a little bit, but it's sudden, patient will be symptomatic. So always acute hyponatremia will be symptomatic and severe hyponatremia will be symptomatic, less than 110. So a patient of hyponatremia with symptoms, either it's acute or severe, and you have to treat it. You have to treat it, even if it's bit less also, mild hyponatremia also, acute with symptoms, treat it. How am I going to treat it? Treatment of hyponatremia. Hypovolemic because of fluid loss, or euvolemic because of fluid excess. Hypervolemic, both fluid and sodium is excess, but fluid is more than sodium. How are you going to treat? So hypovolemic, there is fluid loss. Give fluid, give 0.9% NS, isotonic fluid, that is enough. So 0.9% NS is isotonic. Just give it. How are you going to treat euvolemic and hypervolemic? Here the patient is already fluid overload. So we have to give concentrated sodium if the patient is symptomatic. If the patient is symptomatic, give 3% concentrated. Here it's 0.9, here it's 3% NaCl. If he is symptomatic. No, he is not symptomatic. Then advise fluid restriction. In hypervolemic, we also advise sodium restriction. And we can also give diuretics to decrease the fluid overload. This is how we are going to treat hyponatremia. So before treating hyponatremia, not just simply giving 3% NaCl, you should differentiate whether it's hypo, U or hypervolemic, and what is the cause. You have to treat the cause also. In euvolemic, there are some treatable causes. Hypothyroidism, glucocorticoid deficiency, SIADH. SIADH has some causes. You can treat the cause. So knowing the cause is also important. So this is about hyponatremia. Now let's look into SIADH. What are the causes of SIADH? SIADH is an apt example of euvolemic hyponatremia. So any stressful condition can mimic SIADH because ADH is a stress hormone. So any stressful conditions, any infections, trauma, whether CNS or out of the CNS, patient can land into SIADH. And coming to the CNS, mainly your head trauma is the most common trigger for SIADH. And even in meningitis, you have to suspect SIADH, and some of the malignancies, most important, small cell lung cancer also can present with SIADH. Now the most important thing is drugs. Drugs which can cause SIADH are vasopressin, this has ADH activity. And the anti-cancer drugs are vincristine and cyclophosphamide. And the drugs you use in your psychiatry, serotonin reuptake inhibitors and tricyclic antidepressants, monoamine inhibitors. Your anti-seizure medication, carbamazepine, can result in SIADH. These are the drugs which can cause SIADH. So patient on these drugs presented with euvolemic hyponatremia, you should suspect these drugs causing SIADH. Stop these drugs and patient will improve in 2 to 3 days. Coming to Barter and Schwartz criteria for SIADH. You may be like, "Arey, one more criteria is there." Nothing. The criteria will tell whatever we have discussed. So there should be hypoosmolality. So it should be true hyponatremia. That is what he's telling. The osmolality should be less than 280 milliosmoles per kg. The next thing is urine osmolality. Should be more. It should be increased. Because there is SIADH, antidiuresis, the water is not lost in the urine. So the urine will be concentrated. That is what he is telling. Yeah, we know that. And the next thing is patient should be in clinical euvolemia. Yeah, it's euvolemic hyponatremia. We know that. And there should be normal thyroid, adrenal and renal function. He has excluded the glucocorticoid deficiency, the thyroid deficiency or any abnormality in the kidney. It's just because of the ADH excess. We know that. And there should not be any evidence of renal sodium conservation. That is, urinary sodium should be more than 30 millimoles per liter. Because the urine is concentrated, obviously the sodium in the urine will be more. So this is Barter and Schwartz criteria for SIADH. Everything can be derivable. Coming to the treatment of SIADH. We have already discussed the treatment of euvolemic hyponatremia. So it's the same, plus in SIADH the main thing comes is treat the cause. Any drugs or any stimulatory event causing SIADH, you have to treat it. And if the patient is symptomatic, you can correct with 3% NaCl for sodium correction. And there are some drugs, that is V2 receptor antagonist, that is tolvaptan. And the other drug is V1 plus V2 receptor antagonist, that is conivaptan. Presently we are using this for the treatment of SIADH. When do you start this? When the sodium is less than 125. Only then you start this. So there are some important restrictions for these drugs, which is very important. So tolvaptan we can give only for 30 days. Not more than that. Conivaptan is an infusion. We'll be giving it IV. Tolvaptan is oral. Conivaptan you can give only for 4 days, not more than that. Why? Because these two drugs are highly hepatotoxic. If given more than these days, it can result in hepatotoxicity. They both are hepatotoxic. Conivaptan and conivaptan. Let's go back to the question. Yes, we know everything. Conivaptan we can use, hypertonic saline we can use for SIADH, and demeclocycline is a drug which is causing diabetes insipidus, so we can use this. Desmopressin is nothing but ADH. Already the patient is in excess of ADH state. And this is a typical lung cancer presenting with SIADH. It is a paraneoplastic syndrome, right? So now you know the physiology of ADH, from where it's produced, on which receptors it's acting. What is the deficiency, diabetes insipidus? How are you going to differentiate between central, nephrogenic and primary polydipsia? How are you going to treat that? Next, the excess condition, that is SIADH, and approach to hyponatremia. You know how to approach hyponatremia and ultimately diagnose it as SIADH, and how do you treat it. Yeah, these things are very important, and now we know all those things. So So we are done with the most important hormone of the posterior pituitary. Now let's go to anterior pituitary. First, let's take up the question. She's a female, okay, presenting with galactoria, but there is negative pregnancy test. So she's not pregnant, but still presented with galactoria. So they have suspected something, that's why they have done MRI. MRI is showing a large pituitary tumor. So if the patient is not willing for surgery, which of the following is the best drug for the management? So before knowing the drug, we should know the diagnosis. What is the diagnosis? This is a pituitary tumor producing some hormone in excess, resulting in galactoria. What is that hormone? It's prolactin. So normally prolactin will increase in pregnancy during the intrapartum and postpartum periods. That's why there will be lactation. It is useful to maintain and induce lactation, right? But here this patient is not pregnant, but still there is galactoria, increased prolactin. That means there is some pathological process involving resulting in increase in prolactin. That pathology is pituitary tumor. So it's a pituitary adenoma resulting in producing of excess prolactin. So I call it as prolactinoma. So the diagnosis is prolactinoma. Because it's a large tumor, the patient will be having some compressive effects like headache, bilateral hemianopia. All these symptoms would have been there. That's why they have suggested for surgery, but she is not willing. So the next important thing is medical management. So what is the treatment of choice? So before knowing the treatment, you should know one thing about dopamine. Dopamine will antagonize prolactin production. So you should give dopamine agonist, that is bromocriptine or cabergoline. That is the best drug. Actually, cabergoline is more better than bromocriptine. He has not given that. In options, if cabergoline is there, choose cabergoline. So coming to hyperprolactinemia. So one more important thing here is clozapine, which is an antipsychotic which can cause hyperprolactinemia. But here there is a pituitary mass, pituitary tumor. So the diagnosis is prolactinoma. And this is not a treatment because this itself will cause hyperprolactinemia. So this is not treatment. Coming to hyperprolactinemia. The most important things you should know about the cause of prolactinemia. See, normally your prolactin will be less than 25. If it's more than 25, you should suspect a pathology. If the levels are between 25 to 50, you can suspect drug induced or physiological. What are the physiological causes of hyperprolactinemia? Your lactation, pregnancy, right? If it's more than 50, then it's definitely pathological. And if it's more than 200, it's definitely an adenoma, prolactinoma. Got me? What are the drugs causing hyperprolactinemia? These drugs are very important. Your antipsychotic drugs. The most important side effect you'll be looking for in antipsychotics is hyperprolactinemia, right? Both your typical and atypical drugs can cause this, and it's more for typical. In typical, remember these drugs: risperidone and olanzapine, quetiapine. It's least for clozapine. So if you have started on antipsychotics, patient is developing this hyperprolactinemia symptoms, you can switch to clozapine. And coming to risperidone, in risperidone induced hyperprolactinemia, the levels of prolactin are very high, almost more than 200, simulating adenoma. So patient is on risperidone, prolactin levels are these high, you will think it can be pituitary adenoma, but risperidone has the potential to cause that much high prolactin levels. Don't forget that. Next, your antidepressants, tricyclic antidepressants, MAO inhibitors, and your antihypertensive drug, that is verapamil and alpha methyl-dopa, your anticonvulsants, that is phenytoin, your prokinetic agents, metoclopramide and domperidone, all this can cause hyperprolactinemia. So these are the drugs causing hyperprolactinemia. Now you know the drugs. Do not forget risperidone, the highest prolactin levels. And next, the olanzapine, clozapine, least chances. Okay. Now let's go to adenoma, that is prolactinoma. So this pituitary adenoma can be microadenoma or macroadenoma. Microadenoma is less than 1 centimeter. Macroadenoma is more than 1 centimeter. Less than 1 centimeter, 1 to 4 centimeters. If it's more than 4, it's called giant adenoma. Okay. So most of the prolactinomas are microadenomas. So most of the prolactinomas are microadenomas, so you don't have to treat it surgically. Most of them will go for drug related or pharmacological treatment. Whereas your growth hormone excess or somatostatinoma will be macroadenomas, and most of them will be going for surgeries. These 2 points you should know. Growth hormone excess, growth hormone producing adenomas, mostly macroadenoma, most of them will land in surgery first. In fact, the surgery is the first line treatment there. Whereas prolactinoma, most of them are microadenomas, so you will be doing first drug management and the surgery is the second line. So the prolactinomas, first line, most common or microadenomas, and the first line will be drug or pharmacological management. And what is that pharmacological management? We'll be giving dopamine agonists because dopamine will inhibit prolactin production. What are the dopamine agonists? We have just discussed cabergoline and bromocriptine. Cabergoline is the best. Okay, patient is on pharmacological management. What are you going to monitor? You are going to monitor the serum prolactin levels. When will you going to do surgery? What are the indications of surgery? So I told you surgery is the second line, but which patient will land into surgery? Just now we have discussed, in this case they have advised surgery because there are mechanical symptoms. That is compression of the, they had not mentioned here, but the mechanical symptoms will be increased ICT, the patient will have headaches, and the compression of the surrounding structures, especially your visual pathway. Your optic chiasma is compressed, resulting in bitemporal hemianopia. This term is important, bitemporal hemianopia. One thing is mechanical obstruction or mechanical symptoms, or the tumor is refractory. Anything which is refractory will land in surgery, right? It's refractory to medication. Or persistently high prolactin levels. All these things will land into surgery. So this is about prolactinoma. See, the same thing is given in this table. The symptoms are there. You have to see whether it's micro or macro adenoma. Most of it is micro. You will be giving drug treatment and you will be monitoring prolactin. If it's macro adenoma, you will, here they have tried drugs first and they have monitored the size. If it's increasing, they have gone for surgery. And one more important thing is, if the tumor is not operable, you can go for radiotherapy. So this is about prolactinoma. This is how you diagnose it on MRI. You can see a pituitary lesion. So this is microadenoma. And one more important thing is, in diabetes insipidus, because of ADH, there will be a bright spot in the posterior pituitary. In diabetes insipidus, that too central. The bright spot in the posterior pituitary is lost. So these are the things you should know about pituitary gland. So the other adenomas we have discussed in the previous PYQ session. You can watch it there. Let's take up the next question. Which of the following does not need screening for pituitary tumors? So he has given some syndromes and he is asking which syndrome will have pituitary involvement. Now you tell me MEN1 has pituitary involvement or not? Yes, MEN1 is your pituitary, pancreatic and parathyroid, right? So pituitary adenoma is there. And what is the most common pituitary adenoma in MEN1? It is prolactinoma. And there is pancreatic too. The pancreatic involvement is neuroendocrine tumors. So it's clarity. Clarity is more important. You would have remembered pituitary, pancreatic, parathyroid, but it should be more clear. In that, most common is gastrinoma and parathyroid adenoma. So this is the triad of MEN1. And in MEN2, there is involvement of your medullary thyroid cancer and parathyroid involvement. Pheochromocytoma 2. So in that, there is no pituitary gland involvement. Now coming to MEN4, MEN4 is nothing but MEN1 plus solid organ malignancies like your ovarian, cervical and testicular malignancies. Whereas your Carney's complex is also having the pituitary adenomas. See, pituitary adenomas and hyperplasias is seen along with your atrial myxomas. That is Carney's complex. So what I have just discussed is in this table. So MEN1 is hyperparathyroidism, pancreatic neuroendocrine tumors and pituitary adenomas. That is the triad. But other than that, it can also have foregut carcinoids and adrenal adenomas. This is very important. They can ask a question about foregut carcinoids because you know the triad but you don't know that. And it's due to MEN1 or menin gene mutation which is on 11q. Next, MEN4, it's similar to MEN1 with other tumors. So there are solid organ malignancies. Carney's complex is due to PRKAR1A gene mutation and it also has pituitary hyperplasias and adenomas along with atrial myxomas and schwannomas. These things you have to remember. All these three have pituitary involvement. Atrial myxomas, schwannomas plus pituitary adenocarcinoma. So whenever you're looking into the endocrine, never miss pituitary, because pituitary is very important, especially the posterior pituitary and the anterior pituitary hormones, their functions and deficiencies, and the syndromes. Men's syndromes are very important. Now let's take up the other very important topic of your endocrinology is diabetes. So when you sit in the OP, either endocrinology or as a physician, the most common OP will be your diabetes mellitus. So the most common OP, so it's the most common asked question. Yes, we see diabetes most commonly, but there are still lacunae in our uh, concepts of diabetes. So we'll cure that or we'll complete that. He's asking what is the criteria for the diagnosis of diabetes mellitus. Now you tell me, how do you diagnose a case of diabetes mellitus? If the sugars are elevated, is it diabetes? You have to look into many things. So let's solve the question and let's learn it together. He's asking the sugars are more than 126 plus there is symptoms of diabetes, or the random blood sugar is more than 200. Yes, that is how you diagnose it. And the HbA1c more than 6.5%, you diagnose it as diabetes. This is according to the ADA guidelines. ADA guidelines we are looking into. And the two are postprandial sugars are more than 200. No, this more than 200 is not after post lunch. It is after glucose tolerance test. You will be giving a 75-gram glucose tolerance test. After that, after 2 hours, if the sugars are more than 200, you diagnose it as diabetes. This thing is the most misinterpreted point. You will be thinking it's 2 hours postprandial. So you'll ask the patient to come before food or before breakfast. Before breakfast, you'll be taking fasting if it's more than 126, and after breakfast, you have taken after 2 hours if it's more than 200. You think that is diabetes, but you have asked the patient to take breakfast, but you don't know how much carbs she is consuming, how much fats she is consuming. So to make it constant, we'll be giving glucose tolerance test, which will be having 75 grams of glucose. And the fasting plasma glucose more than 126 mg per dl. So this question has been wrong. So this is how it should be. Yes, if the randomly you have pricked the patient and seen that the GRBS, so if you're pricking and seeing, that is capillary. If you're taking the blood, then that is venous. Okay. You're pricking and the GRBS is more than, or RBS is more than 200 with the symptoms of diabetes. What are the symptoms of diabetes? Polyuria and polydipsia plus fatigue. Here also there is polyuria. Why there is polyuria? Why do you think there is polyuria? Because there is an osmotic substance in the urine. What is that osmotic substance? Sugar. Because it's osmotic, it will drag more water and take along with it through urine. So more water in the urine, polyuria patient will be complaining of. And of course there will be nocturia. He'll be using the washroom multiple times in the night also. And polydipsia, because more fluid is lost in the urine, patient will be activated, the ADH will be activated, the thirst mechanism will be activated, so patient will take more of fluids. So there is polydipsia and there will be fatigue. So symptoms plus random sugars 200, HbA1c more than or equal to 6.5, and after glucose tolerance test OGTT, after 2 hours if the sugars are more than 200 or the fasting is more than 126, any one of these four, you diagnose it as diabetes mellitus. So the wrong option is asking is B and C. So here they have given the FTG guidelines. This is all the things we have discussed. So after a short break, we'll be continuing with the diabetes and we'll see the different types of diabetes too. Okay, let's continue with diabetes. So now we have diagnosed it as diabetes. So when you have seen a young presenting with diabetes, you think as type 1. Elderly presenting with diabetes, you think of type 2. Yeah, that is the basic dictum or basic thing you will be learning, but that is absolutely false. So elderly is type 2. What is elderly? At what age it's called elderly? So type 2 can be presenting from post-pubertal to elderly. Anything can be the age for type 2. So you cannot simply say elderly presenting with diabetes is type 2, young presenting with diabetes is type 1. So how do you differentiate? So diabetes is type 1, type 2 and 1.5. 1.5 is it's mixed. It looks like both. So what is type 1 diabetes? Basically, due to some infection or some insult or genetically, there is deficiency of pancreatic beta cells resulting in deficiency of insulin. It's basically insulin deficiency. Whereas type 2, your insulin is good, your beta cells are good, but there is insulin resistance. What is insulin? Insulin will act on the target organs through GLUT4 receptor, that is your skeletal muscle, cardiac muscle and liposome or your fat. But that GLUT4 is resistant to your insulin. That is called insulin resistance. And this insulin resistance will ultimately lead to beta cell dysfunction. So type 1, beta cell destruction resulting in insulin deficiency. Type 2, insulin resistance resulting in beta cell dysfunction. Now both of these things are perfectly separate, right? They are different. Type 1.5, we will see about that. And type 1, this patient is completely insulin deficient. So if you look at the serum insulin, so insulin has very low T-half, you cannot measure that. We will be looking at the C-peptide. C-peptide is like a precursor of insulin. So the C-peptide levels are low, very low in type 1. In type 2, it's normal or slightly low. So this is how you can differentiate type 1 and type 2. And in type 2, the patient will be having the symptoms or signs of insulin resistance. What are the symptoms or signs of insulin resistance? The patient will have obese phenotype with the signs of insulin resistance like acanthosis nigricans and skin tags. But a type 1 diabetes will be very thin. So we are speaking about the phenotype. His phenotype will be thin and no such insulin resistance features. So you have to look at the phenotype, the insulin levels, only then come to the conclusion of type 1 or type 2. And one more important thing is the presentation. So the type 1 can present with explosive presentations like decay. So a young with thin phenotype came with decay, mostly it's type 1, mostly. Whereas type 2, the presentation can be anything. It can be polyuria or asymptomatic. Just on routine checkup, he would have been diagnosed as diabetes. This is mostly asymptomatic. And you do not see decay in type 2. Type 2 presented with decay, then you have to suspect some other pathology. It's not type 2. So whenever I used to present to my professor, when I was a postgraduate, I used to present type 2 presented with the decay, my sir used to ask me what is KPD. So now you know what's KPD. It's looking like type 2, but presentation is very explosive like DK. It's one of the type of type 1 diabetes. KPD, ketone prone diabetes. So everything will be like type 2. the person will look like type 2 phenotype with insulin resistance features. But he will present to you with DKA. So the presentation is like type 1. And initially first line we will start him on insulin. But ultimately he will need only oral hypoglycemic agents. So what's the difference between insulin and oral hypoglycemic agents? I'll tell you. Type 1, they need insulin. Type 2, you can manage them on oral hypoglycemic agents or insulin. So this KPD, the phenotype is type 2. They'll be presenting with explosive manifestations like type 1. Initially they need insulin, but later you can manage them on OHA. Next thing is latent onset, adult onset diabetes, LADA. So coming to LADA, latent diabetes of adult onset, it is similar to KPD, like exact opposite presentation to KPD. So the patient will look like type 1. The phenotype is type 1. He will present like type 2. Stable with asymptomatic rise in sugars. You will be initially starting him on OHAs, but ultimately he needs insulin. Yes, this is a bit confusing, but KPD, remember, type 2 diabetes presenting with DKA is KPD. LADA, type 1 diabetes presenting with asymptomatic manifestation is LADA. I think now you know the differences. What is the presentation? Young presenting with diabetes is not type 1. Elderly presenting with diabetes is not just type 2. You have to evaluate and look into all these causes, okay? So what are the investigations you do? Okay, for confirming diabetes, you have done the oral glucose tolerance test, you have done the GRBS, everything is, HbA1c is done, you have diagnosed him as diabetes. Now you have to know the etiology, whether it's type 1 or type 2 or 1.5. How do you know that? One investigation we have already discussed is serum C-peptide. If it's low, it's type 1. The next investigation I will be doing is the antibodies. Anti-GAD antibodies, anti-insulin antibodies. I will be looking at the antibodies. If the antibodies are present, then it is type 1. Or sometimes in LADA also it's present. Okay. So based on the antibodies and serum C-peptide levels and the presentation, the phenotype, you will be deciding whether it's type 1 or type 2 or mixed. That is how you manage the patient. Okay, now we have known type 1, type 2, 1.5 and how to diagnose it, how to differentiate it. Let's go back to the question. Yeah, we're completed with the question. Let's take up the next question. Young male with diabetes. Is it type 1? We don't know, we have to see. BMI is 20. Okay, slightly high. And there is same history of young onset diabetes in the family. Okay, there is family history too. The serum insulin level is low. So there is deficiency of insulin production. Urine ketones were negative. So it's he or she is not in DKA. Islet autoantibodies are negative. He has seen the antibodies also. So it's looking like type 1. But he's a bit obese. There is family history. Type 1 because the insulin levels are low, but the antibodies are absent. He was started on oral hypoglycemic agent, that is one of the sulfonamide ureas, that is glimepiride. On glimepiride, everything was in control. So I told you type 1 won't respond to your oral hypoglycemic agents. He needs insulin. But here just with oral hypoglycemic agents, this has been controlled. So this is not definitely a typical type 1. Even the antibodies are negative. So he's asking what is the correct statement regarding this condition. Only when we diagnose we can tell the correct statement. What is the diagnosis? It is MODY. Maturity onset diabetes of young. So whatever the characteristics we have discussed is typical to MODY. So MODY is autosomal dominant with family history. At least 3 generations will be involved with young onset diabetes with no complications. These micro and macrovascular complications are absent with just controlled with sulfonylureas. This is the typical history. So some patients will be telling you, I got diabetes in my early 20s, 30s, but still now I'll take just one tablet. It's in control. I have no complications. Even my father has no complications. You got diabetes just 2 years back, but you are developing these complications. You'll be seeing such set of patients, right? They are moody. They'll be feeling proud that I have diabetes, but I did not develop any complications. It's because of my good lifestyle or good some schedule he's following. But actually it's moody and they won't develop any micro or macrovascular side effects or complications of diabetes. So he's asking what is the correct statement regarding this. It's autosomal dominant. It doesn't require insulin therapy. It responds to only sulfonylureas. Yes, it's associated with other anomalies like cystic kidney disease because it's a inherited condition. Other organs can also be involved. So what are the points you have to note down? About MODY, it is familial, that is autosomal dominant. So what is the gene defect? There are many types of MODY. The most common is MODY 3, in which hepatocyte nuclear factor alpha is deficient. It is young onset, the name itself says, and there are no micro or macrovascular complications of diabetes. And just the treatment is sulfonylureas. So the most common MODY is MODY 3. There are some infantile MODYs like MODY 5 and MODY 2 which may require insulin. But the most common, which is MODY 3, because it's the most common, we are discussing the treatment as sulfonylureas for all of the MODYs. But there are some exceptions. Okay. Now, because we have uttered the term micro and macrovascular complications, so diabetes is not just controlling the sugars. The patient has come to your OP, what are your sugars? Okay, in control, you're taking this drug, go. No. The overall approach, what are the microvascular complications she can develop or already developed? You have to manage all those things. Micro and macrovascular complications also should be noticed or attended during your consultation, right? What are the microvascular or macrovascular complications? The macrovascular are your cerebrovascular accident, coronary artery disease, the peripheral vascular disease. And your microvascular are your retinopathy, neuropathy, nephropathy. These microvascular complications are not related to your glycemic control. Whereas your microvascular complications are related to your glycemic control. So if there is a good glycemic control, this patient, you can prevent these microvascular complications. And how do you screen for this? So this macrovascular complications, you cannot do anything, you cannot screen. But microvascular complications, it's preventable and you have to screen. For retinopathy, what are you going to do? You will be doing a fundus examination. But when, see, if it's a type 1 diabetes, they'll be diagnosed very young in the life. So after 5 years of onset of the disease, see, now he's diagnosed as type 1. After 5 years, you have to screen for all these complications every yearly. If he's type 2 diabetes, you have to start it immediately. Now he's diagnosed as type 2. Now itself, I'll do the fundoscope. All the complications. For retinopathy, you're doing fundus. You're looking at the fundus. And for neuropathy, you will be examining the patient. You will examine for vibration, because vibration is the first sense to be lost in diabetic neuropathy. And for nephropathy, what you will monitor in the urine? You will be looking for albuminuria. So even before the decrease in GFR, even before the symptoms, they will monitor with present with albuminuria. I'm extremely sorry. So you have to look for albuminuria. A patient of diabetes now presented with albuminuria, you have noticed albumin in the urine significant, he is going to land in nephropathy. So you have to prevent that albuminuria. And there should be good glycemic control. Okay, these are the things about micro and macrovascular complications. It can be in any diabetes, it can develop. Exception is MODY. Now whatever we have discussed, let's put that in a table. Very simple table. Type 1, type 2 and MODY. Type 1 is pre-pubertal age of onset. And MODY and type 2 both can be post-puberty. Type 2 can extend to elderly also. Okay, now coming to the presentation. Type 1 is explosive presentation, that is DKA. I'm not telling every patient, but type 1 can present in explosive. Whereas type 2 and MODY are asymptomatic. Coming to the phenotype, type 1 will be thin with no insulin resistance, whereas type 2 is obese with insulin resistance. And MODY is normal phenotype. You can say just thin. Not thin, not obese. Just based on the obesity or thin, you cannot diagnose it as MODY. Next, insulin antibodies. See, insulin antibodies are present in type 1. In MODY also it can be present or absent, and in type 2 also it can be present or absent, but in type 1 it's significantly present. And coming to GAD65 antibodies, yes, they are also present in type 1. In type 2 also they can be present, but very low levels, and in MODY they are absent. Coming to family history, in MODY it's 100% because it's autosomal dominant. Type 2 is also an inherited. Monogenic inheritance is there in type 2. Sorry, polygenic inheritance is there. This is monogenic, one gene mutation. This is polygenic inheritance. And yes, in 30 to 90% of the cases, it can be there. I cannot say it's for sure. And type 1 is not inherited. It's very less. Family history is very less. Coming to mode of inheritance, yeah, that is what I was telling. This is polygenic. This is monogenic. Monogenic is one gene mutation and autosomal dominant. Polygenic is it's due to the mutation of multiple genes, multiple factors involving in that. That is type 2. So this is the basic differences you should know between type 1, type 2 and MODY, because there are overlapping. See, a 28-year-old presenting with diabetes, it can be type 1, type 2 or MODY. So you have to differentiate these things. So this is about diabetes. I think it's clear how to differentiate between these three. The most important thing, you have to look at the phenotype, the presentation, what is the age of presentation, what is the insulin levels, what is the antibody levels. All these things you have to see, only then diagnose it as type 1 or type 2 or 1.5 or MODY. Look at the family history also. Ask the family history. Young with diabetes, you should ask for family history. Okay, next let's move on to other important part of endocrine is your adrenals. See, most of the adrenal gland I have covered in the previous PYQ. You can go back to that and see. Because the diabetes and pituitary was not covered in detail there, I have taken that in detail here. Coming to the pheochromocytoma. What is the false statement regarding pheochromocytoma? What is pheochromocytoma? It's a tumor of adrenal medulla, ultimately resulting in increased catecholamines. So more catecholamines, patient will present with hypertension, labile hypertension. So it's one of the causes of secondary hypertension. You will evaluate, you will look for catecholamines in the urine or blood, and you will do a scan, look at the adrenal tumor, and you diagnose it as pheochromocytoma. What is the treatment? You have to excise the tumor. Very simple. Pheochromocytoma is very easy. But the patient is presenting with hypertension, right? Yeah, you will operate the patient. But now the BP is 200. How will you take that case to the operation, surgery, OT? You have to control the BP, right? Blood pressure. For hypertension, what is the drug you are using? He's saying, is propranolol the best choice for treatment of hypertension? That is definitely a false statement. Surgery is the treatment of choice, yes. Vinyl mandelic acid and catecholamines can be used as diagnostic tests, either in the urine or in the blood. I told you catecholamines are increased, but what is this vinyl mandelic acid? Your norepinephrine will be broken down into vinyl mandelic acid and excreted in the urine. So it's just a byproduct of catecholamine. All these things are true, but why beta blocker is not the treatment of antihypertensive of choice in pheochromocytoma? That is very important. See, in pheochromocytoma, your catecholamines are increased. What are those? Your norepinephrine and epinephrine. They will act on alpha and beta, both receptors. Now you have given beta blocker. So all of this will be acting on alpha. More stimulation of alpha, more vasoconstriction, and patient will land in hypertensive crisis. So in fact, this is a contraindication. You should not start with beta blocker. Start with an alpha blocker. If you give a alpha blocker, patient will have vasodilatation and there will be decrease in BP. Decreased blood pressure. But because there is vasodilatation, the afterload is decreased. To improve the cardiac output, there will be compensatory tachycardia. To treat that compensatory tachycardia, once the BP is controlled, in later lines we will be adding the beta blocker. So first the alpha blocker. To control the compensatory tachycardia, we are giving the beta blocker. This concept is very important. Alpha blocker followed by beta blocker. So if you cannot use the alpha blocker, you can also give the calcium channel blockers. Even they are vasodilators. Even with calcium channel blockers, because they are vasodilators, there will be compensatory tachycardia. You should give beta blockers in the later lines. So any patient on calcium channel blockers, you should add a low dose of beta blocker to it because the patient will be having tachycardia. So first you have added alpha blocker. The best alpha blocker is phenoxybenzamine. It is a non-specific irreversible alpha blocker which is long acting. Long acting, non-specific. So it will be acting on all the alpha receptors and irreversible alpha blocker. So that is the best one to choose. So after 10 days or 2 weeks, you will be adding the beta blocker. And before surgery, at least 2 to 3 days before, you should add the beta blocker to control that compensatory tachycardia. In surgery, there will be more blood loss and the patient can have more tachycardia. Then you have to take for surgery. Surgery is excision of the tumor. During surgery, if the patient is having hypertension, you can give during surgery nitroprusside infusion. You can. nitroprusside IV you can give during surgery. So this is the management of pheochromocytoma. It's very simple, right? So coming to pheochromocytoma, what are the important things you should know? What is paraganglioma? Paraganglioma versus pheochromocytoma. So pheochromocytoma is a neuroendocrine tumor of the adrenal medulla, whereas paraganglioma is extraadrenal, which will involve your sympathetic and parasympathetic ganglions. See, if you look into this picture, if the tumor is here in the medulla, that is pheochromocytoma. See, if it is along this sympathetic and parasympathetic ganglions, that is called paraganglioma. Very simple. That is the difference. It will present with, so the catecholamines are increased, resulting in hypertension. So the patient will present with palpitations, sweating, and headache. All these things are intermittent. Intermittent palpitations, headache, and sweating. This is the typical triad of pheochromocytoma, and this patient will have labile hypertension. Sometimes he is in hypertension, sometimes the BP is normal. So whenever he is having those symptoms, the BP will be more. So this is the presentation. When you are suspecting secondary hypertension, especially labile hypertension, patient is having headache, sweating, and palpitations, suspect pheochromocytoma. How do you diagnose? Diagnosis is, I can look for the catecholamines in the urine, blood, and I can go for imaging and look at the tumor. How do I look for catecholamines? Just take urine, 24-hour urine, look for the catecholamines. That's the best screening test. And if urine catecholamines are absent but the symptoms are very typical, you can also go for plasma catecholamine test. These two are the screening tests. If it is positive, you have to confirm with imaging, and MRI abdomen is best for looking for adrenals, pheochromocytoma. But if you are suspecting an extraadrenal, then MIBG scan is better. MIBG scan is better for paraganglioma, whereas MRI is best for adrenal, that is pheochromocytoma. This is how you have diagnosed. How do you treat? We have already discussed the treatment. Excision is the treatment of choice, but before excision, it's the physician's duty to control the blood pressure by giving an alpha blocker followed by beta blocker. If alpha blocker is not available, you can also choose calcium channel blockers, but ultimately it should be added on with beta blocker to control tachycardia. Okay. Next, we'll move on to the next question. Here also we'll be discussing adrenals. This is like the most important question. Congenital adrenal hyperplasia, the most important thing and the most volatile thing. So this pathway you have to remember, and this is very volatile. This is the last minute revision table for you. Take it a printout or keep it before your table, or you'll save a screenshot. It's your wish, but you before exam, one day before, you have to look into this table, otherwise you will confuse in the exam. So let's take up the question. 13-year-old not attaining menarche. Karyotype is 46XX only. So she's a female only, but pubertal delay. That's the app statement. So a young female with pubertal delay has come to you. So the first thing we will be checking is the external genitalia and whether the uterus is present or not. The first thing we'll be doing is the external genitalia, do ultrasound to look for the uterus. Uterus is present or absent. First thing we'll be doing that. So they have done examination and there is clitoromegaly. So there is some virilization, androgen excess. What is the most likely enzyme deficiency in this condition? Is it 21 alpha hydroxylase, 11 beta, 17 alpha, or 3 beta hydroxysteroid dehydrogenase? He's asking most likely enzyme with hypervirilization. He has not given anything about the BP status. So the most common, a female presenting with hypervirilization, or a female presenting with delayed puberty, or a female presenting with PCOD. Even PCOD will have hypervirilization, right? And one of the important DD for PCOD will be your 21 alpha hydroxylase. So the patient will not have other mineralocorticoid effects. They can just have hypervirilization and can present as PCOD with delayed menarche or hypervirilization. Now let's look into this and let's derive everything. So we need only two things: what's happening to the androgen status and what's happening to the mineralocorticoid status. What is the BP? What is the virilization, hypo or hyper? Based on that you can tell. Just a second. Let's look at the deficiencies. If there is 21 alpha hydroxylase deficiency, deficient, what is happening to the mineralocorticoid pathway? Ultimately, your aldosterone absent, cortisol absent, everything is going and forming your androgens. So patient is having mineralocorticoid deficiency. So she will have hypo or hypertension. What will happen to the BP? Hypotension plus hypervirilization. So a classical 21 alpha hydroxylase will present with hypotension and hypervirilization. But non-classical cases can just present with hypervirilization, which is an important DD for PCOD, especially in young females. Next, let's look into the 17 alpha hydroxylase. See, 17 alpha hydroxylase is deficient. What is happening to the mineralocorticoid pathway? The patient is in hypotension. Sorry, the patient is in hypertension. Everything is coming into the mineralocorticoid pathway. Your glucocorticoids and androgens are decreased. So the patient will have hypertension and hypovirilization. Next, coming to 11 beta hydroxylase. See, the only thing you have to do is remember this flowchart. That's it. Coming to 11 beta hydroxylase, it's deficient, but there is accumulation of deoxycorticosterone, accumulation of deoxycortisol. This deoxycorticosterone has mineralocorticoid effect. So there is increased deoxycorticosterone, increased deoxycortisol, and everything diverted here, so increased androgens. So the mineralocorticoid activity is increased. So you will think the aldosterone is not produced, so there will be mineralocorticoid deficiency. But here there is deoxycorticosterone. So patient will have hypertension plus hypervirilization. Next, coming to 3 beta HSD. 3 beta HSD is deficient. So patient will have increased DHEA, dihydroepiandrosterone, and there is mineralocorticoid and glucocorticoid deficiency. So definitely the patient is in hypotension plus increased DHEA. What will happen because of dihydroepiandrosterone? In females, there will be hypervirilization. But in males, for the production of or development of external and internal genitalia, they need testosterone and dihydrotestosterone. But in males, there will be hypovirilization. This DHEA is not necessary for them. Or I can say it's not sufficient for the virilization in males. But in females, it will cause hypervirilization. So these are the enzyme deficiencies and that's how it's going to present. The only thing you have to do is remember this flow chart. Don't by heart these things. These things are derivable. If you by heart these things, you cannot do anything. But if you by heart the flow chart, you can derive in the exam and you'll be confident about the answer. So I have not seen much cases of congenital adrenal hyperplasia except for 11 beta hydroxylase deficiency. So I have seen a male. He came with young hypertension and hypertensive emergency IC bleed. So we are evaluating for young hypertension. So when discussing with the mother, she told that he is having ambiguous genitalia. So while looking at the genitalia, it's looking like female genitalia with hypervirilization, especially enlarged clitoris. So the genitalia are like female with hypervirilization. So we have done the karyotyping. It is 46XX. So it's a female with hypervirilization raised as male. So hypertension, hypervirilization. And ultimately we diagnosed it as 11 beta hydroxylase based on the enzyme deficiencies. So that is one case I have seen. I'm sharing it with you because at least in exam 11 beta hydroxylase you don't have to think, you will remember my case. Okay, let's take up the next case. He has given an image, okay, and that the patient, they've shown the appearance of the hands, we'll see. Patient is also having short stature and developmental delay. Some skeletal abnormality is there. Mostly it's some congenital disorder. Which of the following is not true regarding the metabolic condition associated with this? If you look at the image, what do you observe? What's happening to the fourth and fifth finger? The metatarsals are short, right? The metatarsals of fourth and fifth fingers are short. So this patient is having short stature, developmental delay, and short fourth, fifth metatarsals. I'm sorry, metacarpals. These are hands, right? So there are short metacarpals. So you can find short metacarpals in other syndromes also. But fourth metacarpal shortening is very significant or specific to Albright's hereditary osteodystrophy. AHO. So you can see second metacarpal shortening in Down syndrome, first and second. But fourth is most specific for Albright's hereditary osteodystrophy. So he is speaking about AHO. And it is sometimes associated with parathormone resistance, PTH resistance. So we call it as pseudo hypoparathyroidism. So what is pseudo hypoparathyroidism? So you now tell me what is hypoparathyroidism. Hypoparathyroidism is PTH is low. When PTH is low, your calcium will be low and phosphorus will be high. This is true hypoparathyroidism. What is pseudo? It's because of resistance to PTH. Because the PTH is there but it's resistant, the calcium will be low, the phosphorus will be high. But as a compensatory mechanism, PTH will be increasing. So this is pseudo hypoparathyroidism associated with AHO phenotype. It has two types, type 1 and type 2. Type 1 is complete resistance, complete parathormone resistance. Type 2 is incomplete resistance. And in type 1 you have 2A and B. This 1A is associated with bone mineral abnormalities, that is AHO. AHO is present. AHO is absent. So 1A, pseudo hypoparathyroidism, 1A is resistance plus AHO phenotype. 1B is complete resistance plus no AHO phenotype. Type 2 is incomplete resistance. So this is about pseudo hypoparathyroidism. So don't be confused, I'll be telling you one more thing. Patient is having AHO phenotype, that is short stature, developmental abnormalities, short metacarpals, but no parathormone resistance. We call it as pseudo hypoparathyroidism. Just the AHO phenotype is pseudo. AHO with resistance is pseudo. I think now you got it. So this is one of the important DD for hypocalcemia. So what are the causes of hypocalcemia? The first important thing is decreased dietary. Next thing is vitamin D deficiency. Next important thing is PTH deficiency. That is hypoparathyroidism. Other thing is PTH resistance. That is pseudo hypoparathyroidism. These are the major things. Or hypercalciuria in renal conditions. These are the most important causes of hypocalcemia. So a patient of hypocalcemia, you have given calcium correction, but still calcium is not improving or the symptoms are not improving. What do you suspect? What do you do next? That is also one of the important clinical scenario they'll give you. So patient is having hypocalcemia, you will correct. You will give injection calcium gluconate. So it is a 10 ml vial. The vial itself is 10 ml. It contains 10% calcium gluconate. You will give that in 10 minutes. That is how you are going to give calcium correction if it's severe hypocalcemia. But even after this, it's not improving, means you have to suspect hypomagnesemia and you have to give magnesium correction. Only if you give magnesium correction, the calcium will be corrected and the symptoms will improve. And what are the symptoms the patient will have because of hypocalcemia? He can present with tetany, seizures, tingling, numbness, all neurological symptoms. Most common will be perioral tingling and numbness. He can also have all over the body. And how do you test for this? There are few tests. What is Chvostek sign? And what is Trocheau sign? Chvostek is when you tap on the facial nerve just before the tragus of your ear, there will be twitching of your facial muscles. That is Chvostek sign. And Trocheau sign, when you are looking for the BP, if you have, for suppose your systolic BP is 120, you are just increasing by 10 mm. You have increased that to 130. The patient will have carpopedal spasm. That is Trocheau sign. Schwastakis, twitchings, facial. So these are all the things you should know about hypocalcemia. You know everything. What are the causes? How does it present? How are you testing? How do you treat? One more important thing is what are the ECG findings of hypocalcemia? It is QT prolongation. Most important thing is QT prolongation. And what is QT prolongation? What is the normal QT interval? If it's more than 480 milliseconds, I call it as QT prolongation. So you have to look for the ECG also. Okay, we are done with endocrinology. Most important parts of endocrinology. Let's move on to the nephrology, renal system. So in renal system, you should know what is acute renal injury, chronic kidney disease. In acute, tubulointerstitial and glomerular. In glomerular, nephrotic versus nephritic. These are the most important parts of kidneys you should know, and also the hereditary disease, cystic diseases of the kidney. The channelopathies, that's the Bartter syndrome, Liddle syndrome, and the renal tubular acidosis. These are the important areas where the MCQs have been frequently asked from nephrology. So these topics, if you have missed, yes, you got another chance to read them. Don't miss any of the topic. 7-year-old boy with abdominal pain, vomitings, oliguria, and periorbital puffiness. So important things I got here is oliguria and periorbital puffiness. It's definitely renal failure is there. And the investigations reveal that the uric acid has increased, create has increased, and the potassium has increased. What is the best step in the management of this condition? Okay, what are you suspecting here? Renal failure, hyperuricemia, hyperkalemia, so definitely see in CKD also your urea will be high, your potassium will be high. But he's having abdominal pain, vomitings also. Anyways, the first step in the management is hydration. Hyperuricemia and hyperkalemia, the first step in the management is hydration. You have to give hydration. After that, you can give uricosuric agents or uric acid lowering agents. And this is the typical presentation of TLS, tumor lysis syndrome, if he has a history of malignancy. Which malignancy can cause tumor lysis syndrome? Any malignancy can cause? No. Highly proliferative tumors with massive number of cancer cells can cause this. And what are those? Especially your high-grade lymphomas. Your Burkitt's, DLBCL will have TLS, and your leukemias. They have high tumor cell burden and ultimately result in tumor lysis syndrome. Immediately you give chemotherapy. Immediately you give chemotherapy, that will be killing the cells, and all the constituents of the cells will be coming out, resulting in this tumor lysis syndrome. But why there is increase in potassium, uric acid, why there is renal failure, we will see. And how to manage also we'll see. So suppose this is a tumor cell. So any insult, either chemotherapy or radiotherapy, the constituents of the cell will come out. The first thing is your DNA. Your DNA has your purines and pyrimidines. They will be degraded ultimately to uric acid. And one of the important enzyme in the production of uric acid is your xanthine oxidase. And your uric acid is lysed by uricase to allantoin. but this uricase is absent in humans. So one thing we have noted is there is hyperuricemia. Next, your intracellular compartment is rich in potassium. Now potassium will come out into the plasma. There is hyperkalemia. Next, your intracellular compartment is rich in phosphate. So there is hyperphosphatemia. This phosphate will combine with calcium. So there is calcemia. So calcium is decreased. And all these things, this calcium phosphate especially, will deposit in your kidney, resulting in renal failure. Your CNS manifestations due to calcium. Patient can present with seizures, altered sensorium, periorbital swelling, and pedal edema, oliguria. All these things patient can present. This is the story of TLS. This is happening here. So patient is having hyperuricemia, hyperkalemia, hyperphosphatemia, hypocalcemia with renal failure and CNS, right? CNS manifestations. We'll take a short break. Lunch break we'll be taking from 1 to 1:45, and later that we'll be continuing. Okay, let's continue with TLS. We are at TLS, right? So this is the pathophysiology of TLS, why there is hyperuricemia and hyperkalemia. Immediately after giving chemotherapy, there is massive lysis of the tumor cells, and this is happening in highly proliferative tumors like lymphomas and leukemias, not every solid tumor or hematological malignancy. So this has happened, you have diagnosed. How are you diagnosing? It's either laboratory or clinical. We all know this. Laboratory is increased serum uric acid more than 8, hyperkalemia, potassium more than 6, phosphate more than 4.6, and calcium more than 7. Sorry, less than 7. This is how you are diagnosing laboratory TLS. And clinically, if the patient is having AKI or any arrhythmias, cardiac arrhythmias due to both hyperkalemia and hypocalcemia, seizure, tetany, and CNS manifestations of hypocalcemia, this is how you are going to diagnose TLS. For laboratory, any one of more than or equal to 2, and clinical, if any one is present, you are going to diagnose it as TLS, and you have to start immediate management or treatment. What is the immediate treatment? The first thing you have to do is hydration. With hydration, most of the hyperuricemia will be improved. Next thing, manage hyperkalemia. So let's discuss about hyperkalemia. How do you manage hyperkalemia? So first thing I'll be doing is I will give insulin. Insulin will cause intracellular shift of potassium. Next, beta agonist, salbutamol. Give salbutamol inhalation. Next thing is calcium gluconate. Why are we giving calcium gluconate in hyperkalemia? So the thing with hyperkalemia is the patient is more prone for bradyarrhythmias and cardiac arrest. To stabilize the cardiac membrane, we are giving calcium gluconate. So calcium gluconate will act as a cardioprotective. And add potassium binders. So they will bind any potassium in the food so that your food intake of potassium is also decreased. So this is how you are going to manage hyperkalemia. Immediately after you see a case of hyperkalemia, if you give insulin directly, patient will land in hypoglycemia. So along with 25% dextrose, 100 ml, you give this. 25% dextrose, 100 ml plus 10 units of insulin, give to the patient, and give a beta agonist, salbutamol inhalation. And if there are ECG changes or very severe hyperkalemia, go for calcium gluconate. How do you give calcium gluconate? 10 ml of calcium gluconate, which contains 10% in 100 ml NS over 10 minutes. That is how you are going to give calcium gluconate. And potassium binders. You should know this, the management of hyperkalemia. So these two will cause intracellular shift of potassium. And not controlled by any of these things, the ultimate thing for hyperkalemia is dialysis. It's the best mode to remove potassium, excess potassium. Next, coming to hyperuricemia. You have to give uricosuric drugs, or the drugs which will decrease the production of uric acid. So what are the anti-uric acid drugs? Allopurinol and febuxostat. They are xanthine oxidase inhibitors. I told you from purines, the uric acid is formed with the help of xanthine oxidase. So it will inhibit the formation. You can also give rasburicase. So uricase, I told you uricase enzyme will convert uric acid to allantoin, resulting in excretion of uric acid, but that is deficient in humans, only animals have it. So we'll give a uricase analog, that is rasburicase, which will convert the uric acid into allantoin and ultimately excretion of uric acid. It's uricosuric. And rasburicase, whenever I say the term rasburicase, do you remember anything, any pharmacological correlation? It will precipitate hemolysis in G6PD deficiency. One of the important drug causing hemolysis. So you have to test for G6PD enzyme, only then give raspuricase. Next, hypocalcemia you don't have to manage. If you give fluids, most of the times this hyperphosphatemia and hypocalcemia will be corrected. And even in renal failure, just give IV fluids, that is enough, if not dialysis. So this is the identification and treatment of tumor lysis syndrome. There is one more entity called prevention. So whenever you are suspecting that, for suppose I am treating a case of Burkitt's, you are treating a case of TLBCL, you are giving chemotherapy, you should suspect that this case might land into TLS. So you will be giving something called prophylaxis. Before giving chemo only, I will start the patient on hydration. I will start the patient on uricosuric drugs. I will see whether TLS is present even before the chemotherapy. Tomorrow I am giving chemo, today only I will look for uric acid, potassium and everything, and I will give fluids and I will bring everything to normal and then give chemo. Chemo also initially I will start with low doses and then increase the dose. So that is called prophylaxis. So you should also prevent tumor lysis syndrome. So we have just spoken about tumor lysis syndrome, which is one of the important cause of intrinsic AKI. This is very important. And the malignancies, do not forget, it's lymphomas and leukemias. Lymphomas that to high grade, that is DLBCL and Burkitt's. Burkitt's is having 100% Ki67. Proliferative index is very high, right? 100% they'll land in TLS. And I've told you this criteria, right? This criteria has a name, that is Cario-Bishop criteria. They won't ask you the criteria, but we should learn everything in complete, right? We have learned the criteria, we should know its name. Next question. A case of hepatitis B presented with pedal edema and proteinuria. Renal biopsy they have done because they have suspected a nephrotic syndrome, probably. And that biopsy picture, electron microscopy picture of the biopsy he has given here. If you see here, this is the endothelium, this is the epithelium, and this is the glomerular basement membrane. There are subepithelial deposits, right? And those deposits are, see, spike, dome, spike, dome, spike and dome pattern, spike and dome. They are in spike and dome pattern. Case of hepatitis B with spike and dome pattern of deposits in electron microscope presenting with nephrotic syndrome. It's none other than membranous nephropathy. So you will learn about these features. You will learn that membranous nephropathy has spike and dome, but you would have not seen the picture. But in exam, they'll give you the pictures. So keep looking into those pictures so that it's not new to you in the exam. So he have given the options. We'll see the other options. It's not minimal change disease because in minimal change disease, the name itself says minimal change. There won't be much change except for the effacement of podocytes in the electron microscopy. Hepatorenal syndrome, yes, hepatitis B can cause chronic liver disease which can decompensate and ultimately resulting in hepatorenal syndrome. But this, to say it's hepatorenal syndrome, the patient should be in decompensated chronic liver disease and you should exclude all the causes of AKI. Here for AKI we have a cause, that is membranous nephropathy, so it's definitely not hepatorenal syndrome. Infection related glomerulonephritis. See, like pro-streptococcal glomerulonephritis, there is one entity called infectious related glomerulonephritis, which is seen in elderly or adults. Post-streptococcal is seen in children due to streptococcal infection, whereas infection related glomerulonephritis is seen in adults post MRSA. methicillin-resistant Staphylococcus aureus infections, you can see IRSA. And this is worst prognosis. And the patient will have subendothelial deposits. Same like PSGN, it will be having subendothelial deposits. That is infection-related glomerulonephritis, and no, it's not looking like that. So if you look into the membranous nephropathy, see any nephrotic or nephritic syndrome, the diagnosis of choice is biopsy. Only on biopsy I can say this is minimal change, this is membranous, this is membranoproliferative. Clinically you can say only it's nephrotic presentation or nephritic presentation, that's it. Clinically you cannot say even lupus nephritis, post-streptococcal glomerulonephritis. Clinically you cannot comment it. You can just diagnose it, but the ultimate diagnosis is by biopsy. So this is membranous nephropathy. We have taken the biopsy. In the histopathological view, you will be seeing thickened glomerular basement membrane. And in immunofluorescence, there is linear pattern. And in electron microscopy, oh, I'm sorry. In electron microscopy, you can see spike and dome pattern. So this is the histopathology. This is the immunofluorescence. This is the electron microscope. So every nephrotic syndrome, you should know all these three views. Anything can be a question. Okay. So here you have to treat hepatitis B first. Coming to the next question. All of the following are the features of nephrotic syndrome except. Nephrotic syndrome presents with extravascular edema. Yes, the patient will be having anasarca. Nephrotic range proteinuria. Yes, it is more than 3.5 grams per day. It's non-selective proteinuria. No, it is selective. There is only albuminuria. Yes, it's prothrombotic because the anticoagulant factors are lost in the urine. The protein C, the protein S are lost in the urine. That is the reason the patient becomes prothrombotic and there is more chances of thrombosis, especially renal vein thrombosis. This is about nephrotic syndrome. Coming to nephritic syndrome, the patient will have intravascular edema, not extravascular. So he will be landing to you with hypertension. And the proteinuria is 2.5 to 3.5. Proteinuria is non-selective. All albumins, globulins, everything is lost. And there is most of hematuria. Hematuria is predominant rather than proteinuria. Whereas in nephrotic syndrome, hematuria is not that much. It's basically proteinuria. So proteinuria and pedal edema is nephrotic with prothrombotic. Whereas hematuria, hypertension, and hypertensive emergencies, intravascular edema, everything is nephritic presentation. So the presentations are totally different. So when you are having a nephritic presentation, and if you are looking at the immunofluorescence, I told you biopsy is gold standard, that's why we are looking into biopsy. And in immunofluorescence, it is granular. This is granular. And that granular pattern, if it is because of IgG, it is post-streptococcal glomerulonephritis. If it is IgA, it is IgA nephropathy. The next pattern is linear pattern. The linear pattern in nephritic syndrome is seen in glomerular basement membrane disease. And this is, there is no immune uptake, pauci-immune. It is seen in small vessel vasculitis. Any small vessel vasculitis which is causing glomerulonephritis, there is pauci-immune pattern. And one more for granular is your lupus nephritis. How are you going to differentiate? In lupus nephritis, your C3, C4 or low persistently, and this is persistent. In your post-streptococcal glomerulonephritis, your C3 is low transient, and your IgA C3 is normal. So this is how you are going to differentiate, and the presentations, the age following infection, all the history is also important. Now, if it is nephrotic presentation, we'll be looking at the electron microscopy. In electron microscopy, there is effacement of podocytes or fused podocytes. You will be thinking of minimal change disease. And if there is focal sclerosis of the glomeruli, it is FSGS. And the same spike and dome pattern, it is membranous. So all the patterns we are explaining just based on the biopsy features. If it is nephritic, you have to go look for the immunofluorescence. If it is nephrotic, you have to go look into the electron microscope. Okay. She's a young female. Next question. Presents to you with fever, arthralgia, ulcers since past 6 months and fatigue. See, young female with fever with arthritis and ulcers, oral or nasal ulcers since a long period. First differential diagnosis will be connective tissue disorders, that to SLA. And there is new onset hematuria, kidney involvement. Urine examination is showing RBC, cast and proteinuria. So there is definitely hematuria and proteinuria. What is the likely diagnosis? It is lupus nephritis. Anyways, we have to confirm it with biopsy and C3 levels. You should also go for ANA profile and treat it with steroids. Steroids plus steroid sparing agents. So steroids plus MMF is better than steroids plus cyclophosphamide for lupus nephritis. Coming to acute interstitial nephritis. Acute interstitial nephritis, it's drug related. Most commonly, it's a drug related toxicity resulting in eosinophils in the urine and renal failure. Post-streptococcal glomerulonephritis, usually young adolescents following 3 to 4 weeks of a skin lesion or pharyngitis, they will develop the same nephritic syndrome presentation. They will present with hypertension, hematuria. And IgA nephropathy, following an infection, upper respiratory tract infection, within 3 to 5 days, the patient will have gross hematuria, most of the patients. So this is the typical presentation of lupus nephritis. Coming to lupus nephritis, see, this classification is important. The most important thing you should know about classification is, the most common is type 4. Type 4 is diffuse lupus nephritis. Type 3 is focal lupus nephritis. Type 1 is minimal mesangial proliferation. Type 2 is mesangial glomerulonephritis. Type 5 is membranous nephropathy. See, lupus nephritis, the type 5 or class 5 can present as membranous also. It's nephrotic presentation, right? Type 6 is diffuse sclerosing nephritis. The most worst and the most common is type 4. And type 4 will have wire loop lesions, the lesions like this. So it's because of the thickening of the glomerular basement membrane, you can see such wire loop lesions. You can also see wire loop lesions in HIV. And one more common thing between HIV and lupus nephritis is houseful effect. What is houseful effect? That is, if you do immunofluorescence, there is deposition of everything, IgG, IgA, and complement. Everything is deposited, that's why it's called houseful effect. And also they both have wire loop lesions. Next, HIV specific glomerulopathy. Recently they are concentrating more on this because this HIV, HIV associated nephritic syndrome, is the newly added component of your Harrison. That's why they are asking more questions on this, because it's a new entity. In Harrison it has added newly. So HIV specific glomerulopathy is FSGS, focal segmental glomerulosclerosis, that too collapsing type. So that we call it as HIV, HIV associated nephropathy, HIV associated nephropathy, and it is nephrotic syndrome presenting as collapsing FSGS. So what should you know about this? This HIV is due to direct viral injury. It's because of the virus. So how do you treat it? Antiviral therapy. Whatever highly active antiretroviral therapy you are giving, with that only it should decrease, and it will correlate with the low CD4 counts. So whenever the viral load is high and the CD4 counts are low, this HIV can be seen, and if you treat and bring the viral load to the lower level, this can be treated. That's the only treatment for this. Whereas HIVIC, it is immune complex mediated kidney injury. It is not due to virus. It is due to immune complexes. So treatment, it's not affected by HRT, not affected by heart. So these are the two different entities, and HIVIC is nephritic. HIV is nephrotic, and this is the most common presentation. This is about HIV associated glomerular injury. Next, coming to ABG. See, you should know how to calculate ABG, and you should be quick and accurate, because one or two questions in the exam is for sure they're going to give ABG, they'll give values and ask you to calculate. There is no other way you have to calculate, because if you know, you can easily crack this question. It's not that difficult to learn and not that tough also to leave. So in ABG, you have to see first what is the pH. What is the pH? It's 7.24. So is it acidosis or alkalosis? It is acidosis. 7.35 to 45 is normal pH, right? The next thing you have to see is bicarb and PCO2. What's happening to PCO2? Normally it should be around 40. It's slightly decreased. And coming to bicarb, normally it's around 26. It's also decreased. So bicarb is decreased, PCO2 is decreased, pH is decreased. It is metabolic acidosis. So for this question, until here my calculation is enough. But When there is metabolic acidosis, you have to look for anion gap. We'll complete it. What is the anion gap? It's sodium minus bicarb plus chloride. So what is the sodium? So it's around 20. The anion gap, what is the normal anion gap? It's 10 plus or minus 2. So it should be from 8 to 12. It's 20. Definitely the anion gap has increased. So it is called HAGMA, high anion gap metabolic acidosis. If you get normal anion gap, it's okay. But when you get high, you have to do further. What is the next thing you have to calculate? You have to calculate the delta gap. What is the delta gap? Delta in the anion gap by delta in the bicarb. So difference in anion gap by difference in bicarb. What's the difference in anion gap? It's 20 minus 10. What's the bicarb? It's 36 minus 12. Okay, we'll calculate the exact anion gap. It's almost 30 anion gap. So 20 by 24, it's less than 1 only. If your delta anion gap is 1 to 2, it's pure HAGMA. If it is more than 2, it's HAGMA plus metabolic alkalosis. If it is less than 1, then it is HAGMA plus normal anion gap. Both are existing. So these are mixed disorders. So whenever there is metabolic acidosis, next you have to go for anion gap. If there is high anion gap metabolic acidosis, you should also get delta gap. All these other things, no anion gap. It's calculated. So I can say it is metabolic acidosis. High anion gap metabolic acidosis is there in this case, plus normal anion gap metabolic acidosis. And clinical scenario is also very important. Where do you see high anion gap metabolic acidosis? The most important thing is your ketoacidosis. Whatever the cause may be, diabetic or starvational or alcohol related ketoacidosis, whatever the cause may be, you can see high anion gap metabolic acidosis. Next is lactic acidosis. Then comes your aspirin. Then your renal failure. All these conditions you can see HAGMA, and whenever you see HAGMA, you have to suspect this. And clinically, mostly it's either ketoacidosis or renal failure clinically. These are most common things you find bedside. Sometimes it's lactic acidosis. So how do you differentiate? See, acidosis means pH is decreased. Alkalosis means pH is increased. Metabolic means there is a problem in the metabolic. Metabolic is bicarb. Respiratory is carbon dioxide. Metabolic acidosis, because bicarb has decreased systemically, there is metabolic acidosis. To compensate for acidosis, carbon dioxide will also decrease. That is compensatory, because carbon dioxide is also acidic. Next, metabolic alkalosis is because of increased bicarb. And to compensate that, the acid will increase. To compensate bicarb, acid will increase. Respiratory acidosis is due to increased bicarb. Due to some respiratory pathology, carbon dioxide is staying, not washed out by your lungs and resulting in respiratory acidosis. To compensate acidosis, your alkali will increase. That is compensatory. Respiratory alkalosis is because of some respiratory or central issue, more of carbon dioxide is washed out and there is less carbon dioxide in the body. And it is compensated by, because the acid is decreased, bicarb also will decrease. So this is what is happening in this acid-base disorders. So one thing you can remember is, everything going in one direction, it is metabolic. Any discrepancy in the directions, it's respiratory. So in exam, it's an easy clue. Okay. Next, renal tubular acidosis. Just now we have discussed about metabolic acidosis. I told you about the causes of high anion gap metabolic acidosis, right? And one of the important cause of normal anion gap metabolic acidosis, that is NAGMA, is renal tubular acidosis. So there is acidosis because of some renal tubular pathology. We'll see what is that. So he has given the types and he wants us to match it. Type 4 is due to aldosterone resistance, true. Type 2 can have Fanconi's and hypophosphatemic rickets, yes. Type 4 is paradoxical aciduria, no. Type 4 is not due to aciduria. See what's happening in the collecting duct? There is sodium and water reabsorption. H plus and K plus is secreted in the urine. But this channel is inhibited. In type 4 renal tubular acidosis, this is inhibited, ultimately resulting in decreased H plus secretion. Yes, your H plus is not going out of your collecting duct. That is the reason there is tubular acidosis. So there should be decreased H plus in the tubule, right? So he's saying aciduria, that is increased H plus in the urine, that is totally opposite. So this is the wrong statement. And type 2 is because of loss of bicarb. Yes. Type 2 is in proximal convoluted tubule. Normally bicarb should be absorbed. Because there is some defect in the proximal convoluted tubule, the bicarb is lost and resulting in renal tubular acidosis. See, type 1, type 2 and type 4. Type 1 is distal. It's in distal collecting duct, convoluted tubule. Type 2 is proximal, PCT. Type 4 is on the collecting duct. What's happening in type 1? H plus is lost in the urine. I'm extremely sorry. H plus is not lost in the urine. Resulting in acidosis. What's happening in proximal convoluted tubule? Bicarb is lost in the urine, resulting in acidosis. In type 4 and collecting duct also, H plus is not secreted. So this is the difference between type 1, type 2 and type 4. Type 1 and type 2 will have hypokalemia. But type 4 will be having hyperkalemia. Along with H plus, potassium is also not secreted, right? So these are the presentations of type 1, type 2 and type 4 renal tubular acidosis. So whenever a patient comes with metabolic acidosis, normal anion gap with hypokalemia, suspect type 1 or type 2. Type 1 renal tubular acidosis most commonly seen in myelomas. Type 2 is most commonly seen in Sjogren's. So now let's go into differences, detailed differences between these three things. So what will happen to the urine pH in proximal RTA? Because in proximal RTA, bicarb is lost in the urine pH will be more than 5.5. In distal RTA, it's more than 5.5. In type 4 RTA also. But in distal RTA, it's more severe. Even though in body there is acidosis, your urine will be acidic. That is less than 5.5. And urinary anion gap will be positive and urinary ammonia will increase in all these conditions. Coming to fractional bicarb excretion, it is very high in distal RTA. I'm extremely sorry. It's high in proximal RTA because proximal RTA is because of bicarb loss in the urine. Other two are because of decreased H plus secretion. I think you are getting me. Here it's slightly. What's happening to potassium? In these two conditions, it's hypokalemia. Here it is hyperkalemia. Coming to urinary calcium, especially in distal RTA, your urinary calcium is increased. Hypercalciuria. So there is deposition of calcium in your kidneys. Because calcium is lost in the urine, there is bone disease also. That is seen in distal artery. Whereas your proximal artery, in proximal artery, your glucose, amino acid, phosphate, vitamin D, bicarb, all these things are absorbed. So when proximal artery is damaged, bicarb is lost in the urine. Along with that, there is amino aciduria, glycosuria, vitamin D in the urine, and phosphaturia. All these things are lost in the urine. So other tubular defects are also present in proximal renal tubular acidosis, that is called Fanconi's anemia. Whereas those things are absent in these things. So this is about the last minute table for proximal, distal and type 4 RTA. This table before going to exam you should revise once because you know the concept behind it, and I have not detailedly explained the concept in the previous PYQ video. I have explained it in detail, you can see there. So this table is very important. Now let's move on to the other system in CVS. So in CVS, your pulse, JVP, ECG, pericardial diseases, and your arrhythmias, which will be asked as ECGs. These are the most important parts where your questions will be asked. That too, in arrhythmia, they will mostly ask you to identify the ECG, or they'll give in correlation with JVP or pulse. All found in left ventricular failure except. So your LV is failing. What are the things that is found? Lung oligemia. Why? Oligemia is decreased appearance of blood vessels in the lung. So when your LV is failing, there is more back pressure, more congestion in the pulmonary vessels. So your pulmonary vessels should be prominent, right? Why it should be oligemia? No, that is not possible. Your lung oligemia is seen in where there is decreased blood flow through the pulmonary circulation, or when there is pulmonary artery thromboembolism. When there is thrombus in the pulmonary artery, then there can be focal oligemia in the lungs. Those are the only possibilities where you can see lung oligemia, decreased pulmonary blood flow. Coming to Kerley B lines, yes, they are specific to left ventricular failure, which can see on X-ray. We'll see what are those. Rails, yes. Rails are nothing but crepitations. So whenever you take a glass of water with water and you take a straw and just blow into that, you will be seeing some bubbling sounds, right? So same way you will be hearing the crepitations. Those are called rails. So these rails or crepitations can be fine creps or coarse creps. These fine creps are many and short duration. You can hear many sounds which are short lived, and it is high pitch. Whereas coarse creps are low pitch, few sounds, longer duration sounds. So coarse creps you will hear whenever there is increased secretions in your larger airways. For suppose there is bronchiectasis, you can hear coarse creps. Fine creps you will hear whenever there is fluid in the alveoli, distal airways, especially your pulmonary edema. You can hear fine creps. And one more example of your fine creps is velcro creps. These are heard in ILD, in interstitial lung disease. While you are inspiring, the small airways will pop up or open up. That will result in velcro creps. So inspiratory creps you can hear. That is velcro creps in ILD. That is about rails. So yes, rails are possible in pulmonary edema due to left ventricular failure. Now coming to pedal edema. Yes, in right heart failure you can see pedal edema, right? So in left heart failure, ultimately resulting in right heart failure, and pedal edema is also a finding in LVF, but definitely lung oligemia, it's not there. But if you remove lung oligemia and in these three options you want me to select LV failure, the exception would be pedal edema, because pedal edema is the complication of right ventricular failure. So whenever you think of LVF, you should think there should be S3, S4 gallop rhythm, and there can be, yes, spine creps because of the pulmonary edema. These are the findings, whereas the patient will present to you with orthopnea and PND. Orthopnea, paroxysmal nocturnal dyspnea. Orthopnea is immediately after supine position, SOB. Paroxysmal nocturnal dyspnea is patient is going into the sleep. After 2 hours of sleep, he will wake up in the midnight, go to a window or fan for air hunger, and after half an hour it will subside. So orthopnea is immediately it will come, immediately it will relieve. Supine it will come, if you sit in the sitting position, it will go. Whereas PND, paroxysmal nocturnal dyspnea, after sleep, 2 hours of sleep it will come, it will stay for at least half an hour and then go. And PND is more specific for left heart failure. Orthopnea is more sensitive for left heart failure. So these are the things you should know about left ventricular failure. And in X-ray, you can see pulmonary edema and curly lines. What are the curly lines? Curly lines. There are three types of curly lines, A, B and C. Curly line A is because of the lymphatics which is connecting the peripheral to the central. C, for suppose there is pulmonary edema in the lung, that should be cleared. Pulmonary edema is nothing but fluid in the alveoli. That will be cleared by the lymphatics. More lymphatics in the periphery. It will be started clearing from the periphery to the central. That's the reason you can see batwing appearance sometimes in the pulmonary edema. So curly A lines are nothing but that lymphatic connection between the peripheral and central lymphatics. What are curly B lines? Curly B lines are thickened interlobular septae. See, this thickened interlobular septae. You can see it clearly here. It's thickened interlobular septae. Whereas curly C are also a type of B lines. See here also you can see curly C lines. There are also a type of B lines which do not attach to pleura. So C is not that important. Concentrate on A and B. Are the lines which will connect between central and peripheral lymphatics, and B is nothing but thickened interlobular septa. These are A and this is B line. And B is specific to left ventricular failure. So in heart failure, the drugs are very important. Which drugs will affect the mortality, which are not going to affect the mortality, or the newer drugs, that those things they will be asking you. So to remember the drugs in heart failure, you don't have to by heart whole group of classification. You should know the pathophysiology. So I'll tell you in a brief what's happening in the heart failure when LV is not contracting and the cardiac output is not efficient. There are few compensatory systems which will be activating. So one among them is sympathetic nervous system, your renin angiotensin system, and your natriuretic system. So your natriuretic system will result in sodium and water diuresis. So that is useful. This is good. Whereas your sympathetic and RAS system is causing more vasoconstriction, more decrease in cardiac output, which are bad. So the drugs should inhibit sympathetic and RAS and should promote natriuretic system. So to block the sympathetic nervous system, we are giving beta blockers. And the drugs blocking the RAS system are your AC inhibitors, ARBs, and your mineral receptor antagonists, that is your spirulolactone. And acting on the natriuretic system are your ARNIs. That is, it's both ARB plus nephrilizin inhibitor. And the example for this is sacubitril valsartan. We'll give that together. So these are the drugs which are acting on the exact pathophysiology of the heart failure. So why am I giving nephrilizin inhibitor is nephrilizin is an enzyme that will cause degradation of your natriuretic peptide. So that's why I'm inhibiting that enzyme so that there is natriuretic peptide for longer periods in your blood. So beta blockers, ACs, ARBs, MRAs and ARNIs, these are all the drugs which will have the mortality benefit in heart failure. So you got me right, the drugs which are acting on the pathophysiology have mortality benefit. So whenever there is acute heart failure, to decrease the fluid overload, we will give loop diuretics. And that is just symptomatic, it's not acting on the pathophysiology, so it has no mortality benefit. Whereas your potassium sparing diuretics will be acting on the mineralocorticoid, that is aldosterone is the ultimate product of your RAS, right? And your mineralocorticoid receptor antagonists are antagonizing aldosterone. So your spironolactone will be mortality benefit or disease modifying drug in heart failure. So loop diuretics are not mortality benefit and your potassium sparing diuretics have mortality benefit in heart failure. That thing you remember. And coming to the newer drugs are riociguat and omecamtiv mecarbil. Riociguat is guanyl cyclase stimulator. Whereas omecamtiv mecarbil is direct myosin stimulator or activator. So by acting on the guanyl cyclase, it is causing vasodilatation. So there is decreased afterload and preload. Ultimately, the left heart will function better. And omecamtiv mecarbil is direct myosin activator. It will activate the myosin filaments of your cardiac muscle, so more force of contraction. Inotrope effect. So these are the newer drugs you have to remember. So this is about the drugs for heart failure. So it's very easy, right, if you remember it in this way. Otherwise, if you have to by heart what are the drugs, okay, they are beta blockers, they are AC inhibitors, they are ARBs, and you won't remember also. So any drugs you are learning in medicine, especially, first know the pathophysiology. Then the targets you can easily match. You don't have to by heart. Okay, let's take up the next question. It's a young male going for some dental procedure. He's asking whether he requires prophylaxis for infective endocarditis. So, which cardiac conditions, while undergoing dental procedures, have to take infective endocarditis prophylaxis? That is given by our ACA guidelines. So, any patient with a prosthetic valve, any type of valve has to take infective endocarditis prophylaxis. Or any patient who had previously infective endocarditis and any cyanotic congenital heart disease, which is either repaired or unrepaired cyanotic congenital heart disease, previous episode of infective endocarditis, and prosthetic valve. So I'm speaking about repaired and unrepaired, right? If it is repaired completely, it's fine. It's incompletely repaired, or even after repairing, there is some residual, you have to give infective endocarditis prophylaxis. So any prosthetic valve, history of infective endocarditis, unrepaired or partially repaired or repaired with residual cyanotic congenital heart disease, you have to go for infective endocarditis prophylaxis. So these three, they need prophylaxis. ASD has a zero risk of infective endocarditis because there is no high to low flow regions. ASD is zero risk of infective endocarditis. That is also can be a question. Okay, now you have identified the group of patients who need infective endocarditis prophylaxis. What antibiotic you will give, for how many days, how many doses you will be giving, and how much prior to the intervention you should give. That is also explained by ACA. So you can just give oral amoxicillin. Just 2 grams, just 1 hour before the procedure. 1 hour before the procedure, you have to take the patient 2-gram amoxicillin tablet. Done. That is the prophylaxis. But the problem comes is, if he is not taking orally, give IV. Give IV ampicillin. Next problem comes is, he is allergic to penicillin. Then you can give clindamycin or azithro or clarithromycin. Just 1 hour before the procedure. If it is oral, 1 hour. IV, 30 minutes. That's the timing. So in the patients who need infective endocarditis prophylaxis, that is prosthetic valve or previous history of infective endocarditis or cyanotic congenital heart disease, you are doing some dental procedures. If I'm giving IV, I'll give 30 minutes before. If I will give oral antibiotic, I'll give 1 hour before. The best to choose in is oral amoxicillin tablet, 2 grams to 1 hour before the procedure. But if he cannot take orally, I'll give IV half an hour before. If he's allergic to penicillin, I'll give either clindamycin or clarithromycin tablet just 1 hour before the procedure. That's it. Just single tablet is enough. So this is the prophylaxis of infective endocarditis. Very important. So you should know whom should be given, what should be given. These things we have discussed. Now coming to infective endocarditis, how do you diagnose infective endocarditis? This modified Duke's criteria is also important. Major criteria and minor criteria. Two major criteria and 5 minor criteria. So the major criteria is, first thing is cultures and imaging. Minor criteria we'll see later. And coming to cultures, the major criteria, if they are typical organisms, I need at least 2 cultures. 2 cultures positive or persistent cultures positive. If it is atypical like Coxiella burnetii, then okay, 1 culture is also I'm satisfied. Or for me, if IgG titers are also increased, more than 1:800, I'm satisfied. Okay, this is coming into major criteria. Now coming to imaging, previously we learned only about 2D echo, right? But nowadays they are including PET-CT, SPECT and also surgical. findings into this imaging. So in 2D echo, there is dehiscence of prosthetic valve, or there is paravalvular abscess or new regurgitant murmurs. You'll think it as infective endocarditis if there are vegetations also. In PET-CT, there is dehiscence of prosthetic valve with increased uptake, the same thing in SPECT. And in surgically, you have performed some open heart surgery and you have seen vegetations with destruction of valvular apparatus. You have seen it with your eyes, so it's definitely infective endocarditis. So this is about major criteria. Now coming to minor criteria, the patient should be having some predisposing conditions like a prosthetic valve or IV drug abuse. Next thing is history of infective endocarditis is also a risk factor for infective endocarditis. Next is the immunological phenomenon and vascular phenomenon. Next comes fever. Fever more than 36.5 degrees Celsius. And the most important thing is the cultures are present, but it's not satisfying the major criteria. Now let's look into immunological phenomena and vascular phenomena. Coming to immunological phenomena, it is Osler's nodes. Osler's nodes are seen on the tips, painful. Janeway lesions are seen on the palm, non-painful. Osler's nodes, glomerulonephritis presenting with hematuria, RA factor positive, and in your retina, presence of rod spots. All these are immunological phenomena. Coming to vascular phenomena, you have to prove it by some imaging. For suppose septic emboli, infarcts, those emboli and infarcts you should prove on some imaging. And hemorrhages. These hemorrhages can be anywhere, intracranial or splinter hemorrhages or retinal hemorrhages. Those are vascular phenomena. Fever. So these are the major and minor criteria. I am speaking about the newer modified Duke's criteria which has come in your 2023. I've added all those things. So one major is enough for me. Sorry, two major is enough for me. Cultures positive with the findings in that ODECO is enough. If it's one major, it should be supported by 3 minor. No major, 5 minor criteria should be there. Any of these things, we will diagnose infective endocarditis based on the Duke's criteria, modified Duke's criteria 2023. So before taking on the next question, we'll take a short break. Okay, let's continue. The next question, hemodynamically unstable patient with supraventricular tachycardia, what should you do? So we know any patient of arrhythmia in shock, the only treatment is shock. The patient is in shock, hypotensive shock, you have to give DC shock. You have to go for cardioversion. So rather than cardioversion or defibrillation, which is the best term? What is the difference between cardioversion versus defibrillation? See, cardioversion, we will be giving synchronous shocks. Whenever there is QRS complex, we will be giving shock. It is synchronous with QRS. Whereas defibrillation, we are not bothered about QRS, we will just shock the patient. And the cardioversion is an elective procedure. The patient is perfectly fine. We'll sedate the patient and plan it as an elective procedure. Whereas defibrillation, the patient is in cardiac arrest. He's unconscious. So it's an emergency procedure. And the patient is in cardiac arrest. Here the patient is stable. So a stable patient with arrhythmia, you're sedating him and shocking him with synchronous QRS complexes, that is cardioversion. A patient of cardiac arrest, you're just shocking him without looking into any QRS complex, without any sedation, which is an emergency procedure, that is defibrillation. That's the difference. Here the patient is hemodynamically unstable, but definitely not in shock, right? Or not in cardiac arrest, right? So cardioversion is the best term. Because he is unstable, we have given cardioversion. But if he is stable, the drug of choice for supraventricular tachycardia is adenosine. It's not there here. We'll give adenosine for 3 times. 5 mg, 5 mg and 5 mg injections bolus will be giving. After 3 times also he is not responding, then we'll stop giving adenosine. We'll go for beta blocker or calcium channel blocker. So this is second line. Adenosine is the drug of choice. So adenosine is very short acting. We'll give it like a bolus, and after that also we'll give you IV NS infusion, so that the adenosine is going fast into the circulation. Whichever limb we are giving adenosine, that will be kept like this, so that it should go fast into the circulation. So he gave it as supraventricular tachycardia. How are you going to identify whether it's supraventricular or ventricular tachycardia? Whenever you are looking into a tachyarrhythmia, you think this ECG is having some tachyarrhythmia, what are the things you should see? You should see whether the QRS is prolonged or normal. Prolonged is more than 120 milliseconds, that is more than 3 small boxes. It's narrow or wide QRS complex. The second thing is whether the rhythm is regular or irregular. Next thing is the P wave. Is it absent, present, same morphology, different morphology? You should look at the P wave. So any tachyarrhythmia, what are the 3 things I told you? QRS, is it regular or not? And the P wave. First thing, based on the QRS. What do you think if it's a narrow QRS tachycardia or wide QRS? See, narrow QRS means the impulse to the ventricle. QRS is nothing but ventricular depolarization. The impulse to the ventricle is coming from above the AV node. So it's a sinus rhythm and it's a supraventricular tachycardia. If the QRS is wide, then the impulse is coming from within the ventricle, some ventricular ectopic. So it's ventricular tachycardia. So based on the QRS, you have differentiated whether it's supraventricular origin or ventricular origin. In supraventricular origin, you will be looking into the irregularity. If it is irregular, what do you think? Supraventricular tachycardia with irregular pulse or irregular RR intervals. So when it is irregular, the first thing that comes to your mind is atrial fibrillation. Next thing is multifocal atrial tachycardia. Or your atrial flutter with variable AV block. Only these three things, and clinically AF is most common. And if it is regular, it can be anything. It is just sinus tachycardia or atrial ectopics resulting in atrial tachycardia or your atrial flutter. So paroxysmal supraventricular tachycardia, which can be AV nodal reentry or atrioventricular reentry tachycardia. Okay, now let's go to the P wave. In atrial fibrillation, in fact, the P wave is absent, but there is fibrillatory wave. In multifocal atrial tachycardia, the name itself says it's multifocal, and the morphology of P waves are more than three. There are more than three types of P waves in the ECG. And in atrial flutter, P waves are present. In fact, they are sawtooth P waves. So just based on the QRS duration, the regularity, and the P wave morphology, we have differentiated the different types of supraventricular tachycardia. So if it's narrow complex, wide complex, it's ventricular tachycardia. It can be VT or ventricular ectopics or VT or ventricular fibrillation or ventricular flutter. Anything can be there. So most of the ventricular tachycardias patient will be very bad. They'll be in cardiac arrest. Whereas supraventricular tachycardia patient will be good only. They can be in, they can have the symptoms of palpitations or they can be hemodynamically unstable. So this is the approach to tachyarrhythmias. So in exam, they have given you a ECG which is showing tachyarrhythmia. First, you have to look at the QRS, narrow QRS or broad QRS. You have to look at the P wave. You have to look at the regularity. Based on that, you have to differentiate which type of arrhythmia it is. Whatever it is, if it is in shock, you have to give shock. That one you should not forget because it's most commonly asked. This approach is important. This shock is also important. Give me 1 second. Okay. So look at this ECG. Is it broad or narrow complex? Calculate the QRS duration. It's not even one box. So it's one box, it's 40 to 60 milliseconds it is. So it's definitely narrow. And there is tachyarrhythmia. Some tachyarrhythmia is going on here. And it is regular. P waves. See, the P waves are superimposed on the T waves. There's no differentiation between P and T. When the P waves are superimposed on the T waves, most commonly it is EVNRT, which is a type of supraventricular tachycardia. The first thing you have to do is give adenosine if the patient responds. to adenosine, it's okay. Otherwise, you can go and give beta blockers or calcium channel blockers. If the patient is in shock, shock the patient. And one more important thing is, a patient with supraventricular tachycardia, he will present with palpitations and post-palpitation diuresis. Why there is post-palpitation diuresis? Immediately after palpitations, why patient is having diuresis? Because this palpitations is because of some arrhythmia, there is some tachycardia. So there is stress in your ventricle and atrial wall. So there is release of atrial natriuretic peptide. Your atrial natriuretic peptide will stimulate more natriuresis and diuresis, ultimately resulting in post-palpitation diuresis. So ANP is most important for that. They can ask you a question based on that. So next question. A young female with pedal edema and fatigue. Okay, there is pedal edema. JVP is elevated with prominent A waves. S1 is loud. And you can hear mid-diastolic murmur in the mitral area. What is the diagnosis? We have diagnosed it. So young female with right heart failure. S1 is loud with MDM murmur. And JVP is elevated with A waves prominent. It is nothing but MS. In MR, you can hear pansystolic murmur with S1 is soft. AR, ejection sorry, it's also a early diastolic murmur. Tricuspid stenosis is also a mid diastolic murmur. It will also present with right heart failure. It will also have prominent A waves. But this mid-diastolic murmur is in the tricuspid area. Here we are having in the mitral area. That is why it's mitral stenosis. Now, coming to JVP. The JVP waves and abnormalities in few conditions is very important. At least one question he will ask. So the two positive waves are A and C. Prominent positive waves. Sorry, A and V. And the two prominent negative waves are X and Y. Now let's look at the correlation with the cardiac cycle. So we'll come from diastole to systole. Your Y is because of ventricular relaxation. When your ventricle is relaxing, your atria is, the blood in the atria is emptying into the ventricle. I'm not saying atria is contracting. When ventricle is really relaxing, the blood in the atria will come into the ventricle. That is called ventricular filling or atrial emptying. This is the first phase of diastole, in which because of ventricular relaxation, the blood from atria will come into the ventricle. And the last phase is atrial systole. Because of the atrial contraction, the blood will come from the atria to the ventricle, and that is the last 1/3, and it is the result of A wave. It is atrial systole. So this is in the diastole. This also in the diastole. This is early diastole. This is late diastole. So now you can see the other two waves are in the systole. Why there is X wave? It's due to atrial relaxation. Why there is V wave? There is venous emptying. The blood in the vena, superior vena cava and inferior vena cava, are being emptied into the right atrium or left atrium. So left atrium, the blood from the pulmonary veins. So the thing is, JVP, we are speaking about the right atrium. So everything is about the right atrium. Venous emptying. So A is atrial systole, X is atrial relaxation, V is venous emptying, and Y is atrial emptying. So these are easy to remember relation to cardiac cycle. And which is coming in diastole, which is coming in systole, it's also easy to remember. Y is due to ventricular relaxation and A is due to atrial contraction. These two are happening in the diastole, other two in the systole. And coming to abnormalities. Coming to A wave, there are two things: giant A wave, canon A wave, and absent A wave. Absent A wave is seen in atrial fibrillation. Canon A waves are seen in atria contracting against the closed tricuspid. Everything is important. Statements are also important. And it is seen in AV dissociation. When atria is contracting separately and ventricle is contracting separately, only then there is AV dissociation, which is seen in third degree AV block and VT. And giant A waves, see, A wave is due to atrial contraction. When atria is contracting, the blood from the atria should go into the right ventricle and then into the pulmonary circulation. Any obstruction to that flow, the A wave will be giant. So it is seen in right atrial myxoma, any problem in the right atrium, or any problem with the tricuspid valve stenosis, anything with the right ventricular failure, and pulmonary valve, anything with the pulmonary stenosis, and the pulmonary artery hypertension. Anything obstructing the pathway, there can be giant A waves. The same thing with MS in this case. Prominent or giant A waves, canon or very big A waves. Coming to the X wave. This X wave is prominent in cardiac tamponade and constrictive pericarditis. Whereas X wave is absent in tricuspid regurgitation. In your tricuspid regurgitation, your X wave is absent, because X wave is atrial relaxation. But when there is tricuspid regurgitation, the blood from the right ventricle is constantly being added to the right atrium. There won't be relaxation of right atrium, right? Next, coming to V wave. The Y wave is more important. We'll see about Y wave first. Y wave is prominent in and absent in. Y wave is absent in cardiac tamponade because there is no diastole. The heart is being compressed from all the directions, so there is no diastole, no Y wave. Whereas in constrictive pericarditis, the Y wave is prominent because the early diastole is intact, the late and mid diastole is affected. The whole of the filling occurs in the early diastole, resulting in prominent Y wave. And prominent V wave is seen in tricuspid regurgitation. So in tricuspid regurgitation, after A, there is C wave, absent X wave, and directly there will be V wave. You got me? In tricuspid regurgitation, V wave is prominent and X wave is absent. That's what I told you, right? So X wave is absent and directly there will be V wave. So this is called CV wave in tricuspid regurgitation. So in tricuspid regurgitation, there is CV wave. In constrictive pericarditis, there is prominent X and Y wave. In cardiac tamponade, there is prominent X wave but absent Y wave. These are very important. So in constrictive pericarditis, because the X wave and Y wave are prominent, it's giving a W sign, which is called as Frederick's sign. So this is about JBP. This table, these two tables should be on your tips. To understand this, you have to know the basic physiology behind why each wave is and in which pathology which is happening. Because if you are not getting clarity in these topics, in exam it will confuse you more. If you're 1% confused, that will exaggerate as 100% in the exam. So even 1% confusion is not allowed. We want 100% clarity in these topics. So revise and revise until you get that clarity. And do MCQs. You will understand where your clarity is missing. So this is about JVP. This is what we have spoken about MS. Next question. Elderly male on diuretics came with weakness. ABG is showing metabolic acidosis. ECG is showing flat T waves and prominent U waves. What is the mostly like diagnosis? See, elderly male on diuretics, enough for me, came with weakness and ECG changes. What are the ECG changes? Flat T waves and prominent U waves. This is nothing but hypokalemia. Especially your loop diuretics will cause hypokalemia. Even thiazide diuretics also, but it's mostly seen in loop diuretics. So we are dealing with hypokalemia. So how does hypokalemia presents? It's basically presents with skeletal muscle and smooth muscle weakness. Skeletal muscle weakness, the patient will present with quadriparesis. Whereas smooth muscle weakness, he can have paralytic ileus. It's one of the non-dynamic type of intestinal obstruction. So if you treat potassium, these symptoms will improve. That's it. And ECG will have flat T waves, prominent U waves. It's okay, but it can land into tachyarrhythmias and cardiac arrest. That is the reason you should treat hypokalemia. Okay, that weakness is not life-threatening, but your cardiac or ECG changes is life-threatening. You should not allow that. Now let's look at the ECG changes. Do you think there are any ECG changes in hyponatremia and hypernatremia? No. They are all CNS manifestations. Hyper or hyponatremia is a CNS manifestation. Next, coming to hypokalemia. In hypokalemia, what is happening to the P wave? P wave is tall. What's happening to your T wave? T wave is flat or inverted. And there is an extra wave, that is U wave. So after T wave, there is one more deflection, that is called U wave. What's happening to QT interval? It's increased. Ultimately, what's happening? Patient will develop tachyarrhythmias. Let's go to hyperkalemia. In hyperkalemia, what's happening to the P wave? It's flattened. What's happening to the PR interval? It's prolonged. So hyperkalemia, initially it will be like this, T wave is tall. Later it will be like this, P wave is shortened, PR is prolonged, T initially will be tall. So initially it will be like this, later it will be like this. It's called pull effect. First it will be pull like this, next it will be pull like this. So PR is prolonged. What's happening to the T wave? It's tall, peaked T wave. What's happening to the QT? It's prolonged. What's happening to ST? It's depressed. Ultimately resulting in bradyarrhythmias. See, hypokalemia, tachyarrhythmias. Hyperkalemia, bradyarrhythmias. And then the sine wave pattern. Next, arrest. So what is the sine wave pattern? The ECG will be just like this waves. Sine wave pattern. So I have never seen sine wave pattern patient going into that much hyperkalemia. Only once I have seen a case of CKD on dialysis have been referred from other hospital to our hospital, and the ECG is showing sine wave pattern, and her potassium was almost 8. They have done dialysis, but still it's 8 because there is bradyarrhythmias. They have put her on pacemaker. See, this is metabolic pacemaker. It's not necessary. They have to treat potassium. Anyways, I have seen her in a casualty emergency. By the time we have acted, we have given calcium gluconate, we have given nebulization, everything, but she ultimately landed in arrest. So that was very severe hyperkalemia, and we could not save her because the treatment was delayed. So whoever who have seen that could have started hyperkalemia management instead of putting her on the pacemaker for bradyarrhythmia. That is why you should know the causes of everything. Bradyarrhythmia should not be very narrow. If there are blocks, AV block or any bradyarrhythmias, will put pacemaker. Okay, if it's tachycardia, we'll give the drugs which are doing AV blockade. No, first you should look at all the causes, rule out everything. Only then you come to some conclusion and treat the case. That is why we are learning all these things. Okay, that is the only ones I have seen sine wave pattern in my life. Most of the times tall T waves only we will be identifying it, especially CKD cases or AKA cases with tall T waves. We are very worried about that. We will immediately start potassium correction or we'll take the patient to dialysis if the potassium is high. Okay, next comes the hypocalcemia. Now about calcium. So calcium is all about QT. If there is hypocalcemia, it's QT shortening. It's hypercalcemia, it is QT prolonged. QT is prolonged. So in hypercalcemia, you can also see Osborne waves. And hypomagnesemia, it's similar to hypocalcemia. Hypermagnesemia is also similar to hypercalcemia. So if calcium is low, we'll give calcium supplement. If magnesium is low, we'll give magnesium supplement. If there are more, we'll look at the cause and treat the cause. If potassium is low, we'll give potassium correction. If potassium is high, we already discussed the treatment of hyperkalemia. So these are the ECG changes of electrolyte imbalances, and this is also very important. One probable question from this. Next question. Elderly male, known case of coronary artery disease, came to EMD, so something is emergency. Chest pain and palpitations. So palpitations means some arrhythmia is a probability. They have given the ECG. What is the best drug for the management? They are asking. What is the ECG showing? So this is definitely a tachyarrhythmia. Is it broad or narrow QRS? So the only thing you can see here is the QRS, and it's very broad. See, it's very broad. Where does lead to? It's almost like 6 small boxes. I told you more than 3 small boxes, it's broad, right? So it's broad QRS complex tachycardia. So it's ventricular origin, and this is ventricular tachycardia. That too monomorphic. All the QRS complexes are looking the same, so it's monomorphic. If they are looking different, it's called polymorphic. And the most common cause of monomorphic VT is MI, or a history of MI. Ischemic cardiomyopathy is the most common cause. Anyways, you have to rule out electrolyte imbalances also, like your hypokalemia or hypocalcemias. And the best drug would be antiarrhythmic agent, that to IV amiodarone. So if this patient is in shock, we have to shock the patient. Mostly this patient would have been in shock. By luck, he's not in shock. That's why he's not mentioned in shock. If he's not in shock, initially we'll give IV amiodarone. Once the rhythm is reverted and the patient is stable, we will shift on him on oral amiodarone. On oral amiodarone, we are going to discharge the patient. And while giving amiodarone, you have to look for the pulmonary function test, thyroid function test. You have to look at the liver enzymes, because pulmotoxicity, thyrotoxicity, and liver toxicity are the important side effects of your amiodarone. One important thing is, according to Vaughan-Williams classification of antiarrhythmic drugs, this amiodarone belongs to class C, but it is broad spectrum. It has sodium potassium channel blocking, beta blocker effect, and also, yeah, it's a broad spectrum antiarrhythmic, although it's class C. Next question. A case of RTA. Okay, this thing we know. RTA with rib fractures came with hypotension, distended veins in the neck, and the heart sounds are muffled. So it is cardiac tamponade. See, other things are not important. Bilateral air entry is good. He is excluding pneumothorax. What are the important key points you have to pick up and take the diagnosis? It is cardiac tamponade. What is the immediate intervention you have to do? The fluid. Here, the blood around the heart is compressing the heart. So there is obstructive shock. Immediately, you have to remove that fluid. You have to go for urgent pericardial tap. If it is pneumothorax, we have gone for ICD insertion. So coming to the cardiac tamponade, you know that Beck's triad patient is in hypotension with muffled heart sounds and dilated neck veins. That is how the patient is going to present. Next, look at the important things in cardiac tamponade. How is the X-ray? It is money bag appearance. See, this could have been the cardiac silhouette. It's the money bag appearance. Here there is fluid. As if because of gravity, if you put money in the bag, more of the money will be accumulating in the bottom, so it's giving like a money bag appearance. Here also it's because of fluid, it's giving money bag appearance. Next, if you have done 2D echo, see, this is the pericardial space which is increased and filled with effusion, and in that fluid your heart will be dancing like this. Because it's dancing, if you take the ECG, if the heart is coming near to the chest wall, there will be high amplitude voltage, and if it's going back from the chest wall, there will be low amplitude voltage, resulting in electrical alternates. One is high, one is low. So this is electrical alternates. Low voltage complexes with electrical alternates. Your 2D echo is showing pericardial effusion and money bag appearance. And one more thing in the 2D echo, if there is fluid around the heart, you can say it's pericardial effusion. But how do you say there is cardiac tamponade? There is diastolic failure. There is diastolic, the left ventricle won't be relaxing. If there is diastolic RV compression, we will diagnose it as cardiac tamponade. And what is the JVP? It's prominent X wave and absent Y wave. We have discussed Y. So the Y wave is absent, X wave is prominent. Treatment, pericardiocentesis. That's it. Next question. A patient with a history of COPD is undergoing right heart catheterization for evaluation of PH. Okay, they're doing a great thing. Pulmonary artery hypertension. See, the terminology is pulmonary hypertension. For pulmonary hypertension evaluation, they are going for right heart catheterization. And what is the mean pulmonary artery pressure above which pulmonary hypertension is made? So to call it as pulmonary hypertension, how much should be the pressure? It should be above 20 mm of Hg. So this is how we'll be doing the right heart catheterization. From right heart, we'll be going through the right ventricle, pulmonary artery and into the pulmonary capillary, and we will measure the pressure there in the pulmonary artery and pulmonary capillary wedge pressure. See, whenever there is pulmonary hypertension, that is diagnosed by pulmonary artery pressure more than 20 mm of Hg. Next, I will be looking at pulmonary capillary wedge pressure. If the pulmonary capillary wedge pressure is more than 15, then it is because of left heart failure, and it is called type 2 PH. If the PCWP is less than 15, it's precapillary. This is postcapillary. It's precapillary, and it can be type 1. Type 1 is called pulmonary artery hypertension because it's idiopathic or due to some mutations. BMPR2 mutations, it can be seen. It's called pulmonary artery hypertension. See, this is pulmonary hypertension, this is pulmonary artery hypertension. If you are saying it's pulmonary artery hypertension, then that is idiopathic. So here the terminology is wrong. It's just pulmonary hypertension. Type 2 we already know. Next, type 3 is because of lung disease. Type 4 is because of chronic PT. Type 5 is because of some miscellaneous causes. Type 3 is chronic lung disease. This is the classification of pulmonary artery hypertension. And right heart catheterization plays an important role. If pulmonary artery pressure more than 20, we diagnose it as pulmonary hypertension. And if PCWP is more than 50, we diagnose it as left heart failure. So this is how you diagnose pulmonary artery hypertension. How are you going to treat? So basically it's hypertension. We have to give vasodilators. And what vasodilators you can give? PDE5 inhibitors, sildenafil, tadalafil. And your endothelin receptor antagonist. Ambrisenton and bosenton. So the drugs are important. The drugs and the mechanism of actions. Prostaglandin analogs. Iloprost and epoprostinol. These drugs can be used, and the newer drugs are Riocuguat. We have discussed this in heart failure. It is guanylyl cyclase stimulator. So these are the drugs you can use in pulmonary artery hypertension or pulmonary hypertension. So most of the times we'll be using combination of PDE5 inhibitors and endothelin receptor antagonists, that is tadalafil plus ambrisentan. This combination is already available. If it is very severe, these are parenteral. So if it's very severe, we can give prostaglandin analogs. And this is the newer drug. So in this question, they have given COPD. Why COPD is having pulmonary artery hypertension? I told you chronic lung disease type 3 can have type 3 pulmonary artery hypertension, and it will be presenting with right heart failure. So when do you suspect? When there is right heart failure. How do you diagnose? The best way to diagnose is the catheterization, pulmonary artery catheterization. How do you treat? You give vasodilators. And you have to treat the cause also. That's why we are evaluating. Okay, now we are done with the respiratory system. Let's move on with the infectious diseases. A patient of retrovirus positive, he was started on highly active antiretroviral therapy. What should you monitor? I will monitor the viral load, because if it's responding to the treatment, the viral load will decrease and ultimately become zero. I will also monitor the CD4 count. CD4 count should improve, but my main goal is viral load should decrease. So P24 antigen is also present on the HIV virus wall, but you are not using that to monitor. And it is absent in window period also. You cannot use that to diagnose. So this picture is showing P24 capsid protein. It's present, but you cannot use that. We are directly worried about the viral load. And this GP120 is going to attach to the CD4 cells, CD4 receptor. Ultimately, this will attach to the CD4 cells and the CD4 cells are killed. That is why CD4 count will be low if viral load is high. They are inversely proportional, but we will be monitoring viral load. Okay, coming to the antiretroviral drugs. You should know the life cycle of the HIV virus. The first step is binding. The binding will happen through CCR5. CCR5 is a co-receptor. The main receptor is CD4 and GP120. But the CCR5 is a co-receptor. And the CCR5 agonist we are using is Maraviroc. And the post-attachment inhibitors, they are recently developed, still not available. Coming to fusion inhibitors, which will inhibit the fusion of the viral wall with the host cell wall, and those inhibitors are enfuvirtide. And the next step is the production of the nuclear material by reverse transcription, and that can be inhibited by NNRTIs and NRTIs. Your non-nucleoside are efavirenz, nevirapine, and your NRTIs are your abacavir, tenofovir, lamivudine. And the next important step is integration. So HIV DNA will integrate into the host DNA. That will be inhibited by integrase inhibitors. And the important example for that is dolutegravir. Next, after integration, there will be transcription and production of a protein. That protein will break and form the viral elements. And for that breaking, you need protease. And we will be using protease inhibitors. What are the protease inhibitors? Lopinavir, indonavir, atazanavir, ritonavir, anything with navir. So these are the drug targets for HIV, anti-HIV drugs. So if you directly by heart fusion inhibitors and tree inhibitors, you may be forgetting. So just learn in this order so that it's easy for you to remember. So in the present generation, the first line we'll be using is two NRTIs plus one integrase inhibitor we are using, that is TLD, tenofovir, lamivudine and dolutegravir. This TLD regimen is the first line for all HIV cases. It is like test and treat. You test, it's positive, you treat. You're not bothered about the CD4 count. But before starting treatment, one thing you have to be careful is about IRIS. What is IRIS? Immune reconstitution inflammatory syndrome. Why there is IRIS? See, when there is immune reconstitution, you started an anti-HIV drug, so your viral load is decreasing, your CD4 count is increasing. So CD4 count is increasing means your immune system is coming up, immune reconstitution. Because the immune cells are coming up, if there is some infection, there will be a bad inflammatory reaction. So before starting ART, just make sure the patient is not having any uh, opportunistic infections. See, our infection profile is different. We are immunocompetent, but immunocompromised, the infectious profile is completely different and they're more prone for opportunistic infections. For example, take TB. If HIV and TB is coexistent, you're not treating TB and giving ART, there will be, the inflammatory cells will come up and give a bad inflammatory reaction to the TB and the TB will flare up. So first TB, control TB, 2 weeks you give ATT, and once you think it's in control, then start ART. Starting of ART is not an emergency, first rule out infection. So how do you diagnose it is whether IRIS or the disease is progressing? So you have started ART, viral load is decreasing, CD4 count is increasing. Now there is some inflammatory reaction to the infectious organism, that is IRIS. But even after ART, your viral load is increasing but CD4 count is decreasing, then that could be a new opportunistic infection. And why should you identify it as IRIS? Because the treatment for IRIS is steroids. Okay, if you think it's IRIS, you should give steroids, only then that inflammatory reaction will come down. I think you got what is IRIS. After starting ART, there will be immune reconstitution, increase in CD4 count. So whenever there is a pathogen, that inflammation will go add badly on the infection. So there will be inflammatory reaction, immune reconstitution inflammatory syndrome, that is IRIS. The name is very good, catchy name, IRIS. And the treatment of choice for IRIS is steroids. That is why you should identify IRIS. In fact, before starting ART, you should rule out any opportunistic infection, or you should screen for the most important opportunistic infection. So this is what I was speaking about, the infection profile of HIV patient. Because they are immunocompromised, the infectious profile is different. And based on the CD4 counts, they are more prone for these infections. I cannot say these will exactly match. Sometimes they don't match. But the CD4 count is less than 20. If it's less than 50, there is 100% probability that you can suspect CMV. Okay, less than 50, this could be CMV. That could be your first TD. So if your CD4 count is less than 50, there are more chances of developing CMV, toxoplasma and Mycobacterium avium complex. And one more thing is, if it's less than 50, there are chances that they can develop HIV associated malignancies. That is lymphoplasmoblastic lymphoma, all your non-Hodgkin's lymphomas. That is best. Non-Hodgkin's lymphomas are very prone if the CD4 count is low. And if it's less than 100, they can develop toxoplasma, cryptococcal infections, and the GI infections, that is cryptosporidiasis. And if it's less than 200, it's pneumocystis cerevisiae, herpes simplex, and esophageal candidiasis. If it's less than 500, oropharyngeal candidiasis. So if the patient is having oropharyngeal candidiasis, he is immunocompromised. But if he is having esophageal candidiasis also, then he is more immunocompromised. So TB can develop within 500 also. So these are the associations with CD4 counts. Next question. RVD positive patient on TLD regimen. I told you this is the first line regimen. He is now diagnosed with pulmonary tuberculosis. Here you can start ATT. Yes, because he's already on ART. His viral load have been under control. His CD4 count is already very good. Now we can give ATT in this patient. If you are newly diagnosing HIV plus TB, both are new, control TB and then give HIV treatment. That is what is the difference. He's planned for drug-sensitive TB treatment. What should be the appropriate adjustment in the highly effective ART? So for this, you should know the drug interactions between TLD and your drug-sensitive TB regimen, HRZE. In this regimen, the most worrisome thing for me is rifampicin, which is a enzyme inducer. And the dolutegravir is most commonly metabolized by enzyme. Because this is enzyme inducer, the dolutegravir is fastly metabolized and it won't act. That is the reason we will give extra dolutegravir. Extra dolutegravir 50 mg tablet will be giving to the patient. Actually, I can change rifampicin and I can go for rifabutin. But this is coming as a fixed dose. In one tablet only, all the 4 drugs are coming. But if I am changing rifampicin to rifabutin, I have to give 4 separate tablets. Isoniazid, these 4 tablets should be given separately and patient won't take those many tablets. So for compliance reasons, we won't replace rifampicin with rifabutin. In fact, we'll add one extra dolutegravir to TLD patients. So you got me right. The most interactions are between rifampicin and dolutegravir. For rifampicin, you can replace it with rifabutin. But with rifabutin, the fixed dose combinations are not available. So you have to take 4 drugs, 4 different tablets. The patient won't be compliant. He won't take it for that long. For 6 months, daily 4 tablets, he won't take it. If it's fixed dose regimen, based on his weight, we'll give this many number of tablets, he'll be taking that. So what can I do? I cannot replace this. So I'll add extra dolutegravir. So TLD, I'll add one more D. So the basic idea behind that question is you should know the enzyme inducers and inhibitors. And the most important enzyme inducers is your rifampicin and carbamazepine. Carbamazepine is an auto-inducer. It will induce itself only. And the most common inhibitors are your fluoroquinolones, cimetidine and isoniazid. Okay. We have any questions on TB? No. So let's discuss about TB. Few important things I want to speak about TB is, what is rifampicin resistant TB? What is monodrug resistant TB? Polydrug resistant TB? MDR resistant TB? Pre-XDR TB? And XDR TB. These definitions are very important. See, monodrug resistant TB is, it's resistant to any of the first line. Except the rifampicin. Rifampicin resistant is nothing but it's resistant to rifampicin. Polydrug is it's resistant to more than one first line. So two first line drugs it's resistant, but the combination is not isoniazid plus rifampicin. Coming to MDR TB, it's resistant to both isoniazid plus rifampicin. Pre-XDR is nothing but MDR plus first line injectables like your fluoroquinolones. XDR, it's nothing but your pre-XDR plus group A agents. What are your group A agents? It's your fluoroquinolones, levofloxacin or moxifloxacin, is bedaquiline and linezolid. If it's resistant to the group A drugs also, it's called XDR-TB. Now the definitions have been changed and you have to know the definitions. So one more thing is this rifampicin resistant TB should be treated like MDR-TB. Let's take up the next question. 40-year-old with 15 days history of intermittent fever and altered sensorium. So this patient is having intermittent fever. So what is intermittent fever? For suppose this is baseline. There is fluctuations of the fever. The fever will touch the baseline and the fluctuations are more than 1 degree Celsius. The fluctuations of the fever are more than 1 degree Celsius and it will touch the baseline. That is intermittent fever. So along with fever, it's also having altered sensorium. So some CNS manifestation is there. So that they have done rapid diagnostic test for Plasmodium falciparum and it is positive. Which of the following is not a complication? So this is basically a severe malaria. Yeah, it's caused only by severe malaria or complicated malaria. It's caused only by Plasmodium falciparum. The other three species are not prone to cause severe malaria. It can cause malaria. Just your fever and malaria is positive. Whereas only your falciparum can cause organ involvement like renal involvement, hemolysis, your brain involvement. All these things can be caused only by falciparum. And what are the other complications he's asking? Definitely hypoglycemia is a complication, lactic acidosis is a complication, renal failure is a complication, pulmonary edema, heart failure is also a complication, but that is non-cardiogenic. Not because of, sorry, pulmonary edema is not because of heart failure, it's because of ARDS. These are all the features of Plasmodium falciparum causing severe malaria. So what are the features of severe malaria? One is your cerebral malaria with impaired consciousness, coma or convulsions. So the impaired consciousness is impaired or there is seizures, then only you call it as cerebral malaria. There is ARDS, circulatory collapse, that is hypotension, liver involvement, hemoglobinuria, that is there is hemolysis or bleeding, then you call it as severe malaria clinically. But along lab investigations should show hypoglycemia, sugars less than 40. See, the definitions are different. Normally we call hypoglycemia as less than 60, but in severe malaria hypoglycemia is less than 40. The definitions vary, so you have to concentrate here. And severe anemia is HB less than 5 and metabolic acidosis is pH less than 7.35. Hyperparasitemia is it's more than 2% in low intensity areas and more than 5% in high intensity areas. Hyperprolactinemia is lactate more than 5 and acute kidney injury is serum creatinine more than 2.65. So these are the exact definitions. The hypoglycemia definition is different. Hypoglycemia in severe malaria definition is different. Renal failure definition is different. Renal failure in severe malaria definitions are different. So these definitions are different. So you have to remember them. So these are the features of severe malaria, and whenever you have severe malaria that is due to Plasmodium falciparum, you can give chloroquine for 3 days. So on day 1 you will give 10 mg per kg. On day 2 you can give one more 10 mg per kg. On day 3 you will give 5 mg per kg. Because it's falciparum, primaquine on day 2 you can give. .75 mg per kg. And most of the Plasmodium falciparum are resistant to chloroquine. So you can give artesunate based therapy or artesunate plus sulfadoxine plus so this treatment you can give. Where is this? Okay. For severe malaria, and whenever there is severe malaria you have to add clindamycin or doxycycline. So this is the treatment of severe malaria. And in peripheral smear you can see this banana shaped gametocytes, which is specific for Plasmodium falciparum. So coming to the smear, you can make a thin smear or thick smear. In thin smear, you can quantify, okay, this is the load of the parasite. Whereas, sorry, in thin smear, you can identify the parasite. Okay, this is falciparum, this is Qbanks. Thin is identify. In thick smear, you can know the load of the parasite. And this is the kit, antigen kit we were discussing, which is positive. We'll keep the blood here and you will get this as positive. I was speaking about artesunate, pyrimethamine and sulfadoxine tablets, right? So this is the kit which is available. On day 1, you will take artesunate, pyrimethamine and sulfadoxine tablets, and day 2 you will just continue artesunate. This will be available as a kit, ASP kit. And if there is severe malaria, you will be giving artesunate injection also. Not just oral, you can give injection, which is 2.8 mg per kg. That much dose injection for 5 days also you can give. 5 days means we will be giving 0, 12, 24, 48, 72 hours. On day 1 we will be giving 2 doses and the next 3 days we will be giving each dose. So 5 doses we will be giving artesunate injection. Severe malaria. But whatever it is, on day 2 you have to take primaquine, that is 0.75 mg per kg on day 2. That is to eliminate the gametocytes. Okay, we'll take a short break and then continue this. Okay, let's take up the next question. Which drug has no role in the management of severe COVID-19? Is it remdesivir or dexa, low molecular weight heparin, or favipiravir? So, dexamethasone and low molecular weight heparin we will be giving in severe COVID only. They are indicated. And coming to remdesivir and favipiravir, we have tried remdesivir in the early periods of COVID. That is within, if it's diagnosed within 7 days, then we used remdesivir. We also used favipiravir in early stages, but it has shown no benefit in severe COVID. In mild cases with early illness, it had shown the better outcomes. So favipiravir. Let's see what are those drugs. See your remdesivir and favipiravir. So same like HIV, we have taken COVID replication, how the virus replicates and what are the drugs acting at each stage, we are seeing the same thing. At RNA replication, which is inhibiting RNA polymerase, are both favipiravir and remdesivir. But remdesivir has worked for severe cases and favipiravir did not work. Next, let's look into what is mild disease, moderate disease and severe disease and how had we treated that. So we have followed this AIMS ICMR protocol. So mild disease is patient is completely stable, no oxygen requirement. At room air, there is no hypoxia and no shortness of breath. For such patients, we had home management. Moderate disease is increased respiratory rate more than 24 and at room air your oxygen saturation is 90 to 93. That is moderate. For such cases we have admitted in the wards, we have given oxygen. We have given anti-inflammatory, that is low dose steroids, and anticoagulation low dose low molecular weight heparin. Whereas severe cases, that is respiratory rate is very high, more than 30 and oxygen saturation is less than 90 at room air, we have admitted in the ICU and we have given respiratory support, whether it's oxygen or NIV or invasive ventilation based on the patient status we have given, and we have given high dose steroids and high dose low molecular weight heparin to those cases. So moderate and severe, both we are given steroids and low molecular weight heparin, and for moderate low doses, for severe very high doses we have given. And we have given remdesivir to moderate and severe disease with no renal or hepatic impairment and within 10 days of onset. So early severe disease we have given remdesivir. And for some severe cases we have tried tocilizumab, which is interleukin 6 inhibitor, and convalescent plasma also they have tried, and a study done by the ICMR, it has shown that it has no improvement. So convalescent plasma had shown no benefit in COVID. So just ignore that. Tocilizumab we have used, remdesivir we have used. So this was the basic management of COVID which was done. And now the COVID cases are very low here and there. That too mild cases are seen. And we are yet to see the long-term complications of COVID and COVID vaccine. Yeah, this question was very simple. Remdesivir we have given for moderate to severe cases only. So all these three we have given to moderate to severe cases. So just now we have discussed MDR-TB means it's isoniazid, rifampicin plus any of the second line injectables, whether it's fluoroquinolones or aminoglycosides. These things we have already discussed. Now coming to hematology. So in hematology, your leukemias are important, acute and chronic leukemias. They'll be asking questions on that, and hematology part is very important. Coming to hemolytic anemias, your iron deficiency anemia, B12 deficiency anemia, these things are important, how to differentiate. And platelets, your coagulation disorders and bleeding disorders are important. You should know the basics of all the disorders. So most of the questions have been asked there. Next, in hematology, first we are dealing with the WBC part, leukemias part, all trans retinoic acid. Atra is used in the treatment of PML rara. So remember this rara, atra. Wherever there is PML rara translocation, we are using atra as the treatment. And it is seen in APML, promyelocytic leukemia, that is M3. Translocation 15, 17. So all other leukemias, the treatment is totally different. All other leukemias will be treating with cytarabine plus daunorubicin, 3+7 regimen. Whereas for PML rara, it's 100% curable and we'll be treating with atra, that is all trans retinoic acid plus arsenic trioxide. Atra plus ATO is the treatment. So remember one thing, rara, atra. You won't forget. And BCR-ABL is present and is a targetable tyrosine kinase in CML. Whereas CEBPA is present in AML, and in AML it's good risk. There are no targets. So this is the WHO classification of AML. This is how you should call AML. If there is some defining genetic abnormality, you should call that AML with that genetic abnormality. But suppose there is PML rara, AML with APML with PML rara, that is how you should call it. If there is core binding factor, AML with core binding factor, that is how you should call it. If there is RUNX1 mutation, you should call it by that name, T821. Core binding mutation is inversion 16. Oh, I'm extremely sorry, this is reverse. RUNX1 is inversion 16, core binding factor is T821, PML rara is T1517. These are the important translocations in AML. So whatever is the translocation, for suppose there is CEBPA mutation, you call it by that name. If there is myelodysplasia related changes, you call it by that name. If there are no genetic abnormalities or you have not identified anything, you have not tested, only then we will be calling it by differentiation. That is M0, M1, M2. So your M7 is acute megakaryoblasttic leukemia, which is most commonly seen in Down syndrome. So when you suspect AML, we'll be doing a peripheral blood smear, and that peripheral blood smear will show a blast with abundant cytoplasm and the cytoplasmic granules, and there are OR rods in that. If you see specifically these cells, there are multiple OR rods, and this is a typical promyelocyte. It's also called as fagot cell. So in APML, you will be seeing a typical myeloblast with multiple OR rods, that is promyelocyte. And blast more than 20% is nothing but AML. And the presentation, they can present with cytopenias. Multiple thrombocytopenias and anemias, and your WBC count can be low or high. If it's high, it's having bad prognosis. That is how it's going to present with high-grade fevers. Next, coming to CML. He's asking about accelerated CLL. So CML has three phases: CP phase, chronic phase, AP phase, accelerated phase, and BP phase is plastic phase. Chronic accelerated to plastic phase. It can progress from chronic accelerated to plastic phase. So he's asking what are the findings of accelerated phase. Yes, more than 20% basophils. There is no response to first generation TKA. Yes. Total leukocyte count is more than 10,000. Platelets more than 10 lakhs. And in new clonal abnormalities in the form of trisomies. So what is correct? So first we'll see the criteria, only then you will understand what I am trying to mark. See, if WBC counts are increasing, it's called accelerated phase even on treatment. If the platelet counts are increasing or decreasing even on treatment, it's accelerated phase. If there is persistent splenomegaly, it's called accelerated phase. More than 20% basophils and 10 to 19% blasts. More than 20% blast is blast crisis, it will be treated like AML. Less than 10% blast is chronic phase. 10 to 19% blast is accelerated phase with basophilia. And if it's not responding to TKI or there are new mutations on TKI, that is what you call it as accelerated phase. And yes, answer is all the options are correct. So this is how you will be looking into the peripheral smear of CML. How in case of CML presents to you? He can present with cytopenias. What is CML? It's a myeloproliferative neoplasm plus translocation 922. That abnormal 22 chromosome is called Philadelphia chromosome. What is myeloproliferative neoplasm? Proliferation of myeloid cells. So in bone marrow, when myeloid cells are proliferated, what happens to the other cells? The other cells are suppressed because there is no space. So there will be cytopenias and cytosis of one lineage. Because there is no space in the bone marrow, that other cells will be produced from extramedullary sites like spleen. So there will be splenomegaly because of extramedullary erythropoiesis. And patient will be having massive splenomegaly. This is how a typical CML presents. So he can come to you with cytopenias, or he can come to you with cytosis, or a dragging sensation in the left abdomen, or somebody has identified a massive spleen and they can be referred to you. So when you suspected CML, you will be doing a peripheral blood smear and you will be looking into the bone marrow. You look at the cells. Definitely there will be shift to left. The blast will be low only, less than 10% only, but there will be shift to left. And all types of cells are seen. There will be promyelocytes, metamyelocytes, myelocytes, your band forms, your neutrophils, everything will be seen. It's like a college party appearance or garden party appearance. See, all types of cells, for all the lineages cells, shift to left can be seen. Garden party appearance or college girls appearance. It's very colorful to see this CML picture. And sometimes some abnormal platelets like hypolobulated platelets can be seen. Hypolobated megakaryocytes can be seen in CML. So this is about CML. How do you treat CML? Tyrosine kinase inhibitors. What are the tyrosine kinase inhibitors? It is imatinib. That is first generation. What are the next generations? Dasatinib, bosutinib, nilotinib. And the third generation is ponatinib. Now recently one more TKI has been approved, that is asciminib. First, second, third generation. You should know the side effects of these TKIs. Imatinib mostly causes myelosuppression. Myelosuppression, the patient will have pancytopenias or cytopenias. Dasatinib will cause diarrhea. Nilotinib will cause diabetes, hyperlipidemia, and arterio-occlusive events, CVS, CADs. That's very dangerous. You have to monitor. Even your ponatinib can cause hypertension and arterio-occlusive events. And your bosutinib will cause pleural effusion, pulmonary thromboembolism, and myelosuppression. So these are the complications of your side effects of your TKA. So this is about CML. Next we'll move on to a 50-year-old female presents to you with lower backache and there are multiple lytic lesions in the bone. Lab parameters is showing hypercalcemia, hypoalbuminemia, increased total protein, serum creatinine is increased, and there is anemia. So anemia, renal failure. See, I'm telling you something. Hypercalcemia, anemia, renal failure, bone lytic lesions. What is this? It's CRAP criteria. So there is CRAP criteria, but to diagnose it as multiple myeloma, the definitive criteria is in bone marrow at least more than 10% monoclonal plasma cells should be there, right? This is nothing but multiple myeloma. There is AG ratio reversal also. See, albumin has decreased. Total protein has increased means globulins would have been increased. CRAB. Calcium is increased. There is renal failure, anemia, and bone lytic lesions. So what is the difference between? So this is a spectrum of plasma cell disorders or plasma cell dyscrasias. So these will come under plasma cell disorders. Monoclonal gammopathy of unknown significance, smoldering myeloma and multiple myeloma. It can progress in this way. So what is monoclonal gammopathy of unknown significance? When the M protein is less than 3 grams, it's a multiple MGUS. If the M protein, if more than 3, it's smoldering myeloma. And in these two, there is no CRAP criteria. So CRAP criteria is called myeloma defining event, and that is not there here. And the plasma cells are 10 to 60%. Whereas multiple myeloma, the criteria is more than 10% monoclonal plasma cells. In the bone marrow, or there should be some biopsy proven plasmacytoma. Plasmacytoma means this plasma cells only will be depositing in a tissue. A tissue will have plasma cells, that is called plasmacytoma. A plasmacytoma should be biopsy proven. That is mandatory, plus any one of the CRAP criteria. CRAP slim, recently slim has been added. What is CRAP? C is hypercalcemia, R is renal failure, A is anemia, B is bone lytic lesions. S means plasma cells more than 60%. The 10 to 60% is your MGUS and smoldering myeloma. More than 60% is your multiple myeloma. And light chain ratio should be more than 100. Li means. M means on MRI there should be lytic lesions which is more than or equal to 1. Here the bone lytic lesions should be more than or equal to 2. So this are the myeloma defining events. So this essential criteria plus any of the myeloma defining events, it's called as multiple myeloma. Whereas in your MGUS and smoldering myeloma, all the myeloma defining events are absent. The plasma cells are 10 to 60%. And if the M protein is less than 3, it's called MGUS. If it's more than 3, it's called smoldering multiple myeloma. Okay. Next question, what is the cause of intracorpuscular defect of hemolysis? So now we are discussing about hemolysis. Hemolysis can be intravascular or extravascular, intracorpuscular or extracorpuscular, inherited or acquired. So he is asking about intracorpuscular defect. See, uremic syndrome, because of the uremic toxins, the uremic toxin will come and cause hemolysis. So it's extracorpuscular. So extracorpuscular is outside the RBCs. Inside intracorpuscular is some problem within the RBC. Autoimmune hemolytic anemia, the antibodies are coming and killing RBC. There is no problem with the RBC. So this is extracorpuscular. Sickle cell anemia is within the RBC, in the hemoglobin, the beta chain 7th position is mutated. So it's within the RBC, right? So it is intracorpuscular. Whereas infections, the RBC is fine. Somewhere an organism is coming and infecting the RBC and killing it. So it is extracorpuscular. So sickle cell is intracorpuscular. If you think in that way, is it within the RBC or outside the RBC? If you think in that way, you can easily answer these questions. So these are the examples of intra and extracorpuscular hemolysis. Intracorpuscular inherited causes are your hemoglobinopathies, that is your sickle cell anemia, beta thalassemias and alpha thalassemias, and enzymopathies, G6PD deficiency, pyruvate kinase deficiencies, and your membrane skeletal disorders, that is hereditary spherocytosis and elliptocytosis. And acquired causes are paroxysmal nocturnal hemoglobinuria, in which there will be more complement mediated damage to the RBC. Next, extracorpuscular are inherited causes like hemolytic uremic syndrome, which is familial. And acquired causes are some mechanical destruction due to some mechanical valve in the body, or it can be due to toxins, drugs, infections, or autoimmune hemolytic anemia. So most of the intracorpuscular defects undergo extravascular hemolysis. Most of the extravascular defects will undergo intravascular hemolysis. The exceptions are PNH will undergo intravascular hemolysis. Autoimmune hemolytic anemia will undergo extravascular hemolysis. Those are the exceptions. So in this way, you can remember all the causes: extravascular, intravascular, extracorpuscular, acquired and inherited causes. This one table is giving you all the answers. So this table is very important. Next question. A patient with anemia and hemoglobinuria. So when there is hemoglobinuria, what do you suspect? It's intravascular or extravascular hemolysis? So it's intravascular hemolysis. There is raised LDH and elevated bilirubin, that could be indirect bilirubin. And he has given the peripheral smear with destruction of RBCs. One of the example is mechanical heart valve. For suppose there is a prosthetic valve and beside the valve there is leaking of blood, paravalvular leak through a narrow space. While passing through that narrow space, these RBCs will undergo a maximum of shear and tear stress, ultimately resulting in their wall damage. And that wall damage, when they are going to spleen, one part of that RBC is being bitten by the macrophage, ultimately resulting in their cystocytes. And there is hemolysis because of that shear stress. It's seen in mechanical heart valve. So this is macroangiopathic hemolytic anemia. One of the examples of extracorpuscular defect causing intravascular hemolysis, and this is acquired. Types of cystocytes. So there is some problem with the RBCs, it has gone to spleen and it has been modified by the macrophage. That is what it means by cystocyte. Coming to the next question, all are present in paroxysmal nocturnal hemoglobinuria except leukemia. Yes, it can progress into AML. Thrombosis, yes, it's a prothrombotic condition. Aplastic anemia, yes, it can progress into aplastic anemia, but not lymphoma. You don't see lymphoma. So what is paroxysmal nocturnal hemoglobinuria? So basically there is defect in PYGA gene, which will be synthesizing GP anchored proteins. What are those GP anchored proteins? Those are your CD55 and CD59. CD55 is your decay accelerating factor and CD59 is your membrane inhibitor of reactive lysis. Basically, they are inhibiting your complement. So the gene which is inhibiting the complement is being inhibited. So now complement is activated. That complement will cause damage to the RBCs resulting in hemolysis, paroxysmal nocturnal hemoglobinuria. Because it's an intravascular hemolysis, there is hemoglobinuria. But why it's nocturnal? Because in sleep, during REM sleep, there will be some respiratory depression resulting in CO2 retention. CO2 retention means acidosis. In acidosis, there is more activation of complement. So night during sleep, more activation of complement. So nocturnal intravascular hemolysis resulting in hemoglobinuria. What is a triad? This patient will have pancytopenia, thrombosis, and hemolytic anemia. That is hemoglobinuria. This is a triad. And they are prone for both aplastic anemia and MDS and AML. How do you diagnose when you're suspecting PNH? That is pancytopenia is there, hemolytic anemia is there, patient is having thrombosis. Thrombosis is also very atypical site like portal vein thrombosis, Budd-Chiari syndrome, you have to suspect PNH. And we'll be doing flow cytometry and we'll be monitoring for CD55 and 59. If CD55 and 59 are absent on flow cytometry, then it is paroxysmal nocturnal hemoglobinuria for sure. How do you treat it? You know the presentation, you know the pathogenesis, now you know the clinical features, how to diagnose, how to treat. It's complement mediated damage. So inhibit the complement. What complement inhibitor do you know? Okay. What complement inhibitor do you know? C5a inhibitor is eculizumab. So C5 inhibitors, eculizumab, and one more drug, ravulizumab, we know that. So we'll be giving complement inhibitors basically. But when There was some technical issue. Let's continue. So we were discussing about paroxysmal nocturnal hemoglobinuria, its complement mediated damage to the RBCs. So we are giving complement inhibitors. The most common thing we know is eculizumab, that is C5 inhibitor. The another C5 inhibitor is ravulizumab. But if we are giving eculizumab and ravulizumab and inhibiting C5, through other pathways, that is to C3 and factor D and B, there is activation of alternate pathway, alternate complement pathway, and resulting in RBC lysis. So we have to act more proximal. Instead of 5, we have to give more proximal inhibitors like C3 inhibitors, pegcetacoplan, factor D inhibitors, danicopan. So these are the newer drugs. Just note them carefully. Factor D inhibitors are iptacopan. So these are the newer complement inhibitors which are used in PNH. Iptacopan is C3 inhibitor, danicopan is factor D inhibitor, and iptacopan is factor B inhibitor. And your C5 inhibitors are eculizumab and ravulizumab. Totally 5 drugs you have to remember. They can ask, because this is a recent addition to the Harrison, they can ask in the exam. Next question. 22-year-old child with thalassemia major, and he is transfusion dependent. He's 2 years, but he's transfusion dependent. Which of the following is the best investigation for determining iron overload? See, the problem with thalassemia is, yes, they will have hemolytic anemia with massive splenomegaly, and they will be transfusion dependent. Like they will be needing transfusions every alternate day. But what's the problem with giving transfusions is we are giving iron overload. HP hemoglobin is nothing but globin plus iron, right? There will be iron overload in such patients, in which you have to identify and go for iron chelation, otherwise there will be multiple organ failures in that patient. So how do you identify by the iron overload? That is serum ferritin. Serum ferritin is the storage form of iron, and if it's increased, it is suggestive of iron overload. Yeah, that this thing we know. Iron is absorbed through DMT, dimetyl transporter, and the storage form is ferritin. The transferring or moving part of iron is transferrin, and it's absorbed from the mucosa by ferroportin. This part of iron absorption we know. And if there is iron overload, you have to go for chelation. Deferoxamine. The iron chelators are deferoxamine, defericirox, deferipirone. Okay. Next question. A patient is diagnosed with iron deficiency anemia. What are the things you are expecting? So in iron deficiency, the first parameter that is going to fall is your storage form. See, the active form and storage form. The storage form will be depleted. Only then the active form of the iron will be depleted. So serum ferritin will decrease, and it's the first parameter to decrease. Next, your serum iron also will decrease. Your transferrin is less saturated. See, transferrin should be bound to iron. If the iron is deficient, your transferrin is less saturated. Yes, decreased transferrin saturation. And your total iron binding capacity, because the transferrin is less saturated with iron, whenever iron comes, it has more capacity to bind to iron. So your transferrin iron binding capacity also increases. All these things are correct. These things are more confusing. You have to be with clarity what is increasing and why is decreasing, because in exam it's so confusing, and the iron profile in iron deficiency anemia is very important. Next, what is true about iron anemia associated with chronic disease? So anemia of chronic disease he's asking. Basically in anemia of chronic disease, it's also presenting like iron deficiency anemia, but iron is normal, but the iron available is decreased. See, the serum iron is decreased, serum ferritin is decreased, total iron binding capacity. So in anemia of chronic disease, it's everything like anemia. See, I'll tell the differences, then this would be easy. Serum ferritin, serum iron, total iron binding capacity, and transferrin saturation. Everything is same. Serum iron is decreased, iron binding capacity is increased, transferrin saturation is decreased. Serum ferritin is decreased in anemia of chronic disease and increased in iron deficiency anemia. That's the only difference. So this is decreased true. Decreased ferritin is false, and total iron binding capacity is decreased, and increased bone marrow iron. Your bone marrow iron can be normal to be increased. So decreased ferritin is completely wrong, followed by D. These are the two options which is wrong in anemia of chronic disease. So this is what we have discussed. The serum ferritin is the one which is going to differentiate your anemia of chronic disease versus iron deficiency anemia. Everything is almost same. The problem with anemia of chronic disease is your hepcidin, which is a positive acute phase reactant. So whenever your body is in inflammation, hepcidin is increased. Hepcidin will inhibit the ferroportin. Let's look at this picture. This is very important. So hepcidin is increased. So ferroportin is inhibited. So your iron is not absorbed into the body. It will be in the mucosa. So basically it's mucosal trap of iron. So the statement I told, iron is absorbed but is not available. That is the exact statement for anemia of chronic disease. How do you treat anemia of chronic disease? Don't give iron. Treat that chronic disease. And if anemia is severe, go for blood transfusions. Next thing, von Willebrand disease is associated with. So he's asking about prothrombin time and activated partial thromboplastin time. So PT is dependent on extrinsic pathway. APTT is dependent on intrinsic pathway. So von Willebrand disease, that is your von Willebrand factor, is important to stabilize factor 8. See, normally the T half of factor 8 is 12 hours. That is because of the von Willebrand factor. If the von Willebrand factor is deficient, the T half of that factor 8 will be just for 2 hours. So ultimately it's deficient. So factor 8 is a part of extrinsic pathway or intrinsic pathway. It's a part of intrinsic pathway. So APTT is prolonged. And your von Willebrand factor also has one more function, that is platelet aggregation. So it's also important for platelet function and coagulation function. Both the bleeding, its deficiency can cause both bleeding disorder and coagulation disorder. That's what you should understand. The same thing I have told you. Von Willebrand factor is needed for platelet aggregation. And it's also needed for factor 8, which is a part of intrinsic pathway. So coming to the next system, that is respiratory system. So in respiratory system, previously they used to ask more questions on asthma and COPD. But in the recent times, they are asking you most questions on LRTIs, the lung malignancies, occupational lung diseases. On these areas, there are more questions which have been asked. So case of asthma came with silent chest. What is your management? So any case of asthma with silent chest, pulses paradoxes, patient is in altered sensorium, not even able to speak a single word without taking a breath, then that is severe asthma. So in severe asthma, the management should be it's an emergency basis management, not a OPD basis management. So we'll take the patient, first we have to stabilize the patient. Airway, breathing, circulation. So airway, there is bronchoconstriction. So you have to go for oxygen. If necessary, we have to go for non-invasive or invasive ventilation. And for bronchodilation, you have to give beta agonists like salbutamol and muscarinic receptor antagonists like ipratropium. So salbutamol plus ipratropium, you have to give nebulizations. And you will go for steroids because it's a acute airway hyperresponsiveness. So asthma is nothing but acute airway hyperresponsiveness when after exposure to an allergen. So to reduce that hyperresponsiveness, you can go for steroids. If not responding to steroids, oxygen and bronchodilators, the last thing will be MgSO4. Because the magnesium is a bronchodilator, you can try MgSO4 as a last resort. So yes, hydrocot, yes, MgSO4, yes, salbutamol nebulization, yes, ventilator support, but not formoterol inhaler. Formoterol is formoterol is long-acting beta agonist. If it's long-acting, we don't need it. We need short-acting because this is an emergency. For management and for maintenance, you can use LABA, but for acute management, we want SABA. So we'll be using salbutamol, not formoterol. So this is acute severe asthma. How is the patient presenting? How do you diagnose and how do you treat acute severe asthma is very important. Next question. A patient has come to you with breathlessness and wheezing. So whenever there is wheeze, so what is wheezing? When the air is passing through a narrow passages, that will be heard as wheezing. So the airways are narrowed. That one thing I can get from this wheezing. And the absolute eosinophil count is 500, definitely increased, and the miliary pattern is seen on X-ray. So breathlessness, wheezing with increased eosinophil count, do you think that miliary pattern is because of tuberculosis? So if it's miliary tuberculosis, the patient will be his performance status will be very bad, and he'll be thin, emaciated with disseminated tuberculosis, and even in other organs also. So this patient is not looking like that. He's just breathless, wheezing, and miliary TB is not airway disease. So definitely this is involving both airway and parenchyma. With eosinophilia. So you should consider eosinophilic lung diseases. So some of the examples of eosinophilic lung diseases is your Loeffler's pneumonia because of your Ascaris parasite, or tropical pulmonary eosinophilia because of the microfilaria, and the drug-induced pulmonary eosinophilias. So this is tropical pulmonary eosinophilia. So what is tropical pulmonary eosinophilia? A patient already in known case of filariasis with microfilaria larvae in his blood, which is going to the lung, which is eliciting a hypersensitivity reaction, which is type 1. Ultimately, the patient will have breathlessness, fatigue, wheezing. So those are the clinical features. And if you investigate, there will be eosinophils in the peripheral blood, more than 3000 eosinophils. And in BAL, bronchoalveolar lavage also, there will be more than 40% eosinophils. Your IgE will be increased. And in X-ray, there is miliary mottling. So it's very important to identify this condition because the treatment for this is diethyl carbamazine. If you give diethyl carbamazine 200 mg daily, the patient will respond in 7 days. Within 7 days, there will be a drastic response. That is the reason you have to identify this condition. You just, okay, wheezing is there, SOB is there, okay, it's bronchial asthma. Don't be in that hurry. Look at the absolute eosinophil counts, look at the X-ray. In X-ray, you won't be having mottling pattern in bronchial asthma. It's both airway and parenchymal disease. TB is parenchymal. Bronchial asthma is just airway disease. Hypersensitivity pneumonitis, it's a parenchymal disease. So this is a typical case of tropical pulmonary eosinophilia because of your Wuchereria branchofti. Microfilaria. see this mottling. If you can see, there is multiple mottling. Yeah, I think you have observed this. So this miliary mottling is also seen not only in TB but also in your eosinophilic lung diseases. And some of the idiopathic eosinophilic lung diseases are your acute eosinophilic pneumonia, chronic eosinophilic pneumonias. Those are idiopathic, and with known etiology, the eosinophilic lung diseases are your Loeffler syndrome, tropical pulmonary eosinophilias. Coming to the next question. A middle-aged female with fever, night sweats, ptosis and bilateral facial nerve palsy. The investigations is showing bilateral hilar lymphadenopathy. Which of the following is the most likely diagnosis? So this is nothing but the presentation of acute sarcoidosis. So the acute presentations of sarcoidosis and the chronic presentation. The acute presentations is Lofgren syndrome or Herford-Waldenstrom syndrome. Okay, the names are looking horrible, but it's very simple. We'll see. Herford-Waldenstrom. So Lofgren syndrome, the patient will present with fever, arthritis, bilateral hilar lymphadenopathy. Whereas patient with Herford-Waldenstrom syndrome will present with fever, pure parotitis, bilateral element nerve palsy, and uveitis. Bilateral element 7th nerve palsy and uveitis. So uveitis can also be there in Lofgren's. So these are the typical presentations of acute sarcoidosis. Whereas chronic sarcoidosis, it is just your bilateral hilar lymphadenopathy and lung infiltrates. And the lung infiltrates can ultimately resulting in interstitial lung disease. And yes, there is also a skin involvement in chronic that is called lupus perineum, which is a hyperpigmented scarry lesion which is atrophic. So this is the acute manifestation of sarcoidosis, that is your Lofgren syndrome. It's definitely not TB. See, bilateral facial nerve palsy, bilateral element facial nerve palsy is seen in only few conditions. One is your acute sarcoidosis, second is your GBS, third is your Melkerson's Rosenthal syndrome, sometimes snake bite, or any descending weakness. You can see it's seen in very specific conditions, bilateral 7th nerve element facial nerve palsy. Yeah, you know the signs. Garland sign, right paratracheal lymph nodes with bilateral lymphadenopathy, that is Garland sign on X-ray. On gallium scan, because of the uptake by lacrimal glands and the parotid glands, it will be looking like a panda. So this is nose. In nose, normally only we will be having uptake. This is lacrimal gland and this is parotid gland. This is looking like a panda appearance on gallium scan. Again, this is Garland appearance. Right paratracheal and bilateral hilar lymphadenopathy. Next question. Elderly with cough and fever. On auscultation, there are bronchial breath sounds in left axillary region. So probably with acute cough and sputum and fever. Cough with sputum and fever. So whenever there is cough with sputum, it's mostly a parenchymal lesion. More than airway lesion. mostly. So if cough is there with sputum, parenchymal or airway lesion along with fever, and you can hear the bronchial breath sounds, means it is lower respiratory tract infection and this patient is having consolidation. Left axillary region means probably left lower lobe consolidation is there. And he has given some parameters. He is asking how do you manage the patient. So here we are more worried about curb 65. So it's confusion. Blood urea is more than 90. Respiratory rate is more than 30. BP is less than 90/60 and age more than 65 years. We'll be giving one score per each parameter, and if it's more than 3, the patient will directly go into the ICU. If it's 2, he'll go into the ward. If it's 0 to 1, he'll go home with antibiotics. Everything is with antibiotic. So here the age is satisfied. BP is normal, respiratory rate is normal, urea is satisfied. So the score is 2. So I should admit the patient but not in ICU. So it's room admission and give antibiotics. I'll also send the sputum for culture sensitivity. Initially, I'll start an empirical antibiotic based on our hospital sensitivity data. And then we'll send the sputum. If it's susceptible, we'll continue. If it's resistant, we'll continue the susceptible. We'll start the susceptible antibiotic. And this is the left lower lobe consolidation you can see here. In consolidation, see, you can see the air bronchogram. So the airway is clearly seen. So this is called air bronchogram. And if air bronchogram is there, so heterogeneous opacity with air bronchogram is nothing but consolidation. So this is the bronchus. Sometimes you can see the bronchus like this, or you can see the bronchus like this. It's either cut. Okay, next question. A patient with history of carcinoma of bladder, now presented with dyspnea, clinical signs of DVT, tachycardia. What is the risk of developing pulmonary thromboembolism according to Wells score, he's asking. So according to Wells score, his carcinoma bladder will have a score of 1, signs of DVT will have a score of 1.5, and tachycardia will have a score of, DVT will have a score of 3, higher score, and tachycardia have a score of 1.5. And if this score is more than 4, then it's definitive that it's pulmonary thromboembolism and you have to go for CT pulmonary angiogram. So this is high risk. So signs of DVT is 3, that just now we have discussed. And 1.5 you will give for tachycardia, recent surgery, and previous history of pulmonary embolism or DVT. Previous DVT or pulmonary embolism 1.5. Now DVT signs are there 3. And score of 1 you will be giving for hemoptysis and malignancy. And alternative diagnosis is not there, means there also you will be giving a score of 3. More than 4, it's highly likely that it's pulmonary embolism and you have to go for CT pulmonary angiogram. And in CT pulmonary angiogram, you will be seeing a filling defect. See, this is the thrombus, saddle shaped thrombus. So just look at the image carefully, because the same image can be given in your exam. They'll just give you the image and ask you to identify. So this saddle shaped thrombus or filling defect you should not miss. All of the following show low glucose in the pleural fluid except. See, this pleural fluid glucose, they've asked many times. They love glucose in pleural fluid. See, in pleural fluid, low glucose means there is some infection or empyema or rheumatoid arthritis associated exudative pleural effusion, or there is malignancy. But it's very low, less than 60 means it's either malignancy or rheumatoid arthritis associated pleural effusion. So he's asking everything will show low except empyema, yes, malignant, yes, rheumatoid arthritis, yes. Dressless syndrome, no. What is Dressless syndrome? It is post MI pericarditis because of autoimmune etiology. Treatment is steroids. So this is the pleural effusion. So this is homogeneous opacity with a curve, a least S-shaped curve. And your CP angle is obliterated. Costophrenic angle is obliterated means there is fluid. For sure, it's pleural effusion. So based on this X-ray, we have identified that there is pleural effusion. See, your costophrenic angle is obliterated, that is filled with fluid. So here if you see the costophrenic angle, it's free. You can see the whole angle. But here the angle is lost. So that is lost with homogeneous opacity with the Ellis S curve on the top is significant of pleural effusion. So how do you say it's exudative or transudative pleural effusion? We'll be seeing LDH and protein. If pleural fluid protein ratio compared to serum protein is more than 0.5 or LDH ratio is more than 0.6 or just LDH value is more than 2/3 of the upper limit, then you call it as exudative. Any one is enough to call it as exudative. If two are positive also, we call it as transudative. If it's low, we call it as transudative. Oh yeah, I forgot to tell you. What is this criteria called? Lights criteria. Okay, next question. A patient presents with complaints of morning time productive cough. So basically he is having a mucopurulent cough. Purulent means some infective pathophysiology is also there. Purulent means pus. And it's increasing on moving. What is the following diseases which can present? See, a cough which has postural changes. By changing the position, it's triggering cough means there are only two reasons in the world. That is lung abscess and bronchiectasis. They will have postural changes. Postural changes of cough. And one more important thing is they are having bronchoria. That is, the sputum is almost more than 100 ml per day. And one more important thing is the sputum is foul smelling. And next important thing is they are having clubbing. Clubbing. The nail changes. We'll discuss about clubbing. So these are the common things about lung abscess and bronchiectasis. Both will have cough with bronchoria, more than 100 ml per day sputum, which is foul smelling and which will change by postural changes, and both will have clubbing. So in lung, along with malignancy, lung abscess and bronchiectasis also have clubbing. One more important thing, asthma and COPD, clubbing is not seen. Just remember that. So your bronchiectasis can be three types: cystic bronchiectasis, varicose bronchiectasis, and cylindrical bronchiectasis. So varicose bronchiectasis, its severe form is called cystic. So cystic is the most severe form. Whereas cylindrical bronchiectasis means it's also called as traction bronchiectasis. So here is the bronchi and here is the parenchyma. When there is fibrosis of parenchyma, that will pull the bronchus apart. So it's called traction bronchiectasis. It's seen in pulmonary fibrosis. There is no problem with the bronchus. There is problem with the parenchyma fibrosis. That is why there is traction bronchiectasis typically seen in your pulmonary fibrosis or interstitial lung disease. And one more important thing is which will cause upper lobe bronchiectasis. Your cystic fibrosis, your allergic bronchopulmonary aspergillosis, which will cause middle lobe bronchiectasis, your non-tuberculosis mycobacteria, cartaginous syndrome, and for upper lobe one more example is TB, which will cause lower lobe bronchiectasis, aspiration. Okay, these are the examples of bronchiectasis by lobes. Next, identify the condition given below. So this is a typical clubbing. It's the bulbous enlargement of the terminal phalanx. See, if you see, it's bulbous enlargement of the terminal phalanx. How do you identify that? So whenever you ask the patient to approximate both the nails of the same finger, there should be a diamond shaped window. Don't know how clarity it is. There should be a diamond shaped window normally. But if that diamond shape is lost, then there is clubbing. This is called Shamrod sign. Next, we will be looking at the index, the diameter or the distance of distal phalanx and interphalangeal. Of the distal phalanx, we'll look at the diameter. In the interphalangeal region, we'll look at the diameter. If the distal phalangeal diameter is increased, then that is also a diagnosis for clubbing. This is how we are going to diagnose clubbing. So clubbing is the bulbous enlargement of the terminal phalanx. Where do you see clubbing? In respiratory diseases, where do you see clubbing? Just now we have discussed lung malignancies, lung abscess and bronchiectasis. In GI conditions, where do you see clubbing? In inflammatory bowel disease and GI malignancies. In cardiac conditions, where do you see clubbing? Excuse me. Yeah, in cardiac conditions, where do you see clubbing? It is infective endocarditis, atrial myxoma. In CNS conditions, any paresis, if there is hemiplegia, you can see clubbing of the digits. Or even in trauma to the nail, you can see clubbing. These are the most important causes of clubbing. And he can give you that picture and ask you to identify in which condition it can be seen. Next question. A 50-year-old male chronic smoker with squamous cell carcinoma. Yes, the most important risk factor for squamous cell carcinoma is smoking. So for squamous cell and small cell, smoking is the risk factor. And adenocarcinoma, it's seen in non-smokers or people who take filtered smoke. Filtered cigarettes, the particles are very light and they will go and settle in the periphery, resulting in adenocarcinoma. And who are taking BDs, those are not filtered. Those core segments will be deposited in the central parts of the airway and resulting in central malignancies like small cell carcinoma and your squamous cell carcinoma. You got me right? Squamous and small cell are central malignancies near the airway. Adenocarcinoma are peripheral malignancy away from the airway. So this is a squamous cell carcinoma with smoker. He came with altered sensorium and BP is also very low. They have taken ECG. What is there in the ECG? I don't know whether it's clear or not. Your QT interval is very narrow. QT interval should be at least more than 7, right? It's here, it's 4 boxes only. It's 4 to 5 small boxes only. Exactly, it's not clear to calculate. So the QT is shortened. QT is shortened in hypercalcemia, prolonged in hypocalcemia. So squamous cell carcinoma presenting with hypercalcemia. This is an oncological emergency. So whenever there is hypercalcemia, there is more polyuria. So the patient will be dehydrated. Polyuria, hypercalciuria, dehydrated. See, altered sensorium, dehydrated patient with hypotension, and the ECG is showing QT shortening. What is the first thing you do? You give hydration. First thing is hydration. So if you think you have excluded all the metabolic causes, a case of lung carcinoma came with altered sensorium and neurological deficits, maybe you can suspect brain mets and go and do for CT brain. But now we are suspecting hypercalcemia, give steroids. And zoledronic acid, if there are bony metastasis resulting in hypercalcemia, you can give zoledronic acid. CSF for cytology. No, we don't need CSF because we are not suspecting any CSF malignancy here or any abnormality in the brain. It's just a metabolic abnormality. So give hydration. So squamous cell carcinoma and small cell, the common things are both are associated with smoking. Both are central tumors, that is near the airway, whereas adenocarcinoma is seen in non-smokers and it is peripheral. Away from the airway. So because squamous cell and small cell carcinomas are central, they can cause SVC obstruction, and SVC obstruction is commonly seen in these conditions. SVC obstruction. Here it can be seen. Now coming to the histology, how do you diagnose squamous cell carcinoma? What are the paraneoplastic syndromes? The paraneoplastic syndrome with squamous cell is most common hypercalcemia, whereas small cell has multiple like SIADH, Lambert-Eaton syndrome, your myasthenia gravis. It has lot of paraneoplastic syndromes. And adenocarcinoma, very less paraneoplastic syndromes. Coming to the histology, here P40 is positive, cytokeratin is positive here. Whereas small cell carcinoma, because it's a neuroendocrine carcinoma, synoptophysin and chromogranin will be positive. Whereas adenocarcinoma, TTF1 and napsin A will be positive. So other than chemotherapy, recently there are multiple targetable agents in these malignancies which have improved the lifespan of lung malignancy. So lung cancer, there are many recent updates and many recent targets, many drugs have been come. So squamous cell, yeah, it's good. It will melt with chemo and radiotherapy. Small cell, it will have multiple recurrences. And adenocarcinoma has multiple targeted therapy. Okay. And one more thing is adenocarcinoma can present with cavitatory lesions. So these are the important things you should know about these three malignancies, which will be most commonly asked. So what is the risk factor? Where is the location? What are the paraneoplastic syndromes and the complications seen? How do you diagnose? And whether it will cause SVC obstruction or not. And they can also ask about Pancoast tumor, a tumor in the upper lobe of the lung which will be compressing the sympathetic chain resulting in Horner syndrome, which will compress the brachial plexus, also resulting in the weakness of the small muscles of the hand. Next, OSA. Your sleep apnea is like the most favorite question of the examiners. You should not miss OSA. In OSA, you should know the definitions of apnea, hypoapnea, and respiratory event related arousals. Apnea, hypoapnea, respiratory event related arousal. So, apnea means total cessation of airflow. Cessation of airflow. For how many minutes? Not minutes, it's seconds. What is hypoapnea? Your airflow is decreased by 15%. Because of that, your oxygen saturation has been decreased by 3%, more than 10 seconds. Respiratory event related arousal means there is some respiratory issue, patient had arousal, but it's not fitting into either apnea or hypoapnea. It's not both. Then you call it as rare. So hypoapnea is 10 seconds. So we'll be calculating apnea, hypoapnea index. If it's more than 5, see, for suppose the patient is having 10 hours of sleep and totally I got 10 apnea and hypoapnea index. So per hour it's 1. So per hour how many are there we'll see, and more than 5 per hour is diagnostic of OSA. More than 30 is severe OSA. Per hour is important. So this is the polysomnography. So you will ask the patient to sleep in your lab where you will be connecting your ECG, EOG, EMG, EKG. You will keep a mic to monitor the snore. You will be monitoring the flow. What's the flow of air through the nasopharynx? What are the chest and abdominal movements? What's happening to the saturation? These 10 things you will be monitoring. See, if you see here the flow has completely stopped. Apnea. And there are chest and abdominal efforts. To overcome those apnea, there is chest and abdominal efforts in the sleep. So this is obstructive sleep apnea. This is what we'll be monitoring in our EKG, polysomnography lab. So whenever there is apnea, your chin muscles also, the EMG is showing nothing. How do you treat? Lose the weight. So dietary, exercise modifications. If there is, we'll do an MRI, and if there is any obstruction, we'll be going for plasty, ovulo-pharyngeoplasty. If not, we'll give patient CPAP, positive airway pressure. Whatever the obstruction is, that positive pressure will overcome that obstruction and patient will have less complications. Next question. Emphysema is characterized by all except. See, this lung volumes and your pulmonary function test is very important. One question can be from for sure. See, in emphysema, let's look at the vital capacity. The forced vital capacity is normal. But if you look that in the first 1 minute, how much is the forced vital capacity, that will be decreased because there is a expiratory obstruction in emphysema. So FEV1 is decreased, but FVC is normal. So FEV1 is decreased, FVC is normal. Because there is airway destruction, even your diffusion capacity to carbon dioxide is also decreased. Now coming to the residual volume is increased because what's happening in emphysema, the terminal airways are dilated. What is happening to the residual volume? The volume in the lungs will increase. So the residual volume will increase, that is the answer. So first you should understand what is what. What is residual volume? What is FEV1? What is FVC? Then you can easily derive all these things. And one more important thing is in asthma, your diffusion capacity to carbon monoxide will increase. Why? Because in asthma there is airway hyperresponsiveness. So more neutrophils in your airway. Neutrophils will have more nitric oxide. So it will release more nitric oxide. So the airway will dilate. So more air is going into the alveoli, more exchange is happening. So the diffusion will increase. So that's the reason your diffusion capacity in asthma will increase. So these are the exceptions. In emphysema, your residual volume will increase. In asthma, your DLCO will increase. All other things will be like obstructive airway disease. Next, coming to rheumatology. A female patient, rheumatology means mostly it's female patients only. Very few are affecting males and elderly males. Most are young reproductive age females are affected. So female patient with numb fingertips and facial skin is tighted, ANA is positive, immunofluorescence is showing nucleolar pattern. What is the diagnosis? So in rheumatology, each disease you should know the presentation. In SLA, what are the systems involved? What is the antibody present? How do you treat? In sarcoidosis, what are the systems involved? In Sjogren's syndrome, what are the systems involved? In small vessel vasculitis, what are the systems involved? What is the presentation? How do you diagnose and treat? So these are the things you should know in rheumatology. The presentations, which systems are involved, which antibody is present. That is more important, and most of the questions are around those presentations and antibodies. So every disease you should know these things in rheumatology. That is the basic for rheumatology. So here a female patient with tightened facial skin and numb fingertips, ANA is positive, IF is nucleolar pattern. What are you thinking? Is it SLE? Yes, ANA is positive. But in SLE, you can see a rash, but is facial skin thickened? And there are numb fingertips. He's saying about Raynaud's phenomenon. No, this presentation is not looking like SLE, so I'm speaking about the presentation. Sjogren's syndrome, the patient will present with Zika symptoms, dry eyes, dry mouth, and in secondary Zika, systemic symptoms with this Zika symptoms. So it's not looking like Sjogren's. In rheumatoid arthritis, the primary presentation is articular manifestations, bilateral, symmetrical, small joint predominant arthritis. It's polyarthritis. That is the presentation, but no, it's not looking like that. The answer is systemic sclerosis, in which the patient will present with thickened skin with sclerosis, which will involve the face and peripheries of the extremities, and there will be hyperpigmentation and depigmentation resulting in coffee pigmentation of the skin. Okay, so this is the typical progression of systemic sclerosis. Initially, the skin is tense, edematous. Later on, see, there is sclerosis with small mouth opening, microstomia. And this patient is having multiple telangiectasias. And it's also involving the limbs also. So how do you differentiate whether it's limited systemic sclerosis or diffuse? So systemic sclerosis can be diffuse or limited. See, whatever systemic sclerosis it is, the presenting symptom will be Raynaud's. The first presenting symptom is Raynaud's. But in limited systemic sclerosis, this Raynaud's is very severe, resulting in ulcers and autolysis of the digits. So 5 minutes break and we'll continue these things. Okay, we were discussing about diffuse systemic sclerosis versus limited systemic sclerosis, right? So diffuse or systemic, the first presentation in a case of systemic sclerosis will be Raynaud's, and that is more severe in limited systemic sclerosis. And one other thing is, in diffuse, your face is involved and the skin above the elbow is involved. Whereas in limited systemic sclerosis, your face is not involved and skin below the elbow is involved. And diffuse systemic sclerosis, the patient will have ILD resulting in pulmonary artery hypertension, that is type 3 pulmonary hypertension. Whereas in limited systemic sclerosis, without the involvement of ILD also, patient can have pulmonary artery hypertension. These are the basic differences between diffuse and systemic sclerosis. And in both these things, ANA is positive. So for screening, you can use that. But in diffuse systemic sclerosis, topoisomerase antibodies are present. Whereas in limited systemic sclerosis, anti-centromere antibodies are present. And centromere antibodies, centromere pattern, whereas topoisomerase antibodies will give you this nuclear pattern. So this is a typical case of diffuse systemic sclerosis because the phase is involved and there is nuclear pattern. This is a case of diffuse systemic sclerosis. What is the presentation? What are the antibodies present? Those things you should know. Next question. A patient came with the deformity of the finger as shown in the picture, and the distal interpharyngeal joint is paired. What do you think it is? What is the thing given in the picture? It is swan-like appearance, yeah, swan finger. Where in distal pharyngeal joint there is flexion, in proximal pharyngeal joint and your metacarpal pharyngeal joint there is extension. That is swan finger appearance. And exactly opposite to this is botanist finger, in which there is extension at the DIP and flexion at your PIP and metacarpophalangeal joints. So this deformity can be seen in both erosive and non-erosive arthritis. In rheumatoid arthritis, you can see erosive arthritis. Because of erosion, there are deformities and these deformities are irreversible. That is the reason you should identify rheumatoid arthritis in the early stage and give DMARDs so that you can prevent deformities. Once the patient is landed into deformities, nothing can be done. It's irreversible. Whereas in SLE and other connective tissue disorders, there is non-erosive arthritis and there is similar deformities because of lax ligaments. There it is reversible. So these differences also you should know. So what is the diagnosis? It's definitely rheumatoid arthritis because the DIP is also spared. In osteoarthritis, both your DIP and PIP are involved. In psoriatic arthritis, DIP is more specifically involved and PIP is spared. In ankylosing spondylitis, it's most of axial involvement than appendicular skeletal involvement. And these are seronegative spondyloarthrosis. So coming to the clinical features, yeah, this is what we have discussed: swan neck appearance and botanist deformity. So the thing with rheumatoid arthritis is the articular presentation. The articular presentation of rheumatoid arthritis is a typical bilateral, symmetrical, small joint polyarthritis. Small joint erosive polyarthritis. which is chronic. So this is a typical articular presentation of a rheumatoid arthritis. Coming to the extra-articular manifestations. So this is something just strike it off. It's not extra-articular manifestations of rheumatoid arthritis. The most important extra-articular manifestation is the rheumatoid nodules. You can see in this picture. In this particular picture, you can see rheumatoid nodules on the extensor surface of your wrist and elbow. That's the most common. And coming to the extra-articular manifestations, other causes, your keratoconjunctivitis sicca. The most common cause of secondary sicca is rheumatoid arthritis. And patient can also have episcleritis and scleritis, but not uveitis. So in rheumatoid arthritis, there is no uveitis, just scleritis, episcleritis and keratoconjunctivitis sicca. That's it. In oral also, you can have sicca symptoms. And I told you the peripheral joints are involved. But if axial skeleton is involved, the most common joint is atlantoaxial joint. And resulting in cervical myelopathy. And the most common hematological abnormality is anemia of chronic disease. And it is prone for malignancy, that is large granular leukemia. Large granular lymphocytic leukemia. What is Feltis syndrome? The active rheumatoid arthritis with rheumatoid nodules and massive splenomegaly with hypersplenism, that is Feltis syndrome. So those are the manifestations of rheumatoid arthritis. And what is the treatment? We'll start DMARDs. DMARDs are the drug of choice. DMARDs are disease modifying anti-rheumatoid arthritis agents. But DMARDs will take some time. For suppose the most commonly used DMARD is methotrexate. Today I have started methotrexate, but to start its action, it will take 2 to 4 weeks. To bridge that period, initially I'll give steroids. So I'll start with methotrexate and steroids. After 2 to 4 weeks, I'll taper the steroids and continue the methotrexate. So steroids will give me immediate benefit. DMARDs, the action will take some time. So we'll start with both. And you have to monitor the disease activity index. If still it's not controlled, you will be going for 2 drugs. Still not controlled, we'll be going for biological agents. Next question, which of the following features not useful to distinguish microscopic polyangiitis versus granulomatosis with polyangiitis? See, the small vessel vasculitis, between these three things, the differences are very important. So he is asking GPA and MPA. So GPA is nothing but your vaginous granulomatosis. The name has changed, granulomatosis with polyangiitis. Whereas MPA is microscopic polyangiitis. These are ANCA-mediated small vessel vasculitis. Okay, so coming to GPA, see what is the triad? This GPA, MPA and EPA, eosinophilic granulomatosis polyangiitis, all these are pulmorenal syndromes. So both your lung and kidney are involved. Coming to lung, in GPA, both your upper respiratory tract, okay, let's write it in the next page. We'll include EGPA also. We'll write here. GPA, MPA and eosinophilic granulomatous polyangiitis. It's also called as Schreck-Strauss vasculitis. These three are ANCA-mediated small vessel vasculitis. Now these three are pulmorenal syndromes. In respiratory tract, upper respiratory tract is involved in. It's involved in GPA and EGPA. In GPA, the upper respiratory tract, there will be multiple abscesses, cavities and recurrent infections of the sinuses. Whereas EGPA, there are polyps. So EGPA is more like allergic. And in LRTI, sorry, in lower respiratory tract, in GPA and MPA, there will be multiple nodules and diffuse alveolar hemorrhages. Whereas in EGPA, it's like asthma presentation with eosinophilia. Next, coming to renal. Yes, all these things can cause rapidly progressive glomerulonephritis. And other organ involvements are almost similar. The only upper respiratory tract is not involved in microscopic polyangiitis. And one more differential is your ANCA. In GPA, it's predominantly C ANCA. In MPA and EGPA, it's predominantly P ANCA. And one more important thing is granuloma. See, the name itself says granulomatous polyangiitis, eosinophilic granulomatous polyangiitis. So, granulomas are present in GPA and EGPA but not in microscopic polyangiitis. These are the basic differences. So, I told you the presentations. These are the difference in presentations of these diseases. So, he's asking which is not useful to distinguish. Upper airway involvement present in GPA, absent in MPA, so it's useful to distinguish. Granuloma is present in GPA, absent in MPA, useful to distinguish. Pulmonary nodules are present in both. Necrotizing vasculitis is present in both. So, pulmonary nodules and necrotizing vasculitis are not useful to differentiate microscopic polyangiitis versus granulomatosis with polyangiitis. But the pulmonary nodules are more in GPA. So, the first answer will be D followed by C. So, this is granulomatous polyangiitis or vaginous granulomatosis, in which the upper airway involvement, there will be multiple infections and scarring of the upper airway. See here there is subglottic stenosis. Here there is diffuse alveolar hemorrhage and bilateral lung nodules. Here there is diffuse alveolar hemorrhage. And in skin there is purpura. That is the skin manifestation. See, coming to C ANCA, it is cytoplasmic staining. P ANCA is perinuclear staining. So, if you can observe here there is cytoplasmic staining. Here just the perinuclear part is stained. Here the whole of the cytoplasm is stained. So, that is C ANCA and P ANCA. In C ANCA, myeloperoxidase, it's antibody against myeloperoxidase. I'm extremely sorry. P ANCA is against myeloperoxidase. C ANCA is against proteinase 3. How do you differentiate? P is not for P. That is how you can remember. So, P ANCA, antibodies against myeloperoxidase. C ANCA, antibodies against proteinase 3. And C ANCA is predominantly positive in, look at my statement, it's predominantly positive in GPA. P ANCA is predominantly positive in MPA and EGPA. See, if I take GPA, granulomatosis polyangiitis, C ANCA, P ANCA both are positive. C ANCA is predominantly positive. So, if the examiner says C ANCA is predominantly positive, true statement. Both C ANCA and P ANCA positive, true statement. Predominantly P ANCA in GPA, false statement. So, I think you got this difference. You should be more specific. Next question. Elderly woman presents with headache, jaw pain with stiffness and pain in her shoulders and hip. ESR is elevated. What is the next best step? See, elderly woman having headache and pain in the jaw, stiffness in the girdle muscles. What do you think of? Definitely you should not forget temporal arteritis. headache with jaw claudication, and polymyalgia rheumatica. Polymyalgia rheumatica. So ESR is also elevated. What's the first step you do here? We'll be starting steroids. They're asking this multiple times because some of the students will opt for temporal artery biopsy. That is what they want you to go wrong. First start steroids and then go for biopsy. And biopsy take at least 1 centimeter, 2 to 3 centimeter length. Because this is a patchy disease, you may miss it. That's it. You no need to do angio of the arteries, and you can start NSAIDs for headache, but here it's temporal arteritis. Treat the cause. We'll start the steroids. If it's non-specific headache without any cause, we can start NSAIDs. If we think migraine, we can start sumatriptan. But no, here steroids, starting of steroids is very important because these patients can have ophthalmic artery involvement and irreversible blindness. Why steroids? To prevent irreversible blindness. Start steroids, take biopsy, confirm it, continue steroids, and you taper it. See, this is a thickened and beadened temporal artery which you can palpate also. Thickened, tender, beaded temporal artery. With jaw claudication. It's a typical presentation, especially in an elderly woman. So, rheumatology is all about understanding the presentation of the disease and which antibodies are positive. What test you will do? For suppose in vasculitis, you will take a biopsy or angio. It will differ for different vasculitis. The presentations also will differ. Those things you should know, then you can answer most of the questions in the exam. Next question. 38-year-old female complains of dysphagia. She's having pallor, chylonychia, angular cheilitis, atrophic glossitis. Barium swallow is showing esophageal webs. So basically, esophageal web is there resulting in dysphagia, and she's having all iron deficiency symptoms along with anemia. So what is this triad? Iron deficiency, anemia with cheilitis, with dysphagia, that is esophageal web. What is that syndrome called? It's Plummer-Wilson syndrome or Patterson-Kelly syndrome. So it's a triad of dysphagia. Why there is dysphagia? Because there is esophageal web, and that esophageal is upper esophageal web. Patient is having anemia because of iron deficiency and other iron deficiency symptoms like angular cheilitis and glossitis. And this is pre-malignant. This web is pre-malignant. It can develop into squamous cell carcinoma of upper esophagus or pharynx. How can you treat if that web is symptomatic? Excision of that web and iron supplementation. That is the treatment of this Plummer-Wilson syndrome or Patterson-Kelly syndrome. So Plummer-Wilson syndrome is also called as siderosphenic dysphagia. If he has given other name, we should not be confused. So even if you don't know this, you can exclude other options. In achalasia cardia, diffuse esophageal spasm, eosinophilic esophagitis, you don't have this esophageal web, atrophic glossitis, anemia, right? You can exclude and still get to the answer. In exam, see, you will be learning most of the portion. Some are direct questions. Don't make silly mistakes in direct questions. Some are indirect questions. Try to derive those things from the knowledge you have. You cannot read every line of Harrison or every line of Bailey and Love. You should know the basics, derive the higher things from that. So in exam, there is nothing like tough or easy. It's like known or unknown. If you know that topic, direct question you can attempt. Indirect question you can derive. If you don't know, you cannot do it. Okay, let's take up the next question. Which of the following statement is true about Mallory-Weiss tear? It presents with hemoptysis, yes, but not that much severe. And it's usually self-limiting, doesn't need any treatment. It shows transmural rupture. No, it is just a superficial mucosa-submucosa rupture of the squamocolumnar junction or the lower part of the esophagus. It can present with chest pain or shortness of breath. No, only if it's transmural rupture, the patient will have pneumomediastinitis resulting in this chest pain and shortness of breath. It shows mucosal tear. Yes. See, we have not observed. It will present with hematemesis, not hemoptysis. Hemoptysis is blood in the sputum. Hematemesis is blood in the vomiting. So this is also false. See, hemo, we are just concentrating on hemo. So that is why concentration is very important. You should read every word, every line very keenly in the exam. So it's just a mucosal tear. How do you differentiate Mallory-Weiss versus Bohr-Haave syndrome? Because both are rupture of esophageum, right? Mallory-Weiss tear is just a superficial. See, if you look at this picture, it's just a superficial. Only the mucosa and submucosa have been teared. So patient will have hematemesis, which is just self-limiting. Whereas Bohr-Haave syndrome, it is transmural rupture resulting in massive hemoptysis and the patient will land into pneumomediastinitis. And the Mallory-Weiss tear, it is squamocolumnar junction of the lower esophagus, whereas Bohr-Haave syndrome, it is a little upper in the lower esophagus. Next question. How to differentiate IBS versus organic GI disease? IBS is irritable bowel syndrome. It's just a psychological. Organic GI diseases, there is some pathology in the GIT. See, diarrhea is seen in both IBS and organic disease. Pain abdomen is seen in both. Mucus in the stool seen in both. But stool calprotectin, if calprotectin and lactoferrin are positive in the stools, it indicates that there is some inflammatory cell in the bowel wall, because the source for this calprotectin and lactoferrin are the inflammatory cells. For suppose the mucosa of the intestine is inflamed, the inflammatory cells will release calprotectin and lactoferrin, that will be positive in the stools. So this is positive, means some inflammation is going on. I cannot say whether it's infectious or non-infectious, but definitely inflammatory process is going on and something is organic there. So stool calprotectin is the differentiating factor. Coming to your IBS, irritable bowel syndrome, your Rome 4 criteria. This is very important. So patient will have pain abdomen. That is the essential criteria. How should be the pain abdomen? It is at least 1 day per 1 week. In the last 3 weeks. In the last 3 weeks, she had pain at least 1 day per 1 week and any 2 out of 3. It is related to defecation. It is associated with change in consistency of stools. And change in frequency of stools. So this is Rome code 4 criteria for IBS. What is the treatment of irritable bowel syndrome? First thing is she has to avoid FODMAP diet. Fermentable oligomosaccharides and polyols. Fermentable oligodimonosaccharides and polyols, that is FODMAP diet. Avoid. In celiac disease, avoid bro food, barley, rye, oats and wheat, not rice. Here avoid FODMAP diet. And for diarrhea predominant, we can give anti-motility drugs, and for constipation, we can give laxatives. Just symptomatic management. Next, coming to cystic fibrosis. What is false about cystic fibrosis? It is a autosomal recessive disorder. Yes. It is cystic fibrosis transmembrane conductance receptor gene mutation. Yes. Patient has a predisposition to Pseudomonas pulmonary infection. Yes. Fertility is 100% affected. Why it's not affected? So coming to cystic fibrosis, it is a autosomal recessive disorder involving this gene. This gene is basically guarding a chloride channel, and this is affected in the respiratory system, GI system, and in your reproductive system. So respiratory tract, GI tract and genitourinary tract. In respiratory, there are both upper respiratory and lower respiratory recurrent infections. That too Pseudomonas predominant. In GIT, the patient can have GI bleeds, intestinal obstructions, especially if young, they can present with intersusceptions. It can also affect the pancreas. First, the exocrine function is lost. Enzymes won't work. Then the endocrine function is lost. So because the exocrine function is lost, the patient will present with steatorrhea, fat malabsorption. And endocrine patient will present with type 1 diabetes. And this is late. Coming to genitourinary tract, there is absent vas difference or decreased motility of sperms. Azoospermia is also there. So infertility is definitely there. So this is about cystic fibrosis. Next question. Which of the following is the most common pancreatic endocrine neoplasm? See, just before this, we have discussed that in men 1, there is neuroendocrine tumor of pancreas. The most common is carcinoma. But without men, the most common pancreatic neuroendocrine tumor is insulinoma. Excess insulin, so increased C-peptide, the patient will have recurrent hypoglycemias. That is called Whipple's triad. Patient will have hypoglycemia. Once you correct the sugars, the symptoms will decrease. That is because the patient is taking recurrent sugars, there will be obesity. That is the triad. Increased weight, symptoms and signs of hypoglycemia, and that will be corrected after giving sugars. Corrected after dextrose. So that is the typical triad of insulinoma. Next, coming to hepatology. MRP2 transporter dysfunction is associated with? It's associated with Dubin-Johnson syndrome. Whereas in Rotas syndrome, it is due to OATP 1 or 3 enzyme deficiency. That's not an enzyme, it's a transporter deficiency. So Dubin-Johnson is a congenital direct hyperbilirubinemia. And one more example for that is Rotas syndrome. The targets you should know: MRP2 for Dubin-Johnson, OATP 1 or 3 for Rotas syndrome. So I have done hepatology and GIT in a great detail in the previous PYQ video. You can watch that if you feel you are still deficient in GIT and hepatology. True about King's College criteria for acute fulminant liver failure. See, whenever there is acute fulminant liver failure, to know the prognosis, there is one criteria, that is King's College criteria. In that, for paracetamol poisoning, there is one criteria, and for non-paracetamol induced acute fulminant liver failure, there is one criteria. We'll see it. So for paracetamol or acetaminophen induced acute fulminant liver failure, the poor prognostic things are acidosis, pH less than 7.3, patient is having coagulopathy, that is INR more than 6.5, or there is hepatic encephalopathy, which is grade 3, grade 4, and serum creatinine is more than 3.4. Coming to non-acetaminophen related, prothrombin time more than 100, so it's coagulopathy. If there is viral hepatitis or drug-induced hepatitis, more poor prognosis. And from jaundice to encephalopathy, there is time more than 7 days, it's poor prognostic. Very less age, less than 10 years or more than 40 years, more age is poor prognostic. And very high bilirubin, that is more than 17.5, is poor prognostic. We are mostly concerned about paracetamol related, that is acidosis, coagulopathy, renal failure, and hepatic encephalopathy are poor prognostic. See, INR, yes. Bilirubin, yes. Jaundice is yes. Age is also there. But INR is not about 3.5. It's about 6.5. So this will be the false statement. They won't ask you in this much great detail. They can ask you what are the poor prognostic symptoms or signs. Next, a patient with a history of CLD now came with increasing abdominal distension and jaundice. Ascetic fluid analysis is showing the absolute neutrophil count is 760. What is the likely diagnosis? It is spontaneous bacterial peritonitis. It's nothing other than that. So what is spontaneous bacterial peritonitis? Previously, there was no intra-abdominal infection. Now, spontaneously in ascites, there are bacteria or neutrophils. That is spontaneous bacterial peritonitis. What is secondary bacterial peritonitis? Previously, there is some intra-abdominal locus of infection. From that, it has spread to this ascitic fluid. Then you can think it of secondary bacterial peritonitis. So, SBP, only one thing, ANC more than 500. That is enough. Of course, cultures are positive. Culture is positive or negative, you don't mind. ANC is more than 500, you treat it as SBP. And how do you treat? You give antibiotics. Most commonly, we'll be using cefotaxime. 2 grams per day for 14 days. And for prevention, once the patient had SPP, there are increased chances of SPP in the future. So until there is ascites, you have to give prophylaxis with fluoroquinolones. So diagnosis, ANC. Treatment, antibiotics. That's it. Very simple. SBP. Next question. A chronic alcoholic male, okay, same CLD case with abdominal distension. So now if you see, this abdominal distension is refractory. When do you say it is refractory ascites? When you have advised the salt restriction and you have given maximum dose of dual diuretics. It's not responding, then that is called refractory ascites. So salt restriction plus you have given dual, that is furosemide, almost 160 mg per day he is taking. Spironolactone, he is taking 400 mg per day. This is the maximum doses. Even with this, it's not responding, means then that is refractory ascites. And what are you going to do for refractory ascites? You will give IV albumin and go for therapeutic ascitic tap. But here, along with refractory ascites, whenever a patient is having refractory ascites, the first thing you have to consider is hepatorenal syndrome type 2. That is most commonly presenting as refractory ascites. Here, the patient is also having decreased urinary output, pedal edema, his creatinine is raising. This is definitely type 2 HRS. And here, the best line of management is you have to give some vasoconstrictors octreotide plus albumin. Yes, you can do ascitic tap, but that is just symptomatic. You will give furosemide, but this is already refractory. You will increase the dose. You cannot increase the dose of furosemide, and we are not giving steroids here. So octreotide plus albumin is the best treatment. If octreotide is not available, you can also give terlipressin. So this is hepatorenal syndrome. We are discussing is hepatorenal syndrome. So coming to hepatorenal syndrome, it's type 1 or type 2. Type 1, the presentation is very massive presentation, very explosive presentation. Like it's precipitating. After an infection or a drug, it will precipitate. And it is rapidly progressive. See, the lifespan of the patient is not more than 2 weeks. He won't make it more than 2 weeks. Whereas type 2 hepatorenal syndrome, it will present as diuretic resistant ascites or refractory ascites. It is slowly progressive. Here also I cannot say he'll live for years. He won't make it more than 6 months. It's a little bit better prognosis, that's it. I cannot say best. Next question. A patient came with fever, jaundice, malaise. So probably it's some infectious disease. And they have done the serology. The serology is showing IgM is positive. HBsAg is positive. So it's definitely acute. Acute hepatitis. Even your anti-HBs are negative, that is supporting this. Your anti-HCV antibodies are also positive. So you have also ruled out HCV, hepatitis C virus. So this is acute hepatitis B. So this is the serology of hepatitis. This is the serology of acute hepatitis, normal Crohn's. This is the serology of chronic hepatitis. So in acute hepatitis, within 6 months, your HBsAg will fall, your anti-HBs will raise, your IgM, anti-HPC IgM will fall, and IgG will increase. So after 6 months, the only thing present is your anti-HPS, anti-HPC IgG and anti-HPS. This is present for lifelong, whereas this is present for 10 to 15 years. This is the normal course. So in this patient, HBsAg was positive, IgM was positive, so this is acute hepatitis. This is acute hepatitis phase, this is recovery phase. Coming to chronic hepatitis phase, after 6 months also, your HBsAg is positive, then that is chronic hepatitis. How do you know it's present after 6 months? Because after 6 months, your anti-HPC IgG will be present. So along with G, HBsAg is present means it's chronic hepatitis. Along with G, your anti-HPS is present means it's recovery. This serology is very important. Just remember these two graphs. Next question. Type 1 diabetes with hyperpigmentation of the skin, hypogonadism, and elevated liver enzyme. So basically, along with liver, hepatitis, this patient is having hyperpigmentation of the skin and diabetes, bronze diabetes. He's having hypogonadism. What do you think is the diagnosis? In alpha-1 antitrypsin deficiency, there will be COPD or emphysematous changes in the lung, and there is liver failure. It's not looking like that. In Wilson's disease is predominantly hepatolenticular. Along with CLD, there will be brain involvement. This is the typical presentation of hemochromatosis, whereas glycogen storage disorders, very early childhood only patient will have mental retardation, hepatosplenomegaly, and organ failures. So this is a typical presentation of hemochromatosis, which is a autosomal recessive disorder, which is mutation in HFE gene. Ultimately, patient will have iron overload. That iron will be deposited in the liver failure, heart, cardiac failure, in the pituitary gland, hypogonadism, in the testes also resulting in hypogonadism, in the pancreas, diabetes, and in the skin along with melanin, bronze discoloration of the skin. How do I treat? I will be doing phlebotomy, remove some blood, iron also will be removed. If the patient is hemodynamically unstable, I will give iron chelators. We already know what are the iron chelators. Very simple. Answer is hemochromatosis. So this is a bronze discoloration. And in heart failure, especially cardiac involvement, they will be having dilated cardiomyopathy. And in pancreas, type 1 diabetes mellitus. And pituitary involvement resulting in hypogonadism. Next question falls about the image given below. Just observe. There is some golden deposit, golden brown deposit here. Yeah, right, golden brown deposit. That is called KF ring, case of Lister ring. And we are looking it in the slit lamp. In the slit lamp, we are looking for that. This KF ring is pathognomic for Wilson's. Yes, it's true. It will first appear in the superior crescent, followed by lower crescent. Next, it will fill up. So this is false. He has given it first appearing in the lower crescent. It's seen in 95% of the cases of neurological Wilson's, yes, and in 40% of cases of liver or hepatic Wilson's. And on copper chelation, that will be disappearing. Yes, that is true. So these are the important things you should know about case of Lister ring. In other conditions which are causing hyperbilirubinemia, especially your obstructive jaundice and very high bilirubin, there can be KF ring. But there it's because of the deposition of bilirubin and it's slightly yellowish in color. That is called pseudo KF ring. Whereas this KF ring is a golden brown deposit due to deposition of copper in the Descemet's membrane, and this is pathognomic to only Wilson's. Okay. So every statement here is important. It's pathognomic to Wilson's. It's seen first in the superior crescent. It is seen in 95% cases of neurological Wilson's and 40% cases of hepatic Wilson's, and it will disappear on treatment. And it's because of the deposition of copper in Descemet's membrane. What is the gold standard investigation? You have to take the liver biopsy, quantify the copper. It should be more than 200 micrograms of copper per gram of dry liver tissue. What is the treatment? We have to give copper chelators, that is D-penicillamine, trientine. And zinc. Let's take up the next question. 37-year-old, okay, we are going to CNS now. 37-year-old woman came with headache. So basically she's having chronic headache, and for that headache she's using analgesics. Recently the headache intensity has increased. She has stopped the drug, then the headache has disappeared. So this is medication overuse headache. So how is tension headache? It's a bilateral headache which will be like a tight band around the head. It's due to stress. How is migraine? Migraine is unilateral pulsatile headache associated with photophobia, phonophobia, nausea, vomitings. How is cluster headache? Cluster headache is trigeminal autonomic cephalalgias. So in the trigeminal supply, that is V1 area, patient will have headache or facial pain associated with autonomic symptoms, that is rhinorrhea, congestion of the eyes. It's trigeminal autonomic cephalalgias. So in the trigeminal region, patient will have cephalalgia, head pain, headache, and autonomic symptoms, that is cluster headache. So this is medication overuse headache. How do you differentiate? See, tension type headaches are usually seen in middle-aged, young to middle-aged. Migraine is seen in young age. Cluster headache is also seen in young age. Coming to the gender predisposition, tension type headache is seen in both males and females. Migraine is most prominent in females and cluster headache is most prominent in males. Coming to family history, in tension type headache there is no history. In migraine it could be there, in cluster headache it's absent. Coming to location of tension type headache, it's bilateral band like. Migraine is unilateral pulsatile. And coming to cluster headache, it's unilateral headache associated with autonomic symptoms. And coming to duration of tension type and migraine headache, tension headache is definitely more than 4 hours. Migraine can last from 4 to 72 hours, but your cluster headache is a short lasting headache, less than 4 hours. Like your headache will be lasting from 10 minutes to 30 minutes, and there are multiple episodes, like 2 to 3 episodes per day. And the quality of pain, it's almost similar. And in migraine, it's pulsatile headache. Coming to severity, your cluster headache is very severe. Your migraine is next severity, and your tension is not that much severe headache. Coming to associated symptoms, in migraine, you will be having photophobia, phonophobia, vomiting, nausea, aura will be there. And in cluster headache, autonomic symptoms are there, like rhinorrhea, conjunctival congestion. How do I treat tension headache? Just give a NSAID. How do I treat migraine? See, I can give NSAIDs, but that is non-specific therapy. For specific therapy, I can give triptans. That is for acute management, and for prevention, I can give tricyclic antidepressants and beta blockers. Coming to cluster headache, for acute treatment, oxygen inhalation is the treatment of choice. Whereas for prevention, you can give verapamil. So this is how you are going to differentiate these 3 headings in the exam based on these key points. Next question. A young lady with history of fever since 1 month presents with headache and ataxia. Brain imaging is showing dilated ventricles and significant basal exudates. See, fever, chronic fever with hydrocephalus, basal exudates. What is the first thing that should come to your mind is TB meningitis. So TB meningitis, which is forming basal exudates, that basal exudates is obstructing the flow of CSF, resulting in obstructive hydrocephalus. Obstructive or non-communicating hydrocephalus. And what is the feature of CSF in TB meningitis? Initially it's clear, but if you keep it for long standing, there is a web formation. What happens to the glucose? Glucose is low, so remove this normal glucose. What happens to the protein? Protein is high. Next, what happens to the neutrophils and lymphocytes? Neutrophils are normal sometimes, but initially there can be neutrophilia, but predominantly there is lymphocytosis. So this is the answer. See, by reading multiple things, don't get confused. Whatever is not there, just exclude it. So the remaining options, it will be easy for you to select. Coming to the treatment, based on the sensitivity, if it's sensitive to the first line drugs, we'll give drug sensitive TB only. It's for 6 months only. Whatever is the type, whatever is the site, it's 6 months only. Now it has been changed. Previously it used to be 6 months, 12 months per different sites, but now whatever is the site, we'll give for 6 months only. But if there is no resolution, we have to prolong it, and CNS TB, most of the times we'll be prolonging the treatment. Yeah, see, this is the typical hydrocephalus, bilateral hydrocephalus. The basal sections are not given here. If we go into the basal sections, we can see the exudates. Loss of pain and temperature on the ipsilateral face. Ipsilateral face, due to involvement of the trigeminal nerve, there is loss of pain and sensation. And contralateral body. So spinothalamic is involved on the opposite side. It's due to thrombosis in. See, ipsilateral face plus contralateral body, pain and temperature are lost. It's nothing but your lateral medullary syndrome. The questions has been asked differently in different exams. It's due to the thrombosis of pica. If vertebral artery is given, that would be the best option. Posterior inferior cerebellar artery. So what are the structures present in the lateral medulla? The structures present are your fifth nerve, spinal nucleus. So there is ipsilateral pain and temperature loss. Next comes your vestibular nucleus. So patient can have ataxia or vertigo. Next are your sensory nucleuses like 9, 10, 11. So patient will be having dysphagia and dysphonia. These are the cranial nerves which can be affected. And one more thing is, there is nucleus tractus solitarius which will supply the taste. So loss of ipsilateral taste. So everything is ipsilateral. Next, what are the other things? There is spinothalamic tract. So contralateral pain temperature on the body is lost. Next, sympathetic chain. So there is ipsilateral Horner syndrome. Next, there is spinocerebellar tract resulting in ataxia, ipsilateral ataxia. These are the things the patient can present with. So ipsilateral pain and temperature loss and contralateral. So ipsilateral pain and temperature loss on the face and contralateral pain and temperature loss on the body is seen in lateral medullary syndrome, and this part is being supplied by your vertebral artery more than your posterior inferior cerebellar artery. This posterior inferior cerebellar artery is also a branch of vertebral artery. So very simple. If you remember the structures, it's very easy. What are the cranial nerves involved? What are the long tracts involved? Next, a young postpartum female came with seizures. They have diagnosed correctly and they went for CT brain with venogram. They have started the patient on warfarin, but she developed a necrotic skin lesions. What is the diagnosis? So basically, postpartum female presented with seizures. So they suspected CSVT, cerebral sinus venous thrombosis. So they have done a contrast or CT venogram. In CT venogram, there is an empty delta sign. And a large venous hemorrhagic infarct. That is why patient had seizures. So because there is a thrombus in the cerebral venous sinus, they have started on anticoagulant warfarin, but they have directly started warfarin. What's the problem here? Always heparin should be bridged with warfarin. warfarin should not be started directly because warfarin will act on vitamin K dependent coagulation factors, that is 2, 7, 9, 10, and protein C, protein S. So the half-life of protein C and S are very low. So the protein C and S will be depleted first, resulting in they are anticoagulant. So they are depleted, resulting in coagulation or thrombus formation. So initially there is formation of thrombus. If the thrombosis is in the skin veins or cutaneous vessels, there will be skin necrosis. So they should have bridged heparin with warfarin. So at least first 2 to 3 days of warfarin should be bridged with heparin. After that you can continue the warfarin alone, because after that these are also inhibited. So this is the typical warfarin related skin necrosis if you give that alone. Next question is Beaver sign. What is Beaver sign? First you should know what is Beaver sign. So normally this is the position of the umbilicus. So suppose he is doing some squats. No, he is doing abs. He has contracted his upper abdomen and the umbilicus is moving upwards. See, the umbilicus is here. Here are the upper abdominal muscles and here are the lower abdominal muscles. Both will contract equally and the umbilicus should stay there itself. For suppose if there is lower abdominal muscle weakness, when you do such exercise or such movement, your umbilicus will move upwards because this will be predominating and this is not acting. So when you have contracted your upper abdomen, the umbilicus is moving upwards, that is called Beaver sign, and that indicates that there is a lesion at the T10 level of your spinal cord. Below T10 everything is gone, so lower abdominal muscles are gone, resulting in the umbilicus moving upwards. So if there is Beaver sign, you can directly localize the lesion to spinal cord, that to T10. So that is thoracic spinal cord pathology. So now we are done with the core systems. The important topics which have been missed or less detailedly covered in the previous PYQs, I have dealt with them. And if you want detail of each system, you can go to the previous PYQs. I have dealt each system with detail. Whatever has been missed, I have covered now. Next, let's take up the toxicology in brief. So a patient has come with beta blocker poisoning. So beta blocker is an antihypertensive. He has taken almost 30 tablets. What is the antidote he is asking? It is glucagon. Flumazenil is the antidote for benzodiazepines. Atropine is the antidote for OP poisoning. Naloxone is the antidote for opioid poisoning. One second. Calcium gluconate is antidote for calcium channel blocker poisoning. Glucagon is an antidote for beta blocker poisoning. Your N-acetylcysteine is an antidote for paracetamol poisoning. Next, your vitamin K is an antidote for warfarin poisoning. Protamine sulfate is an antidote for heparin excess. Idarucizumab is an antidote for your dabigatran. Penicillamine is an antidote or chelator for copper poisoning. We'll be using it in Wilson's disease. So these are the important antidotes you should know in medicine, because one question from antidote is for sure. And coming to your charcoal, activated charcoal, it is an universal antidote. You can use it for any poisoning. It will just decrease the absorption of the drug or poisoning from the gastric mucosa. So here it's glucagon. And one more, fomepizole is an antidote for methyl alcohol. Methyl alcohol poisoning. Okay, next question. A child has consumed 10 to 20 iron tablets. So now there will be iron overload. How do you treat it? Deferoxamine. It's an antidote or chelator of iron. Penicillamine is the chelator of copper. Dimercaprol is the chelator of lead, mercury, arsenic. Whereas your activated charcoal is a universal antidote. So let's look at this quick case. A farmer has consumed an unknown poisoning. Now look at the presentations. He is having bilateral pinpoint pupils. So whenever in a poisoning case you look at bilateral pinpoint pupils, two things should strike your mind. One thing is OP poisoning and other thing is opioid poisoning. Other than poisoning, even if you're pontine hemorrhages, you will be having pinpoint pupils. So these are the things you should think of in EMD. So this is a poisoning case with pinpoint pupils, either opioid poisoning or OP poisoning. He is profusely sweating with bradycardia, with wet lungs. Mostly it is, not mostly, it is OP poisoning, organophosphorus poisoning. So this patient is having cholinergic side effect because organophosphorus compounds are anticholinesterase inhibitors. So they will be having cholinergic side effects or cholinergic effects. What treatment you should give? Anticholinergic, that is atropine. See, I can give gastric lavage, it's an universal antidote. Atropine followed by pralidoxin, yes. Naloxone and naltrexone is for opioid. And you can give IV fluids because the patient is profusely sweating and he can go into hypotension. So atropine is anticholinergic and this pralidoxim will release the anticholinesterase enzyme from OP compound. So it will free the anticholinesterase enzyme, oximes. And what I should monitor, the ultimate thing is I will monitor the lungs. The lungs should be clear. They should be dry, no crypts. That is my ultimate goal of atropinization. Yes, I'll monitor the pupils. The pupils should be dilated. Yes, there should be some tachycardia and the lungs should be dry. But this is my main goal. Next, coming to snake poisoning. Unknown snake bite with bilateral ptosis. So you think this is neurotoxic or hematotoxic? Hematotoxic are viper. Neurotoxic are your cobra and common curate. So this presenting with ptosis, the neurotoxic of the snake bite is descending weakness. So first patient will have ptosis, dysphagia, dysphonia, then limb weakness. So this is descending weakness. And first you have to look for ptosis. If you miss the ptosis, after that patient will have dysphagia, dysphonia, respiratory muscle involvement and he will die. So monitor for ptosis. Descending paralysis, and ptosis is the first manifestation. You have to observe that. So this is neurotoxic. It can be curate or cobra. So what is the next step? They have given ASV. So even after giving ASV, at least 50% of the ptosis should improve. It did not improve. So next we have to give neostigmine plus atropine. So why am I giving atropine? Because neostigmine acts on both muscarinic and nicotinic receptors. but the snake poisoning is acting only on the nicotinic receptor and I want to antagonize that. For that, I am giving neostigmine. But there are also muscarinic receptor antagonizing signs. I don't want that. So to prevent muscarinic antagonizing signs, I will be giving atropine. Sorry, to prevent muscarinic stimulating signs. To prevent muscarinic receptor signs and symptoms, I am giving atropine. Atropine will only block muscarinic, not nicotinic. So even in OP poisoning, you are giving atropine that will block only muscarinic receptor effects, not nicotinic. And this neostigmine will work on the nicotinic receptor, will activate that. If it is a hematotoxic bite, FFPs will be useful. You don't have to find the snake. It's neurotoxic, just treat it. Even after giving neostigmine and atropine, it's not responding, you can go for calcium gluconate because mostly the crate bites won't be responding for neostigmine and atropine. You have to give calcium gluconate for that. Cobra bites will respond for neostigmine plus atropine. Yeah, it's the same thing. Yeah, we are done with the session. So don't be disappointed that exam has been postponed. So the key for this game is persistence, consistency. You have reading since many months. Now if you are leaving it, everything will go in vain. So we don't want that to be happening. Just be consistent. Whatever you have read, read again, do one more revision. And you have been through that exam tension, right? Just before exam you went through that, so you know what are the lacunae you will be having. So now try to cover those lacunae and don't read new topics, new sources. No, whatever books you have read, just revise them. And this PYQs will definitely help you in concentrating on the high yielding topics and points. So they won't repeat the question, it's true, but they will definitely repeat the topics. So you should be knowing everything about that detailed topic. So this session would definitely help you. So whatever is not covered in this, I have covered in the previous PYQ questions, and in core 6 revision also, we have covered almost all of the medicine and which parts to concentrate. You can go through those sessions also. But thank you. All the best for your exam.